day is brilliantly executed along with my team. And also, we will ensure that the entire day, as I mentioned earlier, will be very energetic and also very interactive. So, that is something that we'll try to do. Once again, everybody who is outside, if you can hear us at this point, we will invite all of you to also please start stepping in, take our seats. If you're still having your breakfast, feel free to gather your plates and be inside here. You see, because the day that we're about to spend together, ladies and gentlemen, we promise you will truly be a reshaping day for the heart health. Uh, as this entire day has been planned very meticulously, we have ensured that almost every topic under the cardiac therapeutics is very well covered and questioned to the T today. We will be having a fantastic set of chairpersons, panelists, and of course the speakers who will take you through this entire day. And of course, after every session, we will also have a small one where you will also get an opportunity to win something exciting based on some quizzes. So much is lined up. And once again, everybody outside, since you can hear us, we'll invite you to please start stepping in. And it is my duty to thank and invite each one of you once again to the Innovations in Cardiac Therapeutics 2025. If I can interest each one of you to give in a round of applause to this wonderful day that we are all going to be celebrating, and of course, knowledge sharing together in this room, which is filled with extremely high and extremely learned people. Ladies and gentlemen, we also, before we start, would like to thank Fortis Hospital Shalimar Bagh for bringing this entire session to life in collaboration with Cardio Safe Foundation, which has been also further amplified nationally by Voice of Healthcare as their strategic partners. Now, today, ladies and gentlemen, what you see amongst yourself, who you see amongst yourself are clinicians who have ensured to save lives every day. We have innovators who have challenged everything that's possible. You will also find researchers along with you who push the boundaries of science furthermore. Policymakers who will ensure that we are able to turn ideas to actual realities. So it's a set of individuals that you will find around. So use this opportunity to network with them during the whole day. Ladies and gentlemen, as we go today, there are few topics that we are very clearly and in a very defined fashion will be tackling. For example, the interventional tools, which are becoming even more sharper, safer, and smarter. We'll talk about that. Electrophysiology, which is entering into a new era of precision. We will be speaking about that. Structural heart solutions, which are rewriting the old limitations. We will divulge even deeper into this. Digital health, AI, and remote monitoring, which are truly redefining the care beyond hospitals. We'll be talking about that. And of course, we'll be also briefly touching about policy and access and cost frameworks, which are deciding whether innovation actually reaches the patient's bedside. So that also will be dived into. So truly, this is going to be a land where vision will actually transform into action. And now that we are talking about vision, ladies and gentlemen, it is my pleasure to introduce you to our organizing chairman. Ladies and gentlemen, Dr. Nityanand Tripathi, who is the Principal Director and HOD for Cardiology and Electrophysiology at the Fortis Hospital, Shalimar Bagh. I wish to take this very short opportunity to bring your attention to this man of stature that we are also celebrating today and thanking him for bringing us all together on this single platform. Ladies and gentlemen, as being a pioneer, a mentor, and a relentless innovator, a leader who has redefined cardiac care across Delhi NCR and beyond, from complex interventional breakthroughs to advancement in electrophysiology, could be from building high performing cardiac teams to mentoring young clinicians, such as some of us across the country, from transforming clinical practices to championing patient centered innovation. Dr. Tripathi's journey is one of consistent excellence, fearless experimentation, and unwavering dedication. His vision is the reason that we have all gathered here today. More so, ladies and gentlemen, we have also put together a small film, though it cannot do any justice even to the minutest of his achievements. But we have tried our level best to put his unwavering dedication, to put his vision, to put a day of his life into this film. And we would really want, before I invite Dr. Tripathi to step up onto the stage, have a look at this film, and then we'll have him on stage. Can we please have the film?
Every day begins with purpose, with compassion, with the quiet responsibility of caring for hearts.
For Dr. Nityanand Tripathi, each morning starts with preparation because every heartbeat he cares for deserves complete attention.
Behind every successful physician is a team that shares the same commitment: skilled hands, sharp minds, and hearts aligned toward one goal: patient care. Leadership is not about standing ahead, it's about standing together. For Dr. Tripathi, care begins with collaboration, trust, and respect for every member of the team. He listens first, with empathy, with patience, with kindness. For his patients, it's not just treatment, it's trust. With decades of expertise, Dr. Tripathi blends precision with a deeply human approach to care. In the cath lab, teamwork matters. Decisions matter. And for Dr. Tripathi, every procedure is a promise to protect, to restore, to heal. His responsibilities extend far beyond the consultation room, guiding teams, ensuring continuity of care. Sometimes, healing is not just treatment, it is reassurance, presence, and compassion.
Our patient trust their life with us, and that is the most prestigious responsibility. And we try to give them the best care that they really deserve.
We can do a little louder, ladies and gentlemen. Come on, right in the morning, your energy has to be with us. It is our extreme pleasure and my personal honor now to invite Dr. Tripathi to please step up onto the stage and welcome this august gathering right here. Welcome, sir.
Thank you. Good morning, my seniors and colleagues. Today, I have honor to invite you all to this August gathering as we continue to learn from each other year after year. This year also gives an great opportunity to learn from one another. So I welcome you each and all, every faculty, every member, every delegate to this August gathering. And in fact, this has been possible by multiple team, and I welcome all the team also here. Without wasting time, I will like that we will start the session right now, and we will inaugurate the conference in between around the lunch time. So thank you so much for coming this morning, sparing the time for learning each other, and so that patient can get better out of us. And now I request to start the session. Thank you.
Come on, everyone. This is your cue to please give in a round of applause one more time. Thank you so much. Thank you, Dr. Tripathi, and also, sir, for keeping it extremely brief and crisp. So, you know that we will be talking business. So, let me not uh, indulge into more talks. Rather, straight away, we will get into the session. So, very briefly, to give you an idea what to expect in the day, we have about 9 sessions, and each session that will be planned today is, of course, on your agenda sheets as well, which is in your bag. You can refer to them. More or less, we are unfortunately behind schedule, but we'll try to catch up and bring us back online. So after every session, there are two interesting things as well, which are lined up for you, which will be your opportunity to win some interesting goodies. So we'll try to keep this light-hearted as well. Of course, ultimately, we are talking about heart, but scientific knowledge will be very carefully taken up today. And the first session that we are getting into is topic as the non-invasive assessment of the cardiac patient. And for this session, let me straight away get into inviting our session chairpersons. I'll invite you to, as I call your name, to please join us on the table. Dr. Sanjay Modi. Ladies and gentlemen, you have to give them a welcome. Given a slight round of applause, if you could, Dr. Kuldeep Kumar. I would invite both you fine gentlemen to please step up as the chairpersons on the chairperson desk. Come on, everybody. आपको थोड़ी सी तालियां तो साथ तो हमें देना पड़ेगा. Uh, I also invite our expert panelists for this session who hold deep knowledge on the relevant topic, starting by Dr. Abhishek Kumar. Welcome, sir. बहुत बहुत स्वागत है आपका. Miss Alka Tiwari and Dr. KD Tiwari. If I could invite both of you as well to please take your space on the panelist table. Welcome, sir. Welcome. बहुत बहुत स्वागत है आपका, sir. Please welcome in. Welcome, ma'am. Thank you so much. आइए, आइए, आइए. Thank you. If I could interest everybody to please welcome our panelist and chairperson, please, with a round of applause for this particular session. Now, in this session, the first presenter that I have the opportunity of inviting on stage, let me invite them, is Dr. Amit Gupta. If I can have Dr. Amit Gupta to please join us in on stage, who is an associate consultant cardiology for Fortis Hospital, Shalimar Bagh, sir.
Good morning, everyone. Myself, Dr. Amit Kumar Gupta, working as an associate consultant at Fortis Hospital, Shalimar Bagh. Firstly, I would like to congratulate Dr. Tripathi for organizing IICT 2025. Secondly, I would like everybody participate in the quiz. So, starting with the quiz straight away. Uh, Here is the first EG. A 70-year-old male present with dizziness and shortness of breath. What's the most likely diagnosis? Yes. Yes, you are right. Is it second degree AV block? No. Uh, It's a Mobitz type 2 second degree AV block because PR interval is constant, but some of the P waves are not conducted. And can you please tell me what's the treatment for this? Uh, the patient will be needing a pacemaker for this because it's for second degree AV block. Huh. Okay. Thank you, sir. Thank you. Coming to next question. Uh, a 56-year-old male present with sudden onset of chest pain and diaphoresis. Please see the ECG and tell what's the most likely diagnosis. Yeah, this is acute MI, but this type of MI? There is ST depression in lead V1, V2, V3. R wave is more in lead V2. Okay. Uh, so this is posterior wall MI, which is suggested by ST depression in lead V1, V2, V3. There is tall R wave and upright T wave. This is suggestive of posterior wall MI. In case of any confusion, we can take posterior leads V7, 8, 9, and ST elevation greater than 0.5 mm is suggestive of posterior wall MI. Now, coming to next question. There is a 42-year-old male presented with drug overdose. What's the most likely diagnosis? Yeah, this is VT. What type of VT? Anyone else from the audience? This is bidirectional VT. QRS amplitude, QRS is changing along the axis. This is bidirectional VT and it is due to digoxin overtoxicity. Coming to next question. Young male present with chest pain on arrival, but he is symptom free now. What is this ECG? Yeah, there are inverted T wave, deep symmetrical T waves in lead V1, V2 and V3. Is there any name sign for this ECG? Yes, this is anterolateral anterior wall ischemia. So this is Valence syndrome, which is characterized by deep symmetrical T wave inversion in lead V1 to V3, and this patient will most likely have LAD occlusion. So this patient must directly go to cath lab. Coming to next ECG. There is 56-year-old female presented with chest pain and diaphoresis. What is this ECG? This is also very specific ECG. There is ST elevation in lead 1, AVL and V2 and ST depression in lead 3 and AVF. This is high lateral wall STEMI caused due to the occlusion of first diagonal branch of LAD and ST elevation in lead 1, AVL and V2 and depression in lead 3 and AVF. This is also called as South African flag sign. Now coming to next ECG. 40-year-old chronic alcoholic present with complaint of syncope. What's the most likely diagnosis? Yeah, you are absolutely correct. This is torsades pointed point, which is characterized by twisting of QRS along the axis. And what's the most likely cause of this? This can be due to hypokalemia and long QT syndrome, which can cause torsades pointes. Now coming to next question.
Pointers, so that everybody of us can be more wiser. Why it is task it is pointers each time you are telling the diagnosis. Can you explain it with the pointers? Why are you saying so?
So there is twisting of QRS complex, which suggests this is Torsades. And this is this can convert into VT, can lead to sudden cardiac death, and this is caused due to hypokalemia, hypomagnesemia, and low QT syndromes. Sir, in leads 2, 3, V1.
No, can you tell us the specific point? Like beat after normal beat, third beat is down, and
Yes, sir.
last beat is up.
Can I have pointer?
I think pointer is not working.
No, it's
अच्छा, ठीक है. Continue.
okay. So coming to next ECG, a 70-year-old male with history of bone pains presents with this ECG. What's the most likely diagnosis? Yeah. And this patient must be suffering from which disease? Can you tell me this? Yes. And what might be the cause of hypercalcemia? He's 70-year-old. Yeah, bone cancer, prostate, any cancer that can metastasize to bone leading to hypercalcemia. The patient will present with short QT syndrome. Uh, a young male with quadriparesis shows up with this ECG. What's the most likely diagnosis? There is quadriparesis. Hypo? Yeah. The patient is suffering from hypokalemic periodic paralysis and the patient has QT is prolonged, which is due to hypokalemia. Now coming to last ECG. A 50-year-old male present with chest pain. What's the most likely diagnosis? It's a named sign characterized by LAD occlusion. Yes. Can you explain? Would you like to explain? Yeah, you are right. This sign was described by D. Winters in 1998. There is 1 to 3 mm ST depression with upright T wave, and it is present in 2% of the LED occlusion, and this is recognized as semi-equivalent. Uh, can you tell me what is this ECG? 85-year-old present with chest pain. Acute STEMI. Now all the ECGs are of MI, but what does this ECG show? Which vessel is blocked? Lateral one? No, no, no. There is ST depression in most of the leads and elevation in AVR and V1. Uh, no, no. This is in this patient, there is diffuse ST depression in multiple leads with elevation in AVR and V1. So this ECG is of diffuse. If this ECG is of left main disease or diffuse triple vessel disease. If the elevation in AVR is more than, it is suggestive of left main disease. If elevation is more in V1, then most likely osteal LAD will be involved, and this is called as AVR sign. Thank you.
Uh, if we have 2 minutes, if you have any question from the chairperson or any of the panelists, we'll wish to take that. Any question? सर एक मिनट आपका माइक शायद ऑफ हो गया.
Thank you.
Check, check.
Our next speaker is Dr. Dinesh.
Good morning. I'm Dr. Dinesh Pandey, working as Associate Consultant in the Department of Cardiology, Fortis Hospital. I am presenting the cardiac markers in the cardiology, basically, what's new. Please. Slide, please. Yeah, next. Previous one. Yeah, as per WHO, there is a huge mortality related with the cardiovascular diseases, and around 27% of the all the cardiovascular or the mortality constitute with the cardiac diseases. And there is diagnostic dilemma always in the ED when present with the chest pain, dyspnea, fatigue, which is cardiac sign of the CAD. And it's always a dilemma. There is this cardiac pain or someone else. There is musculoskeletal pain. There is other diseases, pulmonary diseases, or simply sometimes there is anxiety related to chest discomfort or fatigue may be present. So the diagnosis of CVD is the accuracy of and timely diagnosis needs for the crucial and effective management of the patient outcome. There is various diagnostic modality including ECG, echo, angiography, and cardiac MRI, cardiac CT, provides various structures, functional inside the for the CVD. But biomarkers have revolutionized the CVD diagnosis for the early diagnosis and accurate diagnosis for the myocardial injury and infarction. Uh, Acute coronary syndrome related to myocardial injury start with the plaque rupture, which is initially asymptomatic. Plaque rupture converted to coronary thrombus and followed by the total occlusion of the blood vessels. The symptoms start when there is total occlusion of the blood vessels, and which further progress to myocardial ischemia and myocardial necrosis. And this related to the chest pain and other things with the diaphoresis and other. There's venous pressure and other things leading to the cardiac failure, heart failure. The objectives of biomarkers is to diagnose the disease, risk stratification and screening, and monitoring and therapeutic guidance. There are various cardiac biomarkers which lead to for the diagnosis and management of the cardiac disease. There is various related to the neurohormones, vascular system, inflammatory markers, myocardial injury and myocardial stress markers, and many others. So accurate diagnosis and precise management, for the precise management, we have some good markers which can tell me early about the myocardial necrosis and myocardial stress. So there are myocardial injury biomarkers, CPKMB. Previously we used very frequently, but nowadays is less used. Cardiac troponins and cardiotroponins is more accurate currently, and early diagnosis is better. There is myocardial inflammation marker, CRP, Myocardial stress biomarker BNP, anti-pro-BNP, anti-pro-ANP, and myocardial fibrosis biomarkers are as ST2 and galactin-3. The other cardiac biomarkers are D-dimers, H5, and microRNA. MicroRNA are now the emerging biomarker for the cardiac patients, but in the investigational ways. The classical novel biomarkers in the mainly the cardiovascular disease, we use mainly the natriuretic peptides and troponins. Troponins are for the standard gold standard for the myocardial diagnosis, infarction diagnosis. And the natriuretic peptides activate, there's basically secreted by myocardial cells and activated by the activation of BNP genes converted to pre-pro-BNP, which again fragmented to pro-BNP and single peptide. These steps are within the myocardial cells, and this secrete to the general circulation in the form of anti-pro-BNP or BNP. BNP was active molecule and anti-pro-BNP was biologically inactive and more stable and stable in the blood flow. So measurement of anti-BNP is preferable over the BNP. BNP level are changing with the time and transport. There is clinical use of natriuretic with this important caveats as high body mass index decrease the BNP levels. Advancing age is increased. In females, is more than in the males. There is maybe biological variability and in vitro stability, which is anti-protein is more stable as compared to BNP. The optimal anti-pro-BNP cutoff points for acute CHF diagnosis so depends on the age of the patient. It's less than 50 years, 450 picograms per ml is normal. Whereas when the age increased more than 75 years, it's 1800 picogram. And if there is more than this value, then we consider in the criteria of heart failure. And if there is less than 300, simply we rule out the cardiac involvement of breathlessness as heart failure. And there is also the BMI dependent anti-pro-BNP levels. So as the BMI increase obesity, there is low value of anti-pro-BNP. And there is various other non-cardiac conditions which lead to increase in BNP levels instead of various cardiac conditions. These are renal disease, ischemic, and especially infection, sepsis. The acute decompensated heart failure national registry, DARE registry, shows the admission BNP value for the highest quartile more than 1730 versus BNP lowest is 430 is increased 2.23 fold increase in the hospital mortality after adjusting the LVEF level. The other registry optimized HF shows there is BNP is important predictor for 1 year mortality and for the around hazard ratio of 1.15. And other study, well-certain heart failure study, they show over 4 month increase in anti-protonally increased mortality of 1.7. Hazard ratio is 1.7. So anti-protonally is intensified in the guideline-based therapy for the diagnosis and management of the heart failure patient. The other myocardial infarction and myocardial stress, there is various biomarkers we use earlier days like CPKMB, SGA, TLDH, and troponin. Troponin is the indicative of myocardial used for ischemia. There is various trials and registry prove that it's early marker and is present is worse hospital mortality. And HS trop T is more sensitive as compared to earlier generation trops. There is a prior generation cardiac troponins which limits detect zero point zero 0.01 nanograms. Currently, we are using high sensitivity HS-top, which is around 0.005 nanograms per ml. And next generation in the experimental phase, which detects around 0.0001 nanogram per ml. It's more accurate and early detection is possible with the next generation ultra sensitive ultra sensitive troponins. There is a tepid AMI study of around more than 1,200 patients, shows the early detection of troponin. With the further increase in the troponin level, delta values more than 5 nanogram, we can rule out around one-fourth patient ruled in and three-fourths patients ruled out in the first hour of the presentation. In this, there is a within 1 hour, 0 hours and 1 hour troponin, the delta value shows around 75% accuracy of the patient diagnosis. And in the caveat, there is a diagnosis of delta difference within 0 and 1 hour, 0 and 3 hours. If we are sampling, duration of sampling, if very early sampling, there is hard to detect any troponin or delta value. Rising troponin detectable mainly in the early sampling, not very late sampling also may have effect in the delta value of the. And cardiac troponins also included in universal definition of myocardial infarction from the American College of Cardiology. And also troponin is included as a class 1B for the diagnosis and management by the European Society of Cardiology, and also American College of Cardiology in 2025 class 1B indication for diagnosis and management, and also the 0 and 1 hour or 0 or 3 hours. So for the diagnosis, symptoms present with the ACS, perform 12 ECG, which rule out ST elevated MI or non-ST elevated MI or non-ischemic. If there is non-ischemic ECG, apply for HS troponin, high sensitivity, and if its value is clearly high, then consider as non-ST elevated MI. If it is clear cut low, then rule out for the myocardial. And if intermediate, then we have to observe and rule out for the next second or third sampling be required. And if chest pain persists, the second sample is 0, 1 and 3 hours. If 0 and 1 hour delta value is more than 5 nanogram, then patient is clearly ruled in. And if it is low, it is less than 0.5, then patient is ruled out and patient can send for the medical management and follow up for the European Society of Cardiology in 2023 guidelines also mention the same thing, 0 and 1 hours and 2 hours sampling for the non-ST elevated MI. So in summary, cardiac biomarkers are used for the diagnosis, stratification, screening and monitoring of ACS heart failure patient. BNP or anti-pro-BNP are the preferred biomarkers evaluation for the patient possible heart failure, and HS cardiac troponin are the preferred biomarker for the evaluation of patient with possible ACS. Detectable value represents a continuum of risk for adverse event. Thus, no detectable cardiac troponin level can be considered as normal. Sex-specific cardiac troponin may be intensified and for the diagnosis of MI among the females. Thank you, sir.
Thank you, doctor. Thank you.
Thank you, Dr. Dinesh Pandey, sir. It is for wonderful, informative presentation. Anyone want to ask any question? Kindly please ask.
My question to Dr. Nityanand Tripathi, sir. One patient is admitted with lower respiratory tract infection and his echo is EF 45-50%. His anti-pro BNP is 14,000. What should we do?
Thank you, sir. This is quite a frequent dilemma that we have in our clinical practice. That patient is of infection and pneumonia or any other infection for that matter, and has a high pro-BNP as well. As we know that any infection can precipitate the heart failure, so this patient should be treated for pneumonia and for heart failure both.
Thank you.
Thank you, sir.
Thank you, Dr. Dinesh. Thank you.
Thank you, sir.
So there's one more question. Would you like to take that?
सर एक क्वेश्चन और है आजकल यंग पेशेंट में हार्ट अटैक बहुत ज़्यादा हो रहा है तो रोल ऑफ लाइपोप्रोटीन ए इन्वेस्टिगेशन क्या हो सकता है
What, sir?
कैसे डिटेक्ट करेंगे कि अर्ली कार्डियक साइंस हैं उसको
There is early, we use the troponins in the 0 hours when the patient present with the, and if patient is present within time frame, within 1 hour or 2 hours after the onset of symptoms, and if troponin is negative, then we, and ECG and other is non-remarkable, it's perfectly normal, sometime normal. Then we sample the 0 hours, the first sample, and next sample is after 1 hour, preferably. If there is delta values more than 5 nanograms, more than this, then definitely patient is in the window of the acute myocardial ischemia, and we take to cardiac cath lab straightforward if patient is willing. And if there is less than 0.5, then unlikely patient is in the cardiac symptom. We can observe and send for the non-invasive testing for other thing. And we can send safely for home patient.
Actually, my question was the bad cholesterol. So if lipoprotein is more than 50 in young people, then what will be the precaution to get cured and not get heart attacks in youngs?
If more than 50, then definitely it's rule in the patient.
Actually, we have a whole session on the lipids, and so we will discuss more on that in more detail about the nitty-gritty of the lipids. Thank you, sir. Thanks for your interest.
Thank.
Our next speaker is Dr.
Sir,
Sumit. I think Dr. Sumit and Dr. Rakesh is on the way. Can we move to next session, please?
Yes.
Okay.
Any closing comments from any one of you, and then we'll move to the next session.
Hello, thanks everyone. And we are lucky to be in the conference. We are expert and esteemed cardiologists are there. So we all will be discussing the latest evidence-based strategies which will improve the clinical and cardiac outcome in all the patients. And any more questions from anyone before we begin with the next session?
Thank you. Thank you very much, sir. Thank you so much. And now I'll invite our chairperson, sir, and also our panelists to please join us onto your left-hand side for the felicitation, please, which is the felicitation desk. I'd like to invite Dr. Sanjay Modi, Dr. Kuldeep Kumar. I will also invite Dr. Tripathi to please join us on the felicitation stage on the right-hand side, sir. As I also invite Dr. Abhishek Kumar, Dr. Alka Tiwari, and Dr. Katie Tiwari to please join us there. Meanwhile, for everybody here, I had said earlier that there will be a small surprise, and this is where the special quiz is, which will give you an opportunity to win a gift as well. So I'll invite Dr. Gupta to please join us here, and Dr. Amit will ask you his questions in the style. And if you know the answer, raise your hand, we'll come to you, sir. So, Sandesh, I think we need the screen for Dr. Amit Gupta for the special quiz. Same PPT, Amit Gupta sir की जो PPT थी.
Please raise your hand because there will be special gift. Uh, so, coming to this, a 65-year-old female present with progressive dyspnea. This is the ECG. What's the most likely diagnosis? Please raise your hand. Yes, sir.
Sir, एक minute. We'll come with the mic to you if you can say the answer.
What is this ECG?
Pulmonary embolism.
No, no, no. Wrong.
All right, thank you. I think
Yes.
that
Yes, sir. No, sir.
sir, यहाँ पर
There is Q wave in inferior leads and ST depression in lateral inferior-lateral ischemia.
No, no, no. I would like to give you a hint. QRS amplitude is alternating. There is progressive dyspnea, so it is not acute. Yes. Yeah, you are right. In which condition do you get electrical alternance?
Acute pericarditis.
Acute? No, no. Pericardial effusion.
Okay, sorry.
Must be large pericardial effusion causing electrical alternance. What might be the underlying cause? This is 65-year-old female. What can be the cause of pericardial effusion? Large pericardial effusion. Yeah, this can be due to tumor, tuberculosis, hypothyroidism, which might be causing pericardial effusion. That is causing electrical alternance. You are right, sir. Can we have the gift?
To him.
Yes, for that gentleman. Congratulations. Now coming to next ECG. A young male present with URTI, now present with chest pain. This is the ECG. What's the most likely diagnosis? Is this MI?
Acute pericarditis.
Yes, sir, you are right. Why this is acute pericarditis? Would you care to explain?
I see ST elevation in concavity. So
Yes,
that's right.
concave ST
Concave
elevation
ST
in
elevation.
multiple leads associated with ST depression, as associated with PR depression
Yeah.
and downsloping ST depression. This is acute pericarditis. So coming to last question, young male with left leg swelling present with sudden onset dyspnea. Why this is acute pulmonary embolism? Okay.
Plus tachycardia with inversion of T waves.
There is.
Plus the clinical history is very.
Yes, sir, you are right. It is acute pulmonary embolism. Please give him the gift.
Thank you.
Okay, this is the last ECG. Young male present with syncope. He has history of sudden cardiac death in the family. His father died at 42 years. What's the most likely diagnosis? This is the last time. This is last ECG. Anyone from? No, no, no. Yeah, this is Brugada syndrome, which is suggested by coving ST elevation in lead V1 and V2. The patient has syncope in a young male associated with history of sudden cardiac death in the family. So this is Brugada syndrome. Congratulations to all the winners. Thank you. We would like to start with next session.
Thank you. Thank you very much, Dr. Gupta. Thank you, sir. So, ladies and gentlemen, as you have figured out, this is just the beginning, just to showcase that expect more of this during the day, of course, so it becomes even more relevant for us to learn in a more entertaining fashion as well. So with this, in the interest of time, we will strictly move ahead, ladies and gentlemen, and get into our next session. This next session is titled as Managing the Calcific Coronaries, Treating the Rocks. Now, this session will actually truly explore how evolving atherectomy technologies and emerging modalities and alternative strategies are enabling interventional cardiologists to take to tackle the heavily classified disease with greater safety and confidence. So, ladies and gentlemen, in this session, to moderate and chair the session, let me please invite Dr. Anurag Garg and Dr. MS Tomar to please join us on the chairperson, which has now been interchanged. So, onto the right hand side tables, please. If you can please join us on the chairperson table, sir. And in this session, on the panelist desk, let me please invite Dr. Balwant Singh and Dr. Rakesh Gupta to please join us on the panelist desk for this session, please, as well. Can we have a welcoming applause for our chairperson and also our panelists to be on this session as they make this session even more knowledgeable and informative for us. And with this, I will hand over the session to the chairpersons, Dr. Anurag Garg and Dr. MS Toma. Sir, the stage is yours.
Check. Very good Sunday morning, everyone. For today's session, our first speaker, Dr. Rashi Karis, is well known. Additional Director, Interventional Cardiology. She is done MBBS Gold Medalist from Gorakhpur. MD, Internal Medicine, again Gold Medalist from Jhansi. And she did DM Cardiology for KGMU, Lucknow. I welcome Dr. Rashi Karis.
Thank you, sir, for the warm welcome. And I'll be talking about an tried and tested modality for calcified coronary arteries, that is rotablation. So rotablation dates back to 1980s. Just a brief. It works on the modality. It works on the principle of differential cutting. That means it will cut the tough calcified. The calcification it will cut, but it will not harm the softer blood vessel. So I told it works on differential cutting. We have a rota burr. We have different sizes of the burr. Just to prime everybody, this is the rotalink burr. We have pointer. Okay. So here we have got diamond crystals, which actually drill the calcium out of the coronary artery. We have got a sheath that actually protects the coronary artery. We give, just to prime everybody about how we do the procedure, what is the hardware, what is the mechanism, how we do the procedure. There is a flush running throughout that actually cools down the heat that is produced by such a high RPM. It works at around 1,70,000 to 2 lakh RPM. So we continuously flush the fluid. These are the burr sizes. We start from 1.25, 1.5, 1.75 and up to 2 millimeters. It all depends on the size of the artery that we are dealing with. This is the overview of the advancer. These are some great innovation technologies that have happened in coronary CAD. This is the console with which we can control the speed of the burr, the pressure it is generating, and it also helps us to know. It is very important. Rota actually needs a lot of expertise. One has to look at this console for continuous readings to know when we need to stop. The burr pressure is falling, the rotational speed is falling. These are very important. This is the rota wire is different. It is a softer wire that is used for doing the rotablation. So the fundamental elements are, that is very important to know, the burr size, the burr size to artery ratio is very important. That has to be kept in mind, and this actually needs a certain level of expertise. It has a certain learning curve that comes, and the pecking motion that needs to be done for accurately cutting the calcium and not the artery. Because if this pecking motion is not there, if we are persistent in doing rotablation that no, I'll cut this calcium at anyhow, then we can actually perforate the artery. So it actually needs the wisdom when to stop also. It is a class 2A indication. There are certain contraindications. It should not be done in thrombus. I'll show certain cases. There can be certain complications in rotablation also that one should always keep in mind, so that If we know the complication, then we know how to deal with it. We know because our eyes only see what the mind already knows. So we should be prepared for bradycardia, slow flow, any dissection, any perforation, hypotension, any burn entrapment, because doing a procedure is important, but able to manage a complication is more important, because any complication can happen in coronaries. Complications are very unpredictable. So you must be smart enough to recognize them early and expert enough to manage them. So I'll show two cases. One is a 75-year-old gentleman. He was a non-STMI, presented to us with an EF of 35%, continuous chest pain, sweating, and he had a history of angina and exertion since the past 5 months. He was a diabetic. So this was the angiogram. We can see a significant lesion in the mid LAD, proximal to mid LAD. We can see the black shadow that shows significant calcification. This is around 80 to 90% blockage. This was the only lesion. Rest of the vessels were having disease, but not that significant. The echo also showed a hypokinesia of this territory only. So we decided to fix it. This amount of calcium actually needs rotablation. Because there is no thrombus or clot in the artery, we could go ahead. Now this is a burr. This is a 1.5 millimeter burr. We just go and come back. Go, touch the calcium and come back. This is how it is done on a specific rota wire. Then after this, the balloon could go nicely. This is the balloon. The balloon crossed the calcified lesion and we could actually dilate the vessel, and this was the result. Nicely done, all the branches are flowing. So this shows the importance of rotablation in calcified arteries. Now a second case, this is a case where I want to show you all how a complication actually can be managed when we are doing a very complex case where we need to keep all our, we need to sight intact, that not to panic. So this was an 84-year-old gentleman with a history of hypertension and CKD. He had history of unstable angina since the past 2 years, having recurrent rest pains. But because he was old age, the attendants was also not very keen on doing any intervention. Then he was on antiplatelet. Now the angina on exertion was increasing since the past 4 months. He presented with non-STMI. ECG showed LAD territory because there was biphasic. It has already showed now biphasic T in anterior shows well in sign, the proximal to mid LAD. Then echo had a hypokinesia and creatinine was already 2.2. The video is not playing. Yes, sir. जी sir. Because it rotates and ablates. Rotational atherectomy, ROTA.
Is it continuously moving on its axis?
Yes, sir. It actually, when we do a rota, we can actually hear the sound. मतलब जो ही cath lab के बाहर भी है, he can hear that rotablation is going. The zoom sound comes because it has a very high RPM of around 1,70,000 to 2 lakh. And with that, so that is important how we do the procedure, because at that high RPM, if the flow of fluid is not accurate, then it can actually burn the coronary artery from inside, burn the tissues. And if we don't do the rapid movements, then it can actually cut our wire. It can perforate the coronary artery. So that is very important. So in this case, I'll just tell what we did. So we were doing this LED. I'll just show the videos they are playing. Okay. So this was a heavily calcified coronary artery. All the vessels were diseased. LAD had a very tight lesion in the proximal to mid LAD. We can see in this second figure. Because the gentleman was already very old and the creatinine levels were also very high and the um, EF was also around 35 to 40%. We decided to fix the culprit artery only. Initially, the advice was CABG, but because of the reluctance of the attendant, they were not willing for any procedure. So, we got a feel of calcium. Just so they were not willing to what next. So we decided to go ahead with Rota to fix the LAD only, the culprit artery. So we initially planned for 1.25 millimeter burr because the vessel size was very small. So we did not think that 1.5 will actually help in this case. Initially, we decided for 1.25. So this was the burr. We have put the second motion. Because it was so much of calcium, the burr got stuck. It did not come out. It got stuck. So there are various maneuvers by which we can actually take out the burr. We took a second guide, passed the wire across the wire. You know, in such scenarios, you need team effort. We actually immediately called the CTOS team that we might need your support. But meanwhile, we were doing our efforts to take out that bar. So we passed the wire, balloon. There's a maneuver we can actually balloon dilate in front of the distal to the rota, and then we can try to pull it. We could not do it by that also. Then there's very innovative technology. We cut the keys from back, and we could take out the bar. And we took out the burr and we did not leave the case there. Next, we completed the case, took the second rota burr, completed the case, with a beautiful result. The patient was discharged. Next video चला लें. And after that, again, something innovative. We always try to do imaging in any complex case. Imaging actually documented that we had done no harm. The stent was beautifully expanded and the patient did fine. So it is a complex procedure. It requires certain degree of expertise. Definitely, it has got a learning curve. Complications can occur, but keeping our cool and having good team is very important. Thank you.
I mean, how many branches of the coronary you can do at one time or in one sitting?
Sir, depends on the patient, how much time the patient can take, age, body habitus of that patient. A very fragile patient, definitely we try to do only one vessel, but we can go for two vessels in one go. It may depends on various other reasons. EF is very low, so we take an IBP support, or we can also go for some latest devices like Impella. So it depends on patient to patient. Every patient is different.
Sorry to ask, what is success of the procedure in percentage? Thank you,
I've not
thank you.
seen a
Thank you for the procedure.
Thank you, Dr. Rashi, for the nice presentation.
Thank you.
Next session is the newer kid on the block, orbital arthrectomy, Dr. Nityanand Tripathi.
A big round of applause for Dr. Nitin Tripathi sir and his team. I remember he's working very hard. Last month, around 1 month back, he had meetings with doctors. What topics should be kept? What is the your choice? And thank you, sir, for organizing such a program, sir.
Good morning, my seniors and colleagues. Good morning, chairpersons and panelists. The calcium is really bad when it is in the coronary arteries, and particularly bad when there is toxicity as well. So we have to have the multiple devices to tackle this calcium. You have already heard about the rota ablation. It's one of the device which creates the space. But when calcium chunk is larger, when calcium is inside, or media, then it is ineffective because it cuts the calcium only inside the arteries. Before we proceed, this is last 5 years. In last 5 years, that we have done around 11,710 procedures in our cath lab. This is done by my team in Fortis in last 5 years that we moved on. The coronary angiographies were up to more than 6,000. Angioplasties almost around 4,000. Then device and implants and complex devices around 736. Advanced coronary imaging procedures around 1,000, and electrophysiological studies are almost more than 150, and structural interventions to the tune of almost, and we are counting still. Right. So to know the calcium and depth of it, we usually use IVUS or OCT. IVUS is intravascular ultrasound, and OCT is optical coherence tomography. The ultrasound, IVUS, because we use ultrasound technologies to imagine, and OCT we use the optics, that is the infrared, uh, to imagine this calcium and inside the coronary arteries. The approach to calcified arteries can be divided by the IVL or balloon or imaging catheter. So once the imaging catheter cannot cross it, we usually use the rotablation, because rotablation creates uh, the space inside, and when it is balloon crossable and large artery is large, then we use a newer device that is known as orbital atherectomy. Orbital, because as you know that the Earth orbits around the Sun in an elliptical way, and the same way this device also cuts the calcium in an elliptical way. So more runs we take, more space we gain through this device. So this is the device. When we take more runs, we keep on getting the more and more space. This is the device. This is quite easy device. This is the button through which we put on and off the device, and we advance the device inside the coronary arteries. The advantage is like rotablation. We have already seen this is the atherectomy device, that is orbital atherectomy. It moves in an eccentric way, and it cuts the calcium and makes the larger hole, while this rotablation creates a central hole inside. But in atherectomy, we cannot, orbital atherectomy, we cannot pass this device if it is not balloon crossable. So this is how atherectomy, orbital atherectomy does the cutting inside the coronary arteries. And it's a unique dual mode of action. It bidirectional, so we can go inside and come back as well. The rotablation, as you listen, Dr. Rashi saying that the burr might get stuck here, that challenge is taken care of. We can push the burr inside and can take it out and cutting retrogradely as well. So when we choose the orbital atherectomy over the other devices, when there is an eccentric lesion and vessel is large, the elliptical motion of the way Crowne allows it to send to do a eccentric and asymmetrical cutting, thereby creating a larger space. If lesion is angulated in angulated segment, we can go cross the lesion and come back, therefore become more safer, reduce the risk of no flow and slow flow in this with this device, because it cuts in a very small particles, and that can be flushed away. And it is simplified procedure. One single burr can be used to cut to do rotablation or ablation in a smaller vessel to a larger vessel. So this is where we want to take the rotational atherectomy, that is the rotablation. When tight and eccentric lesion and non-crossable, this is the only device. So I will present a few of my cases. 61-year male, non-STEMI, hypertension, diabetic. Angiogram showed a severe lesion and angulated lesion in the LED, and here you can see there is a calcium. When the dye gets washed off, then also you can see the calcium here. Right sided is normal. We cross the lesion with the wire, that is this, arbitrary atherectomy is special wire. Then this is the arbitrary atherectomy. Uh, uh, we gradually cut and went down. This is the crown, and it requires persistence and patience, because more slow we go, more good result we will achieve. I will show you the result finally. This is after the cutting and dilatation, and this is the OCT, that is the optical coherence tomography. You can see the calcium over here, and this is the cutting of the calcium. You can see it is fractured, calcium is fractured here, and once it is fractured, we wired the diagonal and put the stent, and this is the final result. This is the final result. So had it been like not an atherectomy, then there could not have been good expansion of the stent, and that could have led to stent thrombosis and restenosis. I will quickly show you the second case. This is the RCA, long lesion, and we did the same. Put the temporary pacemaker, because patient might go into the CHB, pre-dilated, and put the atherectomy, did the arbitrary atherectomy, and show you the final result. And we'll come back to the third case. Again, here also I think it's not moving. So in the LCX also, we did the same thing, putting the arbitrary atherectomy device, and then did the angioplasty. So when there is a calcium, it becomes really challenge for the clinician and the patient alike, and this require any special tools and procedures to handle it. And fortunately, we have everything in our lab, right from rotablation, arbitrary atherectomy, OCT, IVUS, everything inside our lab, and that is easily available. We need not to bring it from somewhere. So to summarize my talk, arbitrary atherectomy is safe option in heavily calcified artery and nodules. Advantage of arbitrary atherectomy is in large caliber vessel. Atherectomy can be accomplished with a single crown. There is no requirement to change or upsize the valve. Arbitrary atherectomy needs to be supplemented with the appropriate plaque modifying techniques for adequate lesion preparation. Adequately prepared lesion facilitate adequate luminal gain and good stent opposition. A well-opposed stent is and well-expanded lesion is key to the good long-term outcome. Short, shallow learning curve is there with this compared to the rotablation. So thank you for your patience hearing. If there is any questions and comments, most welcome. We are doing these procedures routinely at our lab in all the tortuous vessels and all the complex cases like low EF, and even the cases which are refused by the other labs. Thank you.
Sir, there is a dilemma when so many good procedures have been developed in hardened calcified coronaries, then will it pass over the bypass surgeries in the future?
Then I could not get your question. Then because see every like rotablation, arbitrary atherectomy, IVL, everything has its own niche and its own role. So we have to select the appropriate tool for an appropriate patient so that we can deliver the good result to them. Like I told you, if it is not balloon crushable, then rotablation is a good choice. If it is balloon crushable and the artery is like tapering, the proximal is 3 and distal one is 2.5, or proximal is 4 and distal is 2.5. Then with rotablation, I have to take 2 or 3 bar, and here with the one single device, I can do it both. But problem with this device is this is costly. 3 lakh is the upside cost for this device, and this cannot be reused. It has a chip inside, and that gets deactivated after 12 hours. While in rotablation, we can use it in multiple times because it don't have any chip. So every device has its own advantage and disadvantage, and we choose it very carefully in our patients.
Thank you, sir. Any other question?
I am a जनरल प्रैक्टिशनर. जब हम पेशेंट भेजते हैं आपके पास तो हमसे 2 सवाल पूछता है वो कि डॉक्टर साहब कितना खर्चा लगेगा, वाई नॉट बाईपास, वाई फॉर दिस वन. क्योंकि जो ये मीटिंग है ना, ये हमें एजुकेट करने के लिए हम क्या मरीज कैसे भेजें, हमें तो ये करना नहीं है.
Sir, actually, that is why we are discussing here, because nowadays people do not believe in cardiologists because they say कि cardiology में हम अगर जाएंगे तो stent तो पढ़ना है. And that is true also because we take the patient for angiogram only when we think that there is a 80 to 90% probability that there will be significant disease. That means if I do an angiogram in 100 people, at least 80% of them will turn out to be significantly positive. Otherwise, else my patient selection is wrong. That is why this perception is there. And once we do the angiogram, they invariably call to their referring doctor or their family physicians कि ये तो डॉक्टर बोल रहा है कि स्टेंट डालो, क्या करना चाहिए. That is why you need to be very educated as well. So regarding the CABG and angioplasty, both are the palliative procedures. Both are not definitive one. Even after CABG, 50% of the venous graft get blocked in 5 years. And though the lima only last for like 10 to 11 years on an average. So if both are the palliative procedures, then lesser invasive is better one. The second one is like cost. The cost always remains an issue because this is single time device. We tell the patients upfront that with the this atherectomy device and angioplasty, your cost will be around 5 to 5.5 lakhs. And if it is angioplasty alone, then cost is around 2.5 to 3 lakhs. So 3 lakhs is added into that. So this is regarding the cost, sir.
Thank you.
I think, thank you, sir, for covering the financial aspect also. It is said that every minute a heart stops beating somewhere, not because help reached too late, but awareness in the society came too late. I request Dr. Anurag to introduce our next speaker.
For the next session, again, I welcome Dr. Rashi Khare again to speak on ECLA, the upcoming modality to treat CAD.
So again, a very good morning to everybody. I'll be talking about excimer laser. It is the newer kid on the block. That means not everyone is very familiar with it. We already talked about rotablation, that is actually tried and tested. We are doing it since 80s. Then we had orbital atherectomy that has actually established its roles in long calcified lesions. And then ELCA, the excimer laser. So excimer laser is actually a pulse, it uses pulse gas lasers to navigate through the lesion for not very heavily calcified lesion, but balloon uncrossable, even in thrombus. It actually acts on the phenomena of heat production that is lesser than the rotablation. So what are the mechanism of actions of ELCA, that is excimer laser? We have got photochemical, photothermal, and photomechanical. It is more of theoretical right now, breaking the molecular bonds, producing thermal energy that is lesser than the earlier two modalities we just showed in front of you, and creating some kinetic energy. The photochemical mechanism, it actually breaks the molecular bonds. Then by photothermal mechanism, we produce a thermal energy to liquefy the lesion. It actually forms a vapor bubble that is formed in 100 millions of a second. And with the rupture of that, the expansion and collapse of that bubble actually breaks down the tissue and clears the byproducts away from the tip. There's a single laser pulse type line. We have got certain technologies that are very innovative for this. We use it for 125 billions of a second. Then we come down to 400 millibillions of a second. We give a rest period for the patient for the laser. So there are certain 5S for this laser success: selection of the patient, sizing, setting, saline, and speed. I'll just briefly go ahead with all this. The selection of the patient, because multiple morphology lesions are important. Actually, this is a newer modality that is actually establishing its role. It is not for heavily calcified arteries. Rotablation is a tried and tested modality for heavily calcified arteries. Then came orbital atherectomy, that is actually for calcified and long lesions. The newer one is actually, it can be used in thrombotic lesions also. That is actually a contraindication for the previous two modalities. Then we have got lesser risk factors, lesser complication rates with this patient. We can even use it in graft patients, post-CABG patients. When there's a blockage in the venous graft, the SVG, saphenous venous graft, we can use these lesions. Then we can use it in osteal lesions, where there is a hitch in multiple operators for using a rotablation or orbital. It might, that the burr might got stuck, or maybe the placement might not be accurate. Particularly in left main osteal lesions, certain operators have a hitch that we should not rotablate an osteal left main, because it might dissect the aorta also. So it has importance in all those lesions. Then sizing, that is a theoretical point. The catheter vessel ratio, it is tighter the lesion, the smaller the catheter needs to be taken. The saline flush needs to be used, and the speed should be around 0.05 to 1 millimeters per second. So the importance of ELCA above these, it is not that ELCA is going to replace rota or orbital. It has got its specific indications. We can use it in thrombotic lesions where we cannot use rotablation. Then we can use in ISR, that means in-stent restenosis, where the stent is already placed. In those scenarios, although rotablation is used in ISR situations, but there are certain chances that the burr might actually ablate the stent also, because it is going inside and the stent is also in the same area, and it might ablate the stent and it might deform the stent and might make a thrombotic milieu. So that is avoided by these. Thirdly, in the graft lesions, we cannot use rotablation. There we can use it. It is also a bit simpler because we don't need to have a specific wire for ELCA. Like in rotablation, I showed that we need a specific wire. Sensor also showed. In orbital also, we need a specific wire. We need to exchange the wire. Sometimes we can do directly, but we need to exchange. So that is a simplified modality, this one. There's a slow advancement. For a 6 centimeter lesion, we have 60 seconds minimum for 1 minute to cross. So I showed it shows a photomechanical effect. It actually forms a bubble, and with the collapse of the bubble, it actually extends forward. Slow advancement is the key. We can see the results with the fast, the lumen diameter with the fast advancement, and when we do a slow advancement, what is the lumen diameter? Again, here we can see it is actually inside model of the artery. With the slow advancement, we could get only a 3 millimeter lumen, with the fast advancement, while with the slow one, we got a 6 millimeter lumen. So I'd like to show the indications are in acute MI patients. When we have got thrombus, we cannot use a rota in these patients. Then again, a non-crossable lesion, a non-dilatable lesion, we can use it. In CTOs, we can use it. It is a safer modality for CTOs. Under expanded stents, because it is not going to hamper the stent, it is not going to cut the stent. So we are safer on that side in that particular scenario. In ISR, in-stent restenosis, again, we are safer with our stents. In graft, the saphenous venous graft, we are safer in those modalities. Then bifurcations lesions, yes, very important point, in branches. When we have got a significant branch that is actually significantly diseased, but we are not able to rotablate that branch because it will take a lot of curves and the burr might got stuck. In those scenarios, we can use ELCA. It is a good modality for these indications. contraindications, unprotected left main, and long subintimal course of the PCI wires in certain CTOs. Complications are similar to routine PCI. It is not because rotablation, actually, I told that it has got a higher learning curve. You need to actually know what complications can occur. You need to identify them early. It actually needs a certain expertise and it needs a strong team. Doing a rotablation in a remote center sitting alone is not recommended. But ELCA has a complication rate that is similar to routine PCI. I'd like to share some cases here. These cases are not done by us because we don't have ELCA right now in our hospital, but we are acquiring it. In the coming 2 to 3 months, we'll be having it. These are our cases that we had to refer to some other center because we didn't have that machine right now. So this was an inferior wall MI post CABG. The patient had this was the ECG, inferior wall MI. So the patient had graft thrombosis. Okay, so the patient had graft thrombosis. In the third, we can see there was 100%. We can see the graph, it is 100% occluded. Now, after wiring, passing a balloon, then ELCA was done, 1.5 millimeter laser, and the final result, this is the final result, nicely done. Now this was an ISR situation. We can see in the midpoint, this is a lesion, tight lesion, balloon non-crossable, ELCA was done, 0.9 millimeters, and the result was this. Now again, patient both PTCA to RCA. He was a post-COVID patient, and again in this there was stent restenosis. This was the lesion. After doing ELCA, this was the lesion. Nicely done, nicely put. In acute MI, thrombus. So this was a thrombotic lesion. ELCA was done. Nice results, and even check angio was done after 1 month. That showed nice result. Instant restenosis I already showed after using cutting balloons. Now, so ELCA when nothing could cross, that is a balloon uncrossable lesion. We can see the lesion. It was sort of a CTO, wire crossing. Then again, ELCA was done. The patient was taken with dual injections, and the nice result. We can see the result. The SVG graft restenosis. We can see the restenosis here. This is the graft. This is the restenosis. Again, ELCA was done, and we have got very nice results here. Thank you. So actually, it is a newer modality that we still have not acquired, but in the coming 2 to 3 months, we'll be having it at Fortis, and we are the only center that will be having this modality in this entire region, the Northwest Delhi region, and we would appreciate if any needy patient or the patient appropriate for this modality is treated. Thank you.
Any questions? Most welcome.
In the Fortis, we have tried to introduce newer and newer modalities and newer technologies in this region to serve our patients in a better way. In that section only, in that way only, we are going to acquire this ledger in coming 3-4 months. We have already, in fact, in advanced process of ordering it. And once we had this ledger at our site, then we are at par with any of the cath lab across the world regarding the technologies and the diversities of technologies. So that is most important. In fact, I will in fact thank to Fortis management who have reposed a faith in us and went on acquiring the newer and newer technologies more and more and more. So we will serve you more and more in future, you and your patients alike. Thank you.
Sir, one question. How you choose a patient of a CAD, what to do, rotablation or ALCA?
Say, when it is balloon non-crushable, then either rotablation or ELCA. But once it is tortuous lesion, then it becomes difficult for rotablation. Likewise, if it is ACS where thrombus is there, rotablation is device where blood is rotating at the speed of 1,70,000 RPM inside the coronary artery. If there is a thrombus, it will pulverize the thrombus and break it into the small pieces, and that will go into the a small vessel, that is the microcirculation, and plug it. And once microcirculation is clogged, you can not do anything. Whatever you do, the arteries are 100% occluded. So to avoid this situation, this ELCA is the best situation for those patients who have MI and high like calcium burden. Nowadays, what we do in patients with the MI and severe calcific arteries, we just establish the flow and leave it there and call the patient after like 3 to 4 weeks and then do the rotablation or atherectomy. But this device will be boon for them. This device is again boon for the young people who do not want to put the stent inside their arteries and there is a thrombus only. This ELCA bursts the thrombus in the small pieces, and arteries, once arteries are clean, we are sure with the OCT or IVUS, then we can leave this patient there and their arteries remains original. So that these two areas where this will be the boon.
Thanks,
Hello.
Dr. Rashi, for this wonderful presentation. Thank you, sir.
If you do not want instrumentation, then what are the options available? It will be elaborated by Dr. Ashish Kumar Garg. Next session.
I think he's not here. He's not here, sir.
So next is?
This session is over.
All right, thank you. Thank you very much, ladies and gentlemen, for being an accepting audience. Can we have a round of applause for all the presenters? I would now invite chairpersons, Dr. Anurag Garg and Dr. M.S. Tomar, to please join us for the felicitation ceremony, sir, on your left-hand side, along with Dr. Balwant Singh, sir, and Dr. Rakesh Gupta as well. If you can please join us on the left-hand side, sir, for the felicitation ceremony. And I will also invite Dr. Rashi Khare, and sir, आप तो felicitate करने वाले हो, please. And while they are busy in this, let me also remind you that थोड़ी देर पहले I was telling you कि today we'll have a little interaction and fun as well. So earlier we had Dr. Gupta, Amit sir ने आपसे कुछ questions पूछे, but now is the time when you simply get lucky. As simple as this, okay? So what we're doing is, आप when you were all entering, तो आपने एक lucky draw coupon भरा था, and we want to, हाँ sir please. अच्छा ये आपके पास ही रह गया था, ठीक है, तो फिर बड़ी दिक्कत हो जाती. So what we want to do is now we want to make few of us winners, and we will do this as a ceremony during the whole day. Okay, so right now we'll do about 4 or 5 as time permits. And what I request is, sir, if you only do the honors, sir, तो आंख बंद करके बिना cheating करे. If you can take out one, sir. And the winner is Praveen Jain. Yes, it is Praveen Jain. I think it is Praveen Jain.
Thank you. Thank you.
Sir, please, I'll invite you to come and join us here. मैं सर इसमें एक फोन नंबर लिखा हुआ है, मैं वेरीफाई कर लेता हूँ. सर मोबाइल नहीं, आप बता दो, पढ़ के तो आप. हाँ Sir, we are talking about this Naveen Jain, sir. Please, sorry, Praveen Jain, sir. Please, if you can join us here. And Ashish, sir, I'll request you to help me with this. Ankesh, sir, if we can please invite you to join in and hand over a small goodie to Praveen, sir. And while you help us with this, we will take out another one. Ma'am, why don't you do us the honors and get me one more winner, please? If you can pull out one, and the winner is Dr. I think this looks like Dr. Dinesh Pandey. Now I'm doing the most difficult job to read the doctor's handwriting. Okay. Dr. Dinesh Pandey, I think. मुझे लगता है दिनेश सर तो चले जा चुके हैं शायद. Okay. So you have to be here to win. So I'll come up to somebody else, sir. Please, if you can do the honors. Is this fair that you have to be here to win? Everybody is fair with this, right? Okay. So this is Dr. Anand Prakash Agarwal. This was very clear. Dr. Anand Prakash Agarwal. Chale gaye. Dr. Anand Prakash Agarwal is not here. Wow, ma'am, you're so happy. Chale gaye. This is nice. Why don't you do us the honors and pick out the next one, ma'am? Ma'am, nikaliye. हाँ, वो भी ठीक है. We are okay with that. Okay, and the winner is Dr. Manish Dudlani. No, sorry, Manisha. I'm so sorry. Dr. Manisha. I'm so sorry, ma'am. Please, if you can join us right here, ma'am. I will request you if you can step up there and receive your gift. Meanwhile, I will come this side. Sir or ma'am, any one of you, please do the honors. Pick out one more. Dekhna nahi hai, ma'am. Just joking. अब ये पढ़ के भी आप ही बताओ. Dr. Modi. It says Dr. Modi. I know. Dr. Modi, sir, please go ahead, step over and receive your gift. Okay, 2 more to go. Ma'am, if you can do the honors, pull out one more for us. And the winner is I think this is Dr. Ankit Gupta. Dr. Ankit Gupta. Dr. Ankit Gupta. I don't think Dr. Ankit Gupta is here, so I will proceed. Sir, please, nikaliye. Okay, and you have to just help me with one. This is A. Ahuja. It says A. Ahuja. A. Ahuja. Anyone? Am I getting it right? Dr. A. Ahuja? No. Then, ma'am, if you can help us, pull out another one. I need 2. So we'll do 2. Dr. Jaipal. अरे अभी तो कहीं कोई गया भी नहीं है. Dr. Jaipal, sir. Dr. Jaipal. Ma'am, if you can pull out one more. Dr. Jaipal, are you here, sir? Dr. Jaipal. Okay, he's not here. Dr. Pradeep. It is Pradeep. Pradeep, sir, please step on and receive your gift. Thank you. Okay, so I think with this we'll go. Ma'am, अगली बारी मैं आपके पास आता हूँ मैं. अगली बारी मैं I'll come to you. We have another 25 to go. So don't worry. Okay, in the interest of time, we'll quickly proceed now, ladies and gentlemen, while we're also congratulating our friend here, as we are definitely behind schedule. So, ladies and gentlemen, the next session that we are getting into is coronary interventions. This session will primarily be talking about managing complex anatomies to reducing procedural risks and reimagining the future of stent technology. This session addresses the real-world challenges interventional cardiologists face every single day. Ladies and gentlemen, this session will be chaired by Dr. Rupesh Sharma and Dr. V.K. Kohli. If I can please invite Dr. Rupesh Sharma and Dr. V.K. Kohli to please join us on the chair desk. All right. Meanwhile, if I can also please, I've been informed that they're right here, so they'll be joining us shortly. If I can also please invite Dr. Rakesh Diwan and Dr. Ravinder Kumar to please join us on the panelist table here as well. Thank you. I think Dr. Kohli is here and Dr. Rupesh Sharma. Dr. Rupesh Sharma, Dr. V.K. Kohli are going to be our chairpersons for this session. Dr. Rakesh Diwan and Dr. Ravindra Kumar will be on the panel. So I will hand it over to our chairperson, sir, since one of you is here. I will hand it over to you. And ladies and gentlemen, meanwhile, if you can give it a round of applause as a welcome to our panelists as we get into the coronary intervention session. Over to you, chairperson, sir. This is yours.
So today we are starting this session of coronary interventions. Hello, Rajapal. Okay. Our first speaker will be Dr. Yogesh Habra. He is Director and Unit Head of Department of Nephrology. Please, Dr. Yogesh Habra.
Thank you, sir. I would like to, first of all, I would like to say thanks to Dr. Tripathi and the organizing meeting for giving me a chance to speak on this topic. As a nephrologist, we are on loggerheads with the cardiologist, specifically once it comes to contrast-induced nephropathy. Contrast-induced nephropathy is something which is one of the most common cause for hospital-induced acute kidney injury and which we face day in and out. Although with the advent of the time, the chances of it leading to dialysis has gone down, but still its prevalence is going high day by day. And definitely with adequate treatment and adequate management, we can actually go down on it. Yeah. I would be covering this topic under the following headings. First of all, when it comes to the definition of acute kidney injury, in the past there were multiple definitions which were actually leading to confusion in different era and definitely amongst us and amongst cardiologists and amongst radiologists as well. But right now we are following the guidelines which are being given by KDIGO, and the acute kidney injury as per this is defined as once after giving intravascular contrast exposure, there is a rise in serum creatinine by more than 0.3 or it has risen by more than 25% as compared to the baseline values. Or if we see the urine output has gone down by 0.5 ml per kg per hour, which is persistently low for more than 6 hours, then we define it as acute kidney injury. This is a staging which we would like to follow. If the creatinine has risen by 1.5 to 1.9 times, it is stage 1. If it has risen by 2 to 2.9 times, it is stage 2. And anything beyond 3 times, or if the creatinine has risen beyond 4, we call it as stage 3. And also, as per the urine output, if it has remained below 0.5 ml per kg per hour, for 6 to 12 hours, it is in stage 1. If it is persistently in this range for more than 12 hours, then it is stage 2. And if it has gone below 0.3 ml per kg per hour, or if the patient is in anuria for more than 12 hours, then the patient is classified in stage 3. We already know that it is one of the most important cause. In fact, it is the third most common cause for hospital-induced AKI, and it is associated with increased morbidity, mortality. This is where it actually changes the plan of the cardiologist and definitely the stay of the patient, and many other complications are getting involved. It increases the length of the stay and healthcare costs as well. AKI in general population, if we are seeing, is actually 1 to 2%. In high-risk patient, it has increased to more than 20 to 50%, and it's clearly common after coronary angiography. The factors which I would like to highlight are, as per the multiple scoring, we can see if the eGFR is falling below 60 ml per minute and the patient has underlying diabetes, patient has underlying hypertension, and the age is more than 60 years, the patient is volume depleted at the time of admission and had features of heart failure, then the chances of having AKI secondary to contrast-induced nephropathy are quite high. The procedure, which definitely there are other factors as well, specifically related to procedures. If we are using a higher volume of contrast, specifically we recommend that if we are going ahead with a diagnostic angiography, the contrast volume should be kept below 30. If we are actually talking about interventions, the contrast volume as a nephrologist, we would be happy if it is being kept below 100. Repeated contrast exposure, definitely if it is happening within the span of 72 hours, can also lead to increased procedural risk. Intra-arterial administration, and specifically if we are talking about high osmolar contrast agent, which we were using previously, now it has almost gone down, can also increase the chances of acute kidney injury in all these kind of the patient. If we see this table, this is the most important table of this presentation. We can see if the creatinine is above 3, the odds ratio increases to more than 12. This is the most important thing which we need to see. Yes, if the patient has underlying chronic kidney disease, the creatinine is on a rising trend, the baseline creatinine at the time of admission was 3, definitely the chances of having acute kidney injury after the contrast administration increases by almost 12 times. Diabetes mellitus is one of the most important risk factors. It increases risk by almost 5.5 times. As the age increases, the chances of AKI increases. Per year, definitely the odds ratio increases by 0.02%. Underlying congestive heart failure, hypertension, low effective circulatory volume can increase the chances of AKI. This is the scoring which has been developed and is being followed up in most of the parts of the world. This is contrast-induced AKI scoring as per the KDIGO. Yes, we would like to follow that, and definitely if we see the factors which there is a numbering system related to all these factors. With hypertension, we give a score of 5. With use of intra-arterial blood pressure monitoring, yes, we add 5 more points. When the patient is presenting to us with the heart failure, we add 5 more points. As the age is above 75, 4 more points. And similarly, we all add up all these points as per this table. And if the risk score is less than 5, then we see the chances of having dialysis is very minimal. It is just 0.04%. But if the score adds up to more than 16, then the chances goes above 12.6%. This is a great number. Definitely, we need to be cautious and we should modify the factors if possible before going ahead with the contrast administration. As a nephrologist, it is quite difficult sometimes. The patient has landed up into heart failure. It is quite difficult to decide whether we can give fluid or not, which is the most important part of the preventive regimen. If we are actually going to define all these radio contrast media, we are usually defining it as ionic or non-ionic. They can be monometric or dimetric, and specifically the contrast which we would like to prefer as a nephrologist are isoosmolar contrast, which are dimetric and non-ionic in nature. In this, we actually include Visipac, which is iodoxinolone, or atenolone, which can be included in this setting. Just a word about pathophysiology. We can see that the altered microcirculation, which can lead to vasoconstriction, can lead to hypoxic and toxic renal tubular injury. There is a barrier between the cortex and the medulla. The tubules and the junction of cortex and medulla is actually the S3 segment is the most important segment which can actually undergo acute tubular injury very fast. And definitely it means once the cells have gone under renal tubular damage because of acute tubular injury, hypoxic injury and toxic injury, they need at least 2 to 4 more weeks to recover. This is one thing which we need to remember. If the patient has gone under insult and once the insult is removed, it usually requires 2 to 4 weeks for the cells to regenerate. It can further, if the insult is persisting, then it can lead to renal endothelial dysfunction. Similarly, this thing is being said in this picture as well. Once we give contrast media, the intertubular precipitation of the proteins happens, which can lead to tubular obstruction, increased viscosity, which can lead to red cell deformity, release of adenosine and endothelin, which can lead to renal vasoconstriction. And all these things can lead to multiple factors which can lead to contrast-induced nephropathy, whether because of vacuolization, renal medullary hypoxia, or free radical formation. And definitely, the lesser the insult, the chances of recovery are higher. We have to remember, we sometimes are confused whether it is because of sepsis, whether it is because of contrast-induced nephropathy. But in contrast-induced nephropathy, the FeNA is usually less than 1%. Here we can see in all these graphs, if a person has a delta rise of serum creatinine more than 50%, yes, if the patient had a creatinine of 1 and it has increased by 50%, it has gone beyond 1.5, the chances of mortality increases a lot. And similarly, the chances of cumulative heart failure and end-stage renal disease increases tremendously as compared to the patients who had just minimal rise or no rise of serum creatinine after giving after the contrast administration. Yes, we need to be vigilant. It is usually asymptomatic. The rise in serum creatinine we can see usually after 24 to 48 hours, and the peak we usually see at around 3 to 5 days, and recovery is usually between 7 to 14 days. But if it is persisting, we might have to think in the terms of atheroembolic showering, which is one of the most important differential, and it is very difficult to differentiate in all these settings. Small molecules of cholesterol can deposit in multiple vessels in the kidney and cause permanent damage, which is not usually recoverable. The temporal relation to contrast exposure is the most important thing. And once we are coming to the diagnosis, definitely biomarkers are the most emerging thing, and NGAL, KIM1, cystatin C, but practically in our settings, we are talking about creatinine value only. Coming on to the prevention part, hydration remains the most effective and the most prominent strategy. The isotonic saline is usually given at the rate of 1 to 1.5 ml per kg per hour, and it has to be started 3 to 12 hours before and to be continued at least 6 to 12 hours after the contrast exposure. And we should target a urine volume of around 6 to 12, urine volume of around 150 ml per hour. This is the most important trial which I would like to highlight is Poseidon trial. This was the trial where actually LVDP guided hydration was done as compared to the control group, and we saw a remarkable improvement. LVDP was measured, and if the patient had LVDP less than 13, the fluid was given at the rate of 5 ml per kg per hour, and once the patient had LVDP more than 18, it was reduced to the same volume of 1.5 ml per kg per hour. And we have seen the chances of contrast-induced nephropathy in the control group was 16.7%, and in this group it was just 6.7%. And we can see the change in the hydration level in these two groups, and definitely the results which we have discussed, 16.7 versus 6.7% over the time period. We should be using non-ionic isosmolar contrast. The maximum target volume should be achieved in terms of hydration. The diagnostic diagnostic volume for the contrast agent should be less than 30 ml, and interventional it should be less than 100 ml. Gadolinium is totally different. It is actually not to be covered. It actually leads to nephrogenic systemic fibrosis, and hydration it doesn't play any role in improvement in that. Ideally, we should avoid it if possible. N-acetylcysteine, there's a mixed evidence, but as of now, the study which was published in NAGM has clearly gone against it. The PRESERVE trial, the IV NAC is not recommended. Sodium bicarbonate has shown no clear superiority. Statins have some benefit in coronary procedure, but still requires further data. Contrast volume should be kept. The contrast volume as per the EGFR ratio should be less than 3.7. Once the patient has developed contrast-induced nephropathy, the supportive care should be given, avoid nephrotoxins, and do dialysis as per the indication of acute kidney injury. There is no point of doing dialysis to remove the contrast. This is one thing very important. We just need to do the dialysis as per the acute kidney injury. This PRESERVE trial was a 2x2 trial, which was a randomized control trial, and it has clearly shown that the NAC versus placebo had no benefit, and the sodium bicarbonate as compared to the saline had no benefit. It is the hydration which has shown benefits in trials till date. Thank you. And this is something which we can prevent, and we should be clear about it, and we should identify the patient at earliest and treat it once possible. Thank you.
Sir, one question is there.
Thank you, Dr. Chhabra, for the nice talk. Any questions from audience, please?
Sir, one question is there. You said that contrast-related mishappenings can put the patient for a longer period in the hospital with more expenses, more expenses. Why is it not that a particular procedure that you start in the hospital, a package is given to the patient so that he can go through all the things?
Pardon, sir, sorry, I didn't get it.
Why a package is not given to any procedure so that the long stay and unnecessary
Sir,
expenses
usually the
are borne
packages
by
are given in, specifically if you are actually talking about the cardiac intervention procedure, the packages are
Yeah,
given.
yeah.
But this is something which derails our package. And once we actually have, this is something which we can't predict. We have seen patients being given contrast at the creatinine level of 6 and they have done remarkably well. We have seen patients even at a creatinine level of 1.5 which have developed severe acute kidney injury after the contrast, and because there are multiple other factors which are also interfering to it. Definitely, if we are actually just adhering to the package, sometimes it is getting difficult and we might have a longer stay. And in fact, once these patients are in hospital for a longer time, they have a higher chance of developing sepsis over the time period. Ma'am, as per the data from the randomized control trial, it doesn't help, but definitely since it has no harm, as a nephrologist, we tend to give it, but still we don't have much of the data to support it.
Thank you, Dr. Yogesh.
Thank you.
So, next speaker is none other than Dr. Nityanand Tripathi. He doesn't need any introduction. He is the Principal Director, HOD Cardiology and Electrophysiology, Fortis Hospital, Shalimar. Please.
Seniors and colleagues, and thanks to chairpersons and panelists for introduction. We usually have long differences in the cath lab and in our clinical practice with nephrologists. You have just listened to Dr. Yogesh Chabra. हम लोग अक्सर लड़ाई ही करते रहते हैं कि हमें करना है और कम में करना है, ज़्यादा में करना है, नहीं करना है. We are at a fix. So I think what to do, what not to do. Basically, problem is kidney is important, but heart is equally important as well. In fact, more important. For immediate life, heart and brain is required, but for meaningful life, all organ systems are required. So unless heart is preserved, there is no point in preserving the kidneys. But still, if kidneys are deranged, or creatinine is deranged, and patient goes into acute renal injury or acute renal failure, then life of patient and cardiologist becomes miserable. Both are in a very miserable condition because there is no urine output. Usually, EF is down. Patient starts developing acidosis, and once there is acidosis, the BP comes down, and BP will not come up unless you treat the acidosis. And then we call Dr. Yogesh to help us out, do a dialysis, remove the acidosis, and then he says कि हम पहले बोले थे कि मत करो और आपको ये नहीं करना चाहिए था. So, but still we have to help the patients. This is not for single patient, but we are in dilemma. Patient is in acute coronary syndrome. Patient have repeated chest pain. What to do if creatinine is 1.5, 1.2, 2.5, 3, 3.5, or what to do, what not to do. Once there is a dialysis, then there is a very clear indication that we are not thinking about the kidneys because patient is already on maintenance dialysis. There is no like kidneys or anything for that. So gradually, cardiologists and people have developed the new way to intervene. That is the era of low or ultra low contrast angioplasty. Techniques and technological evidences for zero contrast angioplasties has evolved over a period of time, but it requires a lot of technological backup, and that backup should be in your cath lab. There should be a strong nephrology team who should be backing you up, like Dr. Yogesh Chabra's team, who are backing us daily in and out in our uh, technologies intervention. The magnitude of effect is 78% of the PCI patients and more than 30% of the sick patients do go for a acute kidney injury. In-hospital mortality increases by fivefolds. Accelerated progression into the dialysis. The safe threshold is by rule as advised by Dr. Yogesh was 5 into body weight divided by the creatinine. Modern evidence suggests that the CV-eGFR ratio is the strongest predictor for the mortality and morbidity. The standard of PCI, as Dr. Yogesh said, it should be less than 100. Low contrast PCI, it should be less than 3. Ultra low contrast PCI, our goal is to finish it off in 10 ml of the contrast only. Zero contrast PCI, no contrast PCI, ultra low contrast PCI remains the same. The 3P strategy for ultra low contrast PCI is plan. Pre-procedural hydration is important, and risk scoring is important, where our nephrologist friend do chip into it. And physiology ischemia confirmation by IFR and FFR is important. We don't want to inject any of the dye inside. Imaging guided, like I was guided, or OCT with saline guided coronary intervention is the key factor. And both of the procedures and both of the technologies are available with us. We are doing ultra low contrast and low contrast PCI routinely at our lab. The mechanism is precise fixed volume puff, less than 2 ml, and that to a diluted one. Reduce the total contrast volume by 15 to 20%. Set up injection volume to 2 ml only. Was like mechanism is divert excess contrast reflux away from the patient during the exposure, and this only decreases the contrast volume significantly. We have advanced lab with the of the Philips, where we do have dynamic coronary roadmap. So we take just a single shot, and that shot shows us, gives us the coronary roadmap, and we are following that roadmap in the real time, and we do not require further puff to see where our wire is going or where our balloon is going. We can be just exact about it. The cornerstone of ultra-low contrast PCI is workflow. Lesion length, diameter, and calcium can be measured with the ultrasound, that is IVUS, and post-dilatation stenting, stent sizing can be done with the IVUS. So what we do is we take just one shot initially, take that roadmap, wire it, and then do an ultrasound IVUS. We have co-registration with IVUS, wherein our IVUS catheter exactly shows where we are in relation to our angiogram. And we do go and dilate. After dilatation, we do IVUS again to see whether the dilatation is perfect or not. Then we measure for the length of the stent. Once we put the stent, we do the ultrasound again to see that we have put the stent exactly where it should be, and we are expanded it to a full extent. So once we are confirmed with the ultrasound, and then we do like post procedure injection. So there is only two injections. First, when we are starting the procedure, and second, when we are finishing the procedure. During the hooking the coronary artery, usually people waste a lot of the dye, and we do use the saline, because saline has a characteristic. Once we inject the saline, there will be transient T wave elevation or ST elevation in the ECG. So that is how we check that whether our guide is coaxial or not. We we inject the dye if there is a ST elevation transient ST elevation that says that our guide is inside the coronary arteries. So diagnosis setup, we do a radial or femoral catheter. We choose very carefully, and we scout shoot take one single shoot only, and like why it happens, we already know that wiring preparation and other things. This is how this looks like. So the stabilization and troubleshooting with the dye we do with a very minimal dye. In Mozart trial, comparison is angio guided versus the IVAS guided PCI. Finding is that IVAS guided PCI reduces the contrast volume by threefold. Median contrast is 20 ml or less than that, and clinical outcome is reduced TBR and stent thrombosis very significantly. The DAPT renal data that shows the same thing that is shown by Dr. Yogesh. The data set of 89,000 patients shows that CB-GFR ratio, the risk is less than 2%. If it is less than 1, if it is more than 3, then it becomes 25%. Takeaway is to keep the ratio less than 1 in chip cases. Zero contrast VCI is feasible, and we are doing it routinely. I will show you one of the case. This 55 years male, unstable angina, and came with a LVEF of 40%. You can see significant LCX and significant the LAD. So after doing this first injection, 1 or 2 injections, quickly we took the IVAS, and rest of the things are done by the IVAS. This is the pressing the stent. IVAS again. And once we finished it off, we did the IVAS. Once we are confirmed with the IVAS that everything is fine, we put the second stent into the left main, IVAS again. So we are not injecting any dye here. And after confirming it, we came out with a good result. So to conclude, paradigm shift is contrast is a toxin. It should be minimized as much as possible. Skill set is necessary. Proficiency in IVAS OCT is mandatory. Those people who are doing it day in and day out, there it can be managed, the patients with a high creatinine. And final message is save the kidney and save the life, but you save the heart, but along with save the kidney and save the life as well. Any questions and comments? Most welcome. Thank you.
Dr. Tripathi?
Sir, what about blood urea instead of creatinine in contrast cases? Any measurement required?
Pardon?
Blood urea.
Blood urea?
Yeah.
Urea we are not concerned with, because urea does not reflect the kidney function. In fact, it reflects your hydration. So if urea is high, that means the patient is underhydrated. So he should be hydrated. Sir.
Dr. Tripathi, one of my friends got PCI done this year, and his creatinine came back to normal after 4 weeks. And third and fourth week, he was very much worried. So how we should counsel such patients that your creatinine will come back to normal on third and fourth week, especially in this case?
So most of the times, if creatinine has to rise, it rises between 3 to 5 days and come back to normal within 14 days. But some percentage of the cases, like those patients who have creatinine level of more than 2, there the coming back may not be possible in 3 to 5% of the cases. In fact, in these cases, so there the role of this low contrast PCI comes. In angiogram, we take only 3 shots. One in the RA caudal, where we see the left main bifurcation, LAD and LCX. Second one is in LAO cranial, where we see the left main ostium and LAD complete. Third is in LAO cranial RCA, where we see the complete RCA bifurcation, PTA and PLV. We just take 3 shots only in the angiogram, and then once we move to the angioplasty, we take just 10 ml dye more, and with the IVAS, we complete the procedure in these patients. So the 95 to 98% chances are there that patient will not have any creatinine rise. The patients in whom we have done is like 3.5 to 4 creatinine, and none of them had creatinine rise significantly.
Okay. Dr. Tripathi, in your presentation, you mentioned that you are using ultra short methods for the patient of CKD stage 3 and 4. So may I know what is your experience at your center? What are the long-term complications of these patients?
See, these patients, like patients with diabetes, are very, they have very aggressive disease. Likewise, the kidney disease have patients with the CKD have very aggressive coronary artery disease. They are very likely to have the multiple calcified lesions and severe lesions as well. Likewise, if there is a combination of CAD, diabetes, CKD, and hypertension, this becomes more accelerated. So there are very frequent dilemma that patients have significant angina or severe angina. Still, we are not intervening. And once we are not intervening, these patients goes into the ischemic cardiomyopathy. Once the patient is in ischemic cardiomyopathy, the life becomes even more miserable for him. The BP comes down. The renal, nephrologists do not touch it because once they go for the dialysis, the BP will drop down again. So we need to necessarily intervene these patients to take them out from this vicious cycle.
Thank you.
Thank you so much. If
Hello.
there are no questions and comments.
The next speaker is Dr. Sudhanshu S. Parida. He will be enlightening us on redefining the future of angioplasty. Dr. Sudhanshu is a principal consultant, cardiology and structural heart, Fortis Hospital, Shalimar. He did his MBBS and MD medicine from AIMS, Delhi, and DM cardiology from GB Pant Hospital, Delhi. Welcome, Dr. Sudhanshu.
First of all, good afternoon, everyone, and respected seniors, dear colleague, and thanks, Dr. Tripathi, for inviting me for this topic. And I'll talking about this new game-changing technology that comes in the field of coronary artery disease, that is in the PCI. And this I'll discuss about the stent. Everybody knows that there are a lot of drug-eluting stent has been implanted in many of the patients in coronary artery disease, but stent that disappears is one of the newer technology that has been coming into play in the recent time, and its benefit and what are the advantages we would like to discuss. So first of all, coming to the Indian CAD population, as you know, as compared to the Western world, we have 3 to 4 times higher incidence prevalence, and as compared to Japan, that is in the Far East, we have the 20 times higher than the as compared to the Japanese populations. That means India has the highest risk of coronary disease compared to the other countries. And you can, if you see this from 1990s to 2023, in the span of 40 years, India has witnessed a tectonic shift within the 30 years of CAD among the Indian under the age of 50 years. That means young MI, young CAD population is increasing alarming rate. In the same time, the evolution of PCI called as a percutaneous interventions. For the first time, the innovation has been started in the 1977. It's called as a plain balloon angioplasty. That is one of the game-changing innovation in the field of the coronary artery diseases. But at the same time, it has a lot of drawbacks, and one of the drawbacks includes that high rate of restenosis, like 30 to 40%, have the target lesion revascularization as compared to the not doing anything. At the same time, it is also the limitation of the acute vascular closure leading to the myocardial infarction. So after the invent of the 10 years after the POVA, the first BMS stent was implanted. Although the restenosis rate was decreased, but it is still in the higher range, that is 10 to 20% of TLR was there. So because the cause of this restenosis was the neoantiplatelet proliferation, to mitigate this problem, the DES has been introduced in the early 2000s. So it is high, but at the same time, it has also the drawbacks, like it is higher incidence of stent thrombosis compared to BMS in the first generation DES, that was in 2000 or 2005-6. For this, they have introduced the thinner struts, the second generation disc, but these also have the limitations. To overcome this limitation, currently there are two generations of the bioresorbable scaffold. That is the next revolution in the PCI. The first generation of bioresorbable scaffolds comes in the 150 micron strut thickness, and everybody must be knowing about the name of the Absorb stent that is implanted in the mid 2000s, and the newer one, the latest of the bioresorbable scaffolds coming into this market. Currently, we have one of the product that is the Miras 100 that is completely degrades in 2 to 3 years. So these are the new scaffold systems, and it comes in the new revolution in the field of management of coronary disease. So, but why we need this? Why we need this? Need this the bioresorbable scaffold. That means what are the disadvantages of this stent, or called as a metal case problems? Because in drug-eluting stent, we have the permanent foreign body that has the potential for the chronic inflammation and impaired vascular functions. It comes with the I think these slides have some problems, and just to elaborate with, so these are the problems that, like, the second problem is the lead stent thrombosis. It is in one of the rare but the serious complication occurring years of the implantations, and as there is a metal present all throughout your life in the coronary arteries, that leads to the impaired vasomotions. Because the stented segment loses its natural ability to expand and just one. So the problems are that I've already mentioned. These are the impaired vasomotion cage vessels. So I'm skipping the slides. So to overcome this, we have the current Miras 100, that is a sirolimus eluting BRS system, that is bioresorbable scaffolds. It comes with a hybrid cell design, and it has a scaffold of backbone of the poly L-lactic acid, that is 100 micron strut thickness, and it is an advantage of the optimal side branches access, and the estimated degradation of this molecule is estimated 2 to 3 years. That means after implanting the stent, by the end of the 2 to 3 years, we can able to see the normal vessels function as the complete degradation has been occurs. So the next evolution, the leaving, that means the current concept is to leaving nothing behind. So in the initial stage, when implanted, it acts as a support phase, but that is for the 6 to 12 months. It provides structural supports, delivers anti-proliferative drug, just like in DES. It is in the next 1 to 3 years, the scaffold material, that is the PLLA, things gradually degrades and completely reabsorbed by the body. And in the last stage, that is vascular healing phase, the artery is fully restored, regaining its natural function, elasticity, and pulsatility. Though potential advantage as compared to DS in the long-term status, so there is complete resorption, leave nothing behind. Vascular function is restored natural, and there is restoration of the pulsatility and vasomotions. The future treatment, there is no restriction, like the unrestricted access for the future bypass of the PCI. The lead complications, like it eliminates the lead thrombosis risk as compared to this conventional DES. At the same time, if you go for the imaging, it has allows for the clearer and non-invasive follow-up in the imaging modality. These are the potential advantages on this. The next is the roadwork. First, we have already said that the first generation BRS that are come into the market, the name of the Absorb, that is currently have been withdrawn from the many of the markets because they have the thicker struts, leads to the acute scaffold thrombosis, and at the same time there is the technicality of the high low radial strength. For these features, that has been withdrawn from the market. So the current generation, as compared to the first generation, the strut thickness has been significantly reduced, and currently you have the 100 micron thickness. And by using this newer polymer or metals to reduce the that is closer equal to the maintaining the radial strength as compared to the disc. At the same time, it also the improved radial strength, faster reabsorption, and enhanced visibility. So these are the advantages of this current second generation bioresorb scaffolds as compared to the first generation. So, but these are the therapy not to be incorporated in every patient. So every therapy has its own indication and contraindication. So when I choose this modality, so in my practice, where the patient comes, the younger patient, I have to and simple lesion. So we have to give the maximized benefit of the permanent cure, and at the same time, we have to avoid a lifetime with the metal implant. So if you come with the non-complex lesion like simple short lesion, minimal calcification, that it can be significantly given a better prognostic factor as compared to other modality. At the same time, this is not to be used if the vessel size is less than 2.5, so it should be more than 2.5 to incorporate. So scaffold thrombosis has to be minimized. So this BRS implantation often requires the intravascular imaging. So without this modality, we can't, without IVAS or OCT, we can't do this because it is uh, radio. It is not visible in the normal fluoroscopy. So we need a special investigation like IVAS OCT for accurate implantation techniques. So data is numerous. The MIRES-1 trial that has been followed up for the 3 years. So the reason behind withdrawal of the first generation BRS, that is scaffold thrombosis, was nil in this study, and they have found that there is zero scaffold, and rest of the parameters like cumulative mass, cardiac death, MI, IDTLR, non-cardiac, that is more or less equally or non-inferior to the conventional deaths. So this is how it looks in the OCT. In day 0, we have the small boxes like things, that is the scaffold material. Gradually over the year, in the 3 years, you can see there is fully patent vessels and scaffold segment has been completely reabsorbed. The positive remodeling of the lesion site, completely endothelialization of the struts, no malapposition, no strut fractures, or strong evidence of the early degradation of the strut that we can see in the OCT images in the span of 1 to 3 years. So coming back to the cases in our center, we have done a lot of cases of this curve, but in our case, the first case I'd like to elaborate, like we have the patient who has 63 years male, non-hypertensive, non-diabetic smoker, present with the chest for 4 hours, diagnosed with enteral MI, he have 35%, and the CAG was LAD 99%, mild little bit of thrombosis present because after giving the heparin, the 100% was converted to 90. This is the initial angiograph in the RF model and the PA clinical view. We can see there is a proximal part of the tight blockages is there. So the routine angioplasty, we started the pre-dilators of the balloon in the, then we deployed a stent of 3 into 24 mm of MIRES 100 stent. That is, and this is how it looks after the implantation in the OCT, and the completely there is post dilators. For this little bit of technicality, we need to have the better post dilators, at least for 18 to 20 mm of post dilatation required. The one size similar or 0.25 above size. So this is the, and patient is still now for 6 month follow up, no problems and doing well in the. So with this, like to conclude my talk, and definitely this is a newer technology, but we have to be very cautious and where to implant this small this stent, and we have to little bit of planning and pre-dilatation, post-dilatation technicality are a little bit of different from deploying this stent as compared to drug-eluting. But definitely in near future, it will going to be a very good, and lot number of the patient will come into this category where you can implant this type of stent, where you can give up to 2 to 3 years the natural vasomotion to regain its vasomotion as well as the natural artery as compared to the metal that is presently currently in the drug-eluting stent. Thank you all.
Sir, there is a question. Which one is better, BRS or latest drug-eluting balloons?
Every therapy has its indication and contract, as I already told. So if you compare the drug-eluting balloon, it has own indication. It is not been given the superior benefit as compared to the DES, when the artery size is much more, when there is no ISR, because the DCB, as you have mentioned, this is certain indication where there is ISR is there, or we have the smaller artery branches where the DCB is more or less equally good with the DES. But with the larger vessels, DES is always better and always good having the as compared to the DCB.
Any other question? Thank you, doctors.
Okay, thanks a lot, sir.
Next speaker is Dr. Anshul Jain. Dr. Anshul Jain is renowned consultant cardiologist of the area. He is presently attached with Fortis Hospital, Shalimar, and Jaipur Golden Hospital. Welcome, Dr. Anshul.
Very good afternoon, and thank you for a nice introduction. Thanks, Dr. Tripathi, who is my close friend. Now, I have been entrusted with the task of speaking about these stents used for left main arteries, left main stenosis. In the previous session, Dr. Tripathi and his team has shown newer instruments, rotational atherectomy, orbital atherectomy, ELCA, which is laser. So there was a question from the audience, which instruments to use? Well, let us understand that when you do angioplasties, it is meant to open a blocked artery, make way, and then put a stent or a drug-eluting balloon so that the way is open for the blood to go ahead. These instruments, be it rotational atherectomy, be it orbital, be it ELCA, they are just meant to create an opening. They do not impact the outcome of the arteries. So with this small introduction, let us go to the left main disease. So left main is the mother of all arteries. We can understand, and traditionally, this is one disease, left main, which means that patient would have a very significant, extensive disease in his body. Most commonly, the disease is at the ostium. Disease at the okay. So 20% of the times the blockage is at the ostium, 10% times it is at the shaft of the left main, and 70% of times it is at the bifurcation. Treating bifurcation of left main is never easy because there is a lot of illusion about the size of the stents or required. So this is an example. You see that this is a left main, which is disease at the ostium. It's very hard to understand what is the exact size of the stent or balloon required because the disease in left main is diffuse. You can only say there is disease when there is a normal segment to compare. In left main, usually there is hardly a segment to compare. In this second one, you can see a disease in the shaft. And in this one, you can see this is the commonest. This is the distal left main. We have to do intravascular ultrasound or OCT to understand what sort of lesion are we dealing with, what is the calcium, is it fibrocalcific, calcific, or is there a thrombus? And in this case, what I have shown, we have done IVUS. This is the IVUS ultrasound, which shows a tight lesion at the ostium. Here you can see calcium and a lesion with 70% atheroma. And this is a bifurcation lesion, which is pretty tight. Now, these imaging modalities, they help us choose the size of our instruments. Let me point out that imaging straight away adds 50,000 to 1 lakh rupees to the bill of the patient. So the biggest problem in left main angioplasty is trying to assess what is the degree of lesion and where is it present in left main. Because many a times you would have heard that patient has had bypass surgery. After a few years, he's come back and there was no lesion in left main. This is because left main is most difficult to identify on angiography. So what happens? How do you treat the left main disease? So there are only 3 options. Either you have only medical therapy, or you have stents, or you have bypass. So what happens if you have only medical therapy? The survival is only 50% at 3 years. Therefore, a significant left main disease is bad to be treated on medications alone. The median survival of these patients who have significant left main disease is 6.6 years, if they are lucky. This is in contrast to 13 years if you take treatment, be it angioplasty or be it bypass. If the patient has a critical left main, which is more than 70%, then the survival is 62% at 1 year. So 40% patients will die within first year if you leave them on medical therapy alone. This medical therapy I'm talking is complete medical therapy, which will include beta blockers, statins, and whatever you have in your armamentarium. So how do you take a decision? Is it a stent? Is it bypass? Or what for this patient? So best approach is to get your surgical colleagues, talk to them about what mortality, morbidity, complications they expect, then visit with them. This is called as the heart team approach. This looks at the coronary anatomy, the complexity, which is assessed by a syntax score. Syntax score is nothing. It's a very simple app. You just mark it on the, in the app that which part of the coronary tree has lesions, and it scores. At the end of it, you just total the score. And if it is less than 22, then you call it a simple or a non-complex lesion. 23 to 32 is a medium or intermediate lesion, and more than 33 is a highly complex lesion. So a lot number of trials have undergone versus comparing angioplasties versus bypass. And instead of going into the details, let me just give you a small summary. Bypass surgery is extremely invasive. Angioplasty is non-invasive. Bypass, patient tends to stay in hospital for a week or so. Angioplasty normally discharges after 48 hours. Recovery time is about a month for bypass. Shorter stay for angioplasty. Long-term durability is definitely superior for bypass. In angioplasty, you will see that the patient is comfortable. He goes home without cuts. But the restenosis is there, which is about 20%. And you need to repeat the procedures time and again. Cost is involved, which is very important in our scenario. The stroke is higher in bypass, lesser so in angioplasty. It is lesser, but not zero. Patients, they tend to get more MIs with bypass as compared to angioplasty. We prefer bypass in patients who have diabetes or multivessel disease. Angioplasty is less favored in complex triple vessel disease with left main disease. So what are the recommendations? That isolated left main with one vessel disease, which means it would have a low syntax score or it is non-complex, we can go for angioplasty with equivalent results to bypass. If you have left main with discrete lesions elsewhere in the coronary tree, it would again come in simple in a non-complex lesion or intermediate lesion. You can still go for PCI with almost equal results to bypass. If you have left main with multivessel disease, it is highly advisable to lean towards bypass unless patient preference is towards angioplasty. If it is acute coronary syndrome, then bypass is rarely performed. Angioplasty has to be done. You just open the artery and then maybe preserve the patient for bypass at a later date or do angioplasty as a bridge to bypass. In diabetes and left main disease, we try to lean towards bypass, but as the instruments they advance, as the results improve, we can still think of performing angioplasty in these patients reasonably comfortably. Now, which stents? The companies have introduced modified stents. More and more thinness of the struts are being introduced. They have very good radial profile as well as the expansion parameters, in which the three stents which stand out are the Onyx Frontier from Medtronic, Zyne Sierra from Abbott, and Synergy Megatron from Boston. So these are the stents which we use commonly in left main lesions. So take home points. Left main disease carries grave prognosis. Don't ignore it. A sensible patient-centric approach aided with imaging helps in choosing appropriate strategy. CABG should be reserved for most cases with distal left main disease and complex triple vessel disease. Operator expertise and facilities available at a particular center improve outcomes. Ostial and shaft lesions can be managed with PCI. And to end, I would say that patient must be clearly aware of what he is headed for. if you are doing a complex procedure. He should not go with an idea that angioplasty is done and job is over. It would cost him a hell lot of amount of money, and it's a recurring expenditure. Thank you.
Any questions from the audience?
Around 20%. So reevaluation is not done by angiography. I mean, it's rarely done by angiography. About 10 years back, we were doing angiograms for all patients who underwent left main angioplasty. That was the rule. After 3 months, you get them back and to see. But now with these higher quality of stents, I think in last 5 years, we have not done any angiograms to see. We just do a simple stress test or follow the patient symptomatically. Most will do well. And those who develop disease, it is usually within the first 3 months, because left main is pretty, it really requires a lot of instrumentation.
Thank you, sir.
Sir, one question for you. Sir, there is always dilemma between triple vessel disease, whether to go for CABG, or many times, suppose patient is not hemodynamically stable or suffering with the multiple disease. Many times, there is always conflict of interest between a cardiologist and CTV surgeon. What is your take on this, sir?
So conflict of interest always is there. Okay. So nobody wants to leave something which he can do, but at the same time, we are physicians. All of us are physicians. And I'm sure the conflict of interest is about 2-3%. 97-98%, we think about the patient. And most of us who are sitting here, we do tell them very honestly that, look, if you get a bypass, these are the chances of your graft staying open, as you know very well. Venous grafts, 30% close within first 3 months, 50% close within 3 years. So it is not that you have had a bypass, you have done everything. But at the same time, there are so many patients who are actually sitting here, whom I have told that, look, don't go for bypass. We have done stents for them. They are sitting right here. And there are patients who are sitting here who went for angioplasties, we got them out and sent them for bypass. So it's not that. I think we are pretty careful about choosing our patients. But yes, there are cases when patient preference is there. Then we go in for the procedure with the patient.
Thank you, Dr. Anshul. Speaker for the next session is Dr. Amitav Yaduvanshi. Topic is Advancement in the Management of Hypertension, Renal Denervation Therapy. Dr. Amitav. Dr. Amitav is Senior Consultant, Interventional Cardiologist, Chief of the Cardiology, Holy Family Hospital. Welcome, Dr. Amitav Yaduvanshi.
Thank you, sir. Thank you for the invite, and I thank Dr. Tripathi for allowing me to present my talk. So, renal denervation is a new concept that has come up. Actually, it is not really a new concept. It was introduced way back in 2012, 11, 12, when Simplicity trials were done, and it was quite a enthusiastic response at that time. But then there was a trial, Simplicity 3, which caused a little dampening in the enthusiasm. But now, gradually, over the years, technology has evolved and the patient selection has evolved, and now renal denervation has come into a state where it is now recommended in various guidelines. So why do you talk about resistant hypertension? What is resistant hypertension? We all know that hypertension is the largest global risk factor for death, and it can attribute to almost 20 to 30% of all cardiovascular deaths can be attributed to hypertension directly or indirectly. We all know that the control rates of hypertension are abysmally low. If you estimate around 1.4 billion people in the world suffer from hypertension, only half of them are aware of it, and almost 2/3 of them get treated, and only half of them are actually controlled. So if you see the whole population, around only 14% of population is actually treated and under control with hypertension. And even a small decrease in office systolic blood pressure, a decrease of 5 millimeters or 10 millimeters of mercury cause a significant decrease in the cardiovascular outcomes, be it stroke, heart failure, MI, or cardiovascular death. So decreasing blood pressure is very important. But when you talk about decreasing blood pressure, it is often required that patient needs escalating doses of antihypertensive therapy. And as the number of pill increases, the adherence decreases, and that is one of the most important reasons why many of our patients are not controlled on hypertension, because they are actually not adherent to medications. So what is renal denervation? So we all know that there is a overactive sympathetic nervous system, and there is a lot of interplay. How do I? Is it working? It's working, but not. So there is a lot of interplay with renal efferent arteries, which causes changes in the renal vasculature, increased serum renins and renal tubular epithelial cells. Then there are renal efferent afferent nerves, which causes increased stimulation of the hypothalamus, sympathetic outflow up to the heart, kidney, and renal, and the arterial tree is increased, which again all of them leads to hypertension. And when you disrupt this efferent and afferent nerves, it is known to decrease the blood pressure. So this sympathectomy is not a new concept. It is a age-old concept. When it was when we did not have many drugs to control blood pressure, sympathectomy was done, and these were the papers that were published way back in 1940-41. But because of the severe side effects of surgical sympathectomy, when newer drugs came in, it was it 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 went away. So now what we are having is renal denervation, which is a minimally invasive interventional approach to BP reduction. And it is a simple, precise, controlled, targeted radiofrequency therapy. No permanent implants are left, and it is independent of patient adherence. That is, it requires only one-time procedure. So how is renal denervation done? So as of now, there are two devices for renal denervation which are approved by FDA. One is the ultrasound-based device, called the Recor or the Recor Medical or Paradise device. Another is the Medtronic spiral renal denervation, which is an RF energy-based device. So the Simplicity blood pressure device is available to us in our country. So it is a spiral catheter with a special generator, and it delivers radio frequency for renal denervation. And this is the catheter. So it is a 4 French catheter. It has 4 independently controlled electrodes that are arranged in a spiral fashion. And because of the spiral fashion, it can be used in arteries. One catheter can be used in vessels from 3 to 8 millimeters, and it is a non-occlusive catheter, so it protects the vessel wall as well as prevents any ischemia to the kidney. And the RF generator also is dedicated RF generator, which has independent controls for each electrodes. So the power is given separately to each electrodes, and if at any point of time the generator finds that the electrodes are moved or it is not optimal, it automatically switch off power to the generator. The new thing that has developed is we have to analyze and take care of the branches as well as the main vessels. This was shown in this IV study, where they found that if you ablate the branch vessels as well as the main vessels, the outcomes are better. And there is anatomical evidence of destruction of the renal nerves as well as functional evidence of destruction of the renal nerves post renal denervation. So now the question arises, who will benefit from renal denervation? So the the IFU or the device mentions that it is indicated to reduce blood pressure as an adjunctive therapy in patients with hypertension whom lifestyle modification and anti-hypertensive medications are not adequately controlling the blood pressure. Certain contraindications, very small or very large renal arteries, renal FMD, fibromuscular dysplasia. Stented renal artery is a relative contraindication. Big aneurysm, renal artery diameter of more than stenosis is also a relative contraindication. pregnancy or abnormal kidneys are other contraindication. Renal disease is a relative contraindication, and now there are trials in patients with severe renal disease where it has been found to be effective. So as of now, the ACC and AHA hypertension guidelines suggest renal denervation as an adjunctive therapy in patients who are uncontrolled on 3 or more antihypertensive medications, which includes one diuretic. So this is a chart where I'll not go into details because I think the most important thing is these are the 4 categories where it can be used: resistant hypertension, uncontrolled hypertension with end-organ damage, uncontrolled hypertension in patients who are non-adherent to medications, and uncontrolled hypertension because of intolerance to medications. So does renal denervation works? There are multiple trials that have supported that renal denervation do work. There is a significant decrease in the systolic as well ambulatory blood pressure and diastolic ambulatory blood pressure when you compare. These are RDN sham control trials where one was the control group and where sham procedure was done, another was a treatment group, and there was a significant decrease in systolic blood pressure and diastolic blood pressure, both ambulatory and office blood pressure. And multiple trials have demonstrated that even up to 3 years and more than 5 years, the results are consistent. And it is beneficial in all groups of patients, whether it is CKD, AF, diabetic, or prior stroke. Even up to 10 years, there are studies which have shown that the blood pressure reduction is to the tune of 10 to 16 millimeters of mercury after renal denervation. Is renal denervation safe? It has been demonstrated there is no evidence of renal artery stenosis or adverse events. The kidney function, in fact, remains stable. In fact, in some patients, they do improve. And this is the stable renal functions in the global simplicity registry. So what is our experience? So we have various societies are now recommending renal denervation in various conditions. Some of the patients that we have treated. So this is a patient who had polypharmacy and non-compliant. She was a 65-year-old female, diabetic, hypertensive and diabetic for 15 years, had multiple PTCs also. She lives with her divorced son, and the son has long shift duties, so there is nobody to take care of her medications, and she often forgets her doses. Presented with accelerated hypertension, brain with transient left-sided weakness, brain imaging did not show any abnormality. She was on amlodipine twice, 5 milligrams twice, olmesartan 40 milligrams once a day, prazosin thrice a day, aldactone 50 milligrams once a day, metoprolol, and when she presented, she was in accelerated hypertension. She was started on anti-G drip, and you can see that the blood pressures were very high when she started, and even despite anti-G drip, her blood pressure was not controlled. So she was taken for the renal denervation. So this is the catheter that I mentioned. So that you can see the spiral shape of the catheter, and this is the lower side is the remote control through which you initiate the RF ablation, and you can see on the generator there are values of impedance and temperature that are continuously monitored, and you can see the electrode to the parameters were not proper, so it automatically got disconnected. So this is how it is done. So we take care of all the branches as well as the main vessel. And this patient, amlodipine dose was decreased at discharge, and prazosin was made twice daily. So thrice daily is probably a difficult dosing regimen, so we changed it to twice daily. And subsequently after 6 months, again, so this is another patient, a priest who came with postural hypotension, and we again did it the same way. This patient had an accessory renal artery also. So whenever an accessory renal artery is there and it is more than 3 millimeters, you have to take care of the accessory renal artery also. So this patient was also discharged and medication decreased. Similarly, we had another patient. This is not working. Uncontrolled hypertension despite renal artery stenting. In this patient, the ejection fraction had improved from 20 to 50%, but hypertension did not improve. In this patient also, we did renal denervation. And to our surprise, the next day, all her medication had to be decreased, and she was discharged only on 20 milligrams telmisartan and 12.5 milligrams metoprolol, and she was doing fine. So renal denervation is a complementary option for lifestyle changes and pharmacological therapy. There are ways to identify which patients are more likely to benefit. And the renal denervation, the potential is very high. And if you see the labels and the recommendation, almost 30% of the whole population could be actually be eligible for renal denervation. Thank you.
So there is a question.
Thank you, Dr. Aptab.
Do you denervate both the kidneys?
Yes, we have to denervate both the kidneys and we have to denervate the branches as well as the main vessel.
And if a person is having one kidney?
Then whichever kidney is effective. In fact, just a follow-up of what sir has asked, in patients with renal transplant, the native kidneys are left. So in patients with renal transplant, if they have uncontrolled hypertension, you have to do renal denervation of the native kidneys, because the native kidneys, although they are not producing blood, urine, they are still endocrinally active. So we have to take care of the native kidneys if we have a renal transplant patient.
Any other question, please?
I can't hear you.
Sir, how many days stay for this procedure in the hospital?
How many days stay? So we usually keep the patient for 2 days, although it can be a daycare procedure also, because the only thing is it's a relatively painful procedure. During the procedure also we have to give conscious sedation, and patient can have back pain for quite some time. In fact, one of our patients had a back pain for almost a month, and we thought maybe we have injured something, but we got the CT and all done, but everything was fine, and subsequently she improved. So it is a painful procedure. So keeping for a day or two with maybe some tramadol or something is required.
What is the cost of this procedure?
That catheter cost around 7 lakh rupees, and it is a single-use catheter, cannot be used multiple times. So 7 lakhs plus our hospital cost charges around 1.5 lakh rupees.
One more question.
Yeah.
When there is ectopic kidney, can you do for these things?
Ectopic kidney is a relative contraindication, but if the arteries, the course of the artery and the artery size is suitable, then it can be done.
Thank you. Thank you.
How frequently we are doing this procedure?
Sir, we have been doing it. We have done around 7 cases in the last maybe 6 months. The only thing is it's a costly procedure, so gradually people are accepting it as an option. Once the competitor brands comes in, then probably the cost will also come down.
Thank you very much, sir.
Do we have to see that the patient is not going to be disrupted by this procedure as far as function of the kidneys are concerned,
sir,
afterwards?
Yeah, sir, basically, as I mentioned, it has been proven beyond doubt that there is no deteriorating effect on the kidneys. In fact, they have shown that people who had borderline kidney disease, in fact, there was this trial which has just been published. Anybody who has GFR less than 40, which otherwise is still now considered as something where renal denervation should not be done. They did those patients, and they found that the expected decline in the eGFR in these patients was less than what is otherwise predicted post-renal death. So in fact, it was kind of renal protective, because once the blood pressure is controlled, I think the decline in the eGFR will be better.
Thank you, sir. Thank you, my panelists, and thank you, or my co-chairmen.
Thank you, sir.
Thank you, sir. And if I can please invite us for the felicitation ceremony. To the left-hand side, we'll invite Dr. V.K. Kohli, Dr. Rupesh Sharma, Dr. Umesh. We'd also invite our panelists comprising of Dr. Rakesh Diwan, Dr. Ravindra Kumar. And I will also please invite our speakers as well. If you can please join in. Dr. Yogesh Chabra, Dr. Amitabh Yaduvanshi, Dr. Sudhanshu Parida, Dr. Anshul Jain. If you can also please join in. And meanwhile, Sudhanshu sir, actually आपको मैं एक बारी यहाँ भी बुलाना चाहता हूँ, because I have been telling you that we are ensuring and we work towards the fact that we make this conference interesting. So the last session we had a lucky draw, but once again this session we have a quiz for all of you. A quiz which will get you to win some goodies as well. So rules are बड़ा simple है. Sudhanshu आपका सवाल है, and if you know the answer, raise your hand. Don't utter the answer. We will come to you, and if the answer is given is correct, then you give us a thumbs up and we give you the gift. Okay. So so we are here, and my colleague is there. So please go ahead, sir. Ask your question. Mic, podium mic.
I have some simple questions. Probably everyone knows about the things, but like to see who the get luckier one.
So then in
First
that
questions.
Okay.
Which of the following is the most significant advantage of OCT over the, as you know, the current PCI's trend or the OCT IBS we do in the most of the cases. So
Okay.
like to have getting knowledge about
So
this OCT IBS.
so this is like the एक minute रुको. Fastest finger first. She was the first one who raised her hand, so I'm going to let her answer. If it's incorrect, then we go there.
Ability to image without contrast dye or blood.
Advantage, I have significant advantage of OCT over IBS.
Okay, so A is correct or not?
No.
No. Okay.
The
so
answer
this
I'll
one-
be
No, that is the second one, sir. D. He was the second.
D is the correct answer because as compared to the IBS, the
Then
OCT
that's
has
the
the
right.
high resolutions. So that is the correct answer.
All right, correct, sir. Congratulations. So, sir, this becomes like a fastest fingers also. So, she was
So
the
this is a
first one who
simple
raised her
ECG
hand.
quiz. A 35-year-old man present with the palpitations. He has been drinking heavily with the friends over the weekend. This is his ECG. Kindly give the diagnosis based on the ECG finding.
Okay, the first person who raises your hand, we'll
The
come to
ans-
you.
Sorry.
No, please carry on, sir. Carry on.
You have to give the direct answer.
Yes. Wait.
Anyone?
Okay, here. I have Amit Gupta. What's up?
This should not be allowed to the.
He's not allowed? Acha, he's not. Sorry.
Sir.
No, you're not allowed. Sit down. Yes, sir. Please.
Sir, question, sir.
Actually, the first, we will take your answers, but sir, abhi कहना नहीं गलत या सही because that gentleman was the first one who raised his hand. I
You
saw
have to give
sir.
the correct diagnosis as well as the reason behind this diagnosis.
Sir. So, Dr. Sudhanshu is here. He was the first one who raised his
Okay.
hand.
Sir, atrial fibrillation.
Wait, we have to give the complete diagnosis. Chalo, partially it is atrial fibrillation with fast ventricular rate.
All right, so we should give it to him, sir?
You can give them.
Yeah, all right, great. Congratulations, sir. Congratulations. Thank you very much. Next question.
So the question is the identified the modality. So one of the So these are the choices. You can look at the choices and gradually go back to the slides.
OCT.
OCD is the correct answer.
All right, well done. Yeah, thoda, you can congratulate this guy by giving a round of applause. Come on, the gentleman deserves
So
it.
next question on the IVUS. IVUS creates the cross-sectional images of the coronary artery using what primary physical principles?
ये तो सबने आंसर दे दिया सर फिर गिफ्ट किसको देंगे अच्छा पहले इन्होंने भी ये बोला पर अच्छा वो बाद में बोला
IVUS is equivalent to ultrasound and definitely the answer is a reflection of high frequency sound waves. That is the principles. And another question is what is the specialized functional test that is often combined with the image guidance to determine if a lesion is physiologically severe enough to warrant stenting. But before stenting, if you want to know the physiological test, then what is the correct answer for this?
Okay, so ma'am raised her hand once again. C.
C. C. No, it's wrong.
Fractional flow reserve.
That's the correct answer. This is the fractional flow because this is the FFR modality. We invasive modality to know whether the lesion is significant or not. So what is the characteristic feature of the OCT that necessitates flushing of the artery with saline or contrast during image acquisition? As I have one of the slides, we have the OCT images. So on what principle this has been utilized? You can choose from the any of the topic.
The gentleman in the hat was the
I
first one
got
who raised
B.
his hand.
B.
Otherwise, we'll come to you, sorry. एक second, sir.
D. It's B because the OCT depends on the infrared rays, and for that we need to scatters blood. For that we need to flushing of the blood flow. So what is the primary characteristic of the plaque that typically indicates a need of specialized pre-treatment such as rotational atherectomy? Because a lot of topic has been discussed in this.
Yes, the lady in the denim jacket, please.
B, significant dense and circumferential calcification.
Yeah, that is the correct answer because we need rotational atherectomy where there is calcium is very high. Which imaging
सुधांशु सर बस बहुत सारे हो गए अगली बारी हाँ बहुत सारे हो गए बहुत
Okay,
6-7 हो गए थैंक यू सो मच थैंक यू कम ऑन लेट्स थैंक सुधांशु सर फॉर सो मेनी क्वेश्चंस हमने तो 5 बोले थे सर ने बोला हम बहुत सारे पूछ लेंगे सबको विनर बनाएंगे थैंक यू सो मच सर सो काइंड ऑफ यू and Sudhanshu sir, if I would also request you for the felicitation ceremony, if you can please join in. Meanwhile, in the interest of time, ladies and gentlemen, we will go ahead further. और मैं आपको याद दिला दूं कि there are still lucky draws and of course lot of quizzes that we'll keep doing post lunch as well. So all that is still there. But meanwhile, the next session that we are getting in is titled as the device-based therapy. Now this session primarily will be it'll be moderated by Dr. Satpal Yadav and Dr. S. Rajan. If I can please invite both our fine chairpersons to please join us on the chairperson desk. On the panel, this time we have 3 panelists. We have Dr. Manish Mittal, Dr. G.P. Kelly, and Dr. G.P. Kaushal. I will invite all 3 of them to also please join us on the panelist table here. And once again, the format remains the same. I will hand it over to the chairperson whenever they're ready to kindly invite our speakers, and we'll follow the same. Post this, we will also have the inauguration ceremony, post which we'll get into the lunch. But over to the chairperson, sir. Yours.
Hello everyone. So I am inviting the first speaker of this session, Dr. Sudhanshu Shekhar Parida. He is Principal Consultant Cardiology and Structural Heart Disease at Fortis Hospital, Shalimar Bagh. He is MBBS MD Medicine from AIMS, DM Cardiology from GB Pant. I invite Dr. Sudhanshu.
Good afternoon, everyone, and thank you for patience sitting over here, and thank you, Dr. Tripathi, again for inviting me to give you the topic on this another newer technology, another newer game changer in the field of now this time in the field of the pacemaker, that is the CRMs. So my topic is discussing it's about the leadless pacemakers. So as you all know, the pacemaker has been evolved since from 1970 to the current time with the miniature sizes of the pacemaker has been decreasing significantly, but the 2 important components, that is the pacemaker lead and pacemaker generator, has been associated with a lot of complications. So what new technology do you have current times? So my topic of discussion is no wires but no worries, the invisible solution to the pacing technology. The traditional transvenous pacemaker has the 2 important components, that is the pacemaker that is implanted just below the intraclavicular area in the left side or right side, and under the leads that has been incorporated inside the venous system that is implanted in the ventricles. So, but the limitations often limitations are that the recovery often requires the upper arm movement restriction to the prevent lead dislodge in the initial days, as root 2 component is the main component in the any pacemaker system, but it comes with its own weakness, hence it is called as actually seal. So when you come to the generator pocket that is implanted just below the clavicular area, the noted complications like hematoma, infection, erosion. So nobody want this type of complication when implanted the transvenous pacemakers. But the ratio is somehow bit there, but we have to go beyond this. At the same time, the disadvantage of leads, these are the fragile wires that is running through your veins, and many times it got lead fracture, uh, leads into the insulation break, and many times it leads to the venous thrombosis, obstruction, and in fact, the disease of the source of this wire-induced endocarditis. So these are the complications that can, whether it can be preventable or not. If you eliminate these two factors, then we can able to decrease the complication rate by the large number of the patients. So there is definitely this in a complete, at current time, we have a complete self-contained pacing units, generator, battery, electrode, all incorporated in the single unit and directly implanted inside your heart. That is called as a miniaturization miracle. So this is how the pacing evolution has been there. In the 1950, the first pacemaker, external pacemaker has been evolved. And the same time, you can see the size of the pacemaker. The current times we have the era of the nanotechnology where the size matters, and the smaller the size, then that is more friendly. And currently we have also come into the picture the leadless pacemaker, that is the one of the smallest size pacemaker that is present in our current times. But the concept of the leadless pacemaker was not new. It was first in 1970 it was postulated, but it took long, 2008 or 2009, that long more years for this to be incorporated inside the human heart, and so it is the game changer in the field of the pacing technology. What are the advantages of this leadless pacemaker? First, it has zero lead related complication. As we have already told, the lead has been eliminated and directly incorporated inside this RV. So it eliminates the risk of the lead fracture, failure, endocarditis. That was all eliminated. As we do not have the any generator just inside your subclavicular area, that means it also has the zero pocket infection risk, and the restriction of movement is on that is been able to mobilize after 5 minutes of this implanting the pacemaker, because it is totally intracardiac. And the last and the most important was the aesthetic comfort. You don't want to see a visible lump inside the skin, inside just visible outside of the skin. For this reason, it is very aesthetic and very comfortable. So coming out of the long-term complication, definitely the overall complication rates are significantly reduced by this leadless pacemaker. The all-cause mortality more or less equal. The infection, negligible infection, device revision, negligible, but little bit of some amount of more pericardal tamponade with the first generation or first initial stage of implanting. But currently, we do not have any tamponade or with this molecule. With this therapy, the heart failure hospitalization was significant, also lower in the LPM group as compared to the transvenous group. So in the evolution of this leadless, so currently we have two leadless pacemaker. One is AVR, one is Micra. In the meantime, in future, we also have the different pacing modality. We can have the leadless pacemaker surplus ICD. That means the compactness has been gradually improving. At the same time, the pacing location, vascular access, that has been also improving to give the best quality of life to the patients. So these are the two models currently available in the market. One is the Micra VR or AV, that is one of the smallest, and in fact is the smallest pacemaker currently in current times. And another is the AVR VR. It is also one of the leadless pacemaker, but a little bit of more bigger size than as compared to the Micra AVR. So question is the target. Who benefits the most? The first in the primary indication includes where it can be perfectly fit, like any patient who has the AF with the bradycardia or AF with the chronic AV block. So where we require the VVI or VVI mode, they are the ideal candidate for this therapy to be incorporated. The second indication includes who are the high risk for the transvenous populations, like where the prior infection, where the venous access issues, where we can able to find the venous access, where the future access is needed, mainly in the dialysis patients, where we can need the vascular access. So these are the secondary indication where this can be fit, because here the pocket or lead infection can be prevented. The venous system that block the damaged nerve superior, that can also be prevented. So the tertiary indication definitely who are the frail, elderly, cosmetic for active lifestyle management. This can be one of the primary indications because it is less invasive, is a faster recovery, and it eliminates the chest lump and the scars. So these are the comparison of leadless pacemaker as compared to the transvenous pacemakers. as I've already told the different, many of the topics, they're like vascular access. Definitely it is beneficial as compared to as compared to transvenous. Infection risk negligible or zero, we can say. Heart failure rate also the rate compared to less as compared to transvenous. The definitely cosmetic benefit also there. But at the same time, we should know the where we should not use this as a primary indication, like absolute contraindication for this modality. And because any patient who require dual chamber pacing, who require, because this is the mechanism we implant in the RV, we can't able to uh, pace in the arterial system. For this reason, this micro AV particularly is not suitable for where the dual chamber pacing is requirement. But the newer modality like AVR, they have the two leadless pacemaker implanted. One is RV, one is LV. That is going to mitigate some of this indication of contraindication for this micro one. Where the structural anatomical barriers to implant in the RV, like severe TR, significant congenital heart defects, complex intracardiac shunts, where you can't able to implant this modality. And where we need alternative pacing model, like who needs CRTD, ICT. Currently, at current time, we don't have any uh, devices that has leadless as well as this giving this modality benefit. So another contraindication is implant is access failure, like where we have inability to achieve safe and stable access by femoral vein route, and definitely very small patient, very underweight or very pediatric patient, we don't have any modality to be incorporated at the current time. So data is abundant. This is the 3-year follow-up MICRA CD trial. We can clearly see the complication rate that chronic complication significantly lower. At the same time, device reintervention was significantly lower in the leadless group. And other parameters like patient heart failure, hospitalization were also lower as compared to transvenous. And all-cause mortality is more or less significantly similar as compared to the transvenous. This is the latest study showing the 5-year follow-up data of the MICRA, and here also the all the parameters significantly showing the lower in the leadless as compared to the transvenous. So this is the procedure how you do. We will take the venous access from this. Usually the ideal site is the from this right femoral vein. We'll take the access, then cross a wire, then the pre-dilate because we need the sequential pre-dilatation of the right femoral vein, because we need to incorporate the large device. The bore size is 23 mm. So this is how the sheath is incorporated in. So first the sheath is incorporated in the RA. This is the how we incorporate devices crossing the RA to RV. Then it is usually implanted in the mid or lower septum to avoid the complication like the pericardial effusions. So after we recheck the position of this device in different view, and this is called as in spacer sign, because in the LO view we need to have spacing because to reduce the complication rate. So after that, all the parameters has been checked. We release the device. Then finally we recheck the position of the device in the many view. And finally we treated this. So whenever next time, many times we found an X-ray of this type of picture. So it is a leadless pacemaker that is incorporated. Take-home message for my topic is that there is definitely this is the newer technology, and there is definitely expanding role of this modality in mainly in the bradyarrhythmia management. There are two models are micro VR, micro AV, and AVR VR and AVR dual chamber that has been that presently in market. But you need to have proper planning and the patient selection, because not every patient is a candidate for this micro. And there is definitely low rate of short and long-term complication as evident by the 3 years and the 5-year data. At the same time, there is very low system revision. That means need of the second pacemaker is very low in the 5-year data till now. With this, like to conclude, and any topic you want to. So after incorporating many of the patients in our hospital, we have this giving this mentorship in the different hospitals across the country, and till now we don't have find any complications in other hospitals or in our hospitals. So this is a very safe procedure, but the main concern is you have to choose the right candidate who can be given this therapy as a modality for the bradyarrhythmia management. Thank you.
Sir, there is a question. what is the status? What is the status of incorporating this leadless pacemaker in a patient who has already had pacemaker with the leads?
Who had already the pacemaker because already the lead and that has been, because if we have to change the things, if once incorporated the lead, then with the lead complication has to be there lifelong. So in those subset of the patient, usually leadless patient do not give any more advantage as compared to the lead, because you have already lead inside and that has to be, any complication related to leads has to be there. So we don't give any advantages of that.
But if leads are, if the life of the battery is over a period, then
in that situation, there are new technology where we can extract the leads. If you extract the leads, then you can give the benefit of the leadless pacemaker to those patients. Because on presence of the lead, so we can't have any more added advantage along with the lead with the leadless pacemaker.
Yeah.
The lifespan is
Battery-
gradually increasing. Initial from the first time they were given the 10 to 12 years, but now newer generation devices are there. They are given 14 to 16 years of the life.
14 to 16.
In two modalities, one that's micra, we have to incorporate another devices, because in the lifespan we can give at least 4. But RV such that it can accommodate up to 3 to 4 micro devices. So span of 40 to 50 years you can go. But we can't retrieve this micro one, but the newer heavier one, that is then that can be retrievable there. So we have to incorporate one after another.
And what will be its cost to the patient?
Cost is currently it is around starting with the 16 for the micro AV, and the dual chamber pacing modality, that is 2 devices incorporate, one in RV, one in the RA, that is costing around 22. 22 lakhs.
Okay, thank you.
Ma'am?
This device is MRI compatible?
Yeah, MRI compatible from day one.
Okay.
And till now it didn't find any dislodgement because it is very safe, and we have to reassure before cutting out threads so that it will be implanted deep inside your moderator band or that is muscle bundle. So it don't find any, till now didn't find any dislodgement thread, but if it has to be dislodged, then has to be retrieved through different modality by snaring or something like that.
Sir, what have you told about the development of heart failure in leadless one?
Heart failure, the rate is this is an RB component. So as compared to the physiological patient, the heart rate failure rate is little bit of more, but overall heart failure rate in any pacemaker is 30 to 40%. That, and when you incorporate this in the basal area, like the apex area, the heart failure rate is more. But now we implant this pacemaker in the more septal area. The septal area, the QRS is become narrower. For this reason, the heart failure rate is also very minimal.
That's all. Thank you. Thank you, Dr. Sudhanshu, for such a nice presentation. Our next speaker is Dr. Nityanand Tripathi. Sir, कोई परिचय के मोहताज नहीं है शायद. Sir is the Principal Director, HOD of Cardiology and Electrophysiology, Fortis Hospital, Shalimar Bagh. Sir का अभी टॉपिक है pacing induced heart failure. Is it avoidable or not? Yeah.
Good afternoon. Seniors and colleagues, we have learned a lot about the pacemakers. They have been great in the past. Many decades have saved millions and millions of the life. But everything comes with the riders. Likewise, pacemakers also are not innocuous, not harmless. There is a problem. The LVEF drops to almost more than 10%, resulting in LVEF less than 50% as we implant the pacemaker and time goes by. Incidence in meta-analysis published in 2024 is as much as 12.3% of the patients who had preserved baseline LVEF developed pacemaker-induced cardiomyopathy. Now we have a definite entity, that is the pacemaker-induced cardiomyopathy. It ranges from 9 to 39%, depending on the strictness of the definition and time course. The silent phase is in initial phase. Subclinical remodeling begins immediately once we put the pacemaker. And clinical diagnosis from the putting the pacemaker usually takes 2.4 years on an average. The problem is, you can see in a normal conduction system, there is a impulse formation at the atrium. It is coming down to the His-Purkinje system, getting distributed into the ventricle and the atrium, and the right and left ventricle. It is activating first the upper chamber, upper part of the myocardium, then activating the lower part, and velocity is 2 to 4 meter per second. But when we pace it at the apex, the electrical polarity changes. The activation is from up down to up, therefore leading to the base to apex reversal of the contraction, and then there is a slow conduction from myocyte to myocyte, and that myocyte to myocyte conduction is slow. It's a zero point 0.3 to zero point 0.5. It is almost 8 to 10 times lesser than the normal conduction. An intraventricular delay is more than 40 milliseconds. That gives rise to electrical remodeling, then structural remodeling, leading to the low EF in the coming time. The concept is vested work. Vested work is like dysynchrony. This is the normal loop. The heart contracts and it ejects the blood outside. But what is happening here? The septum is contracting first when the lateral wall is relaxing. Likewise, when lateral wall is contracting, the septum is relaxing. So most of the there is a mechanical dysynchrony. This leads to the wasting of the work or wastage of the energy, and there is a efficiency drop by almost 25 to 30% of the heart. Septal flash is there. This is a hallmark in echo sign that there is a septal bounce that can be easily seen, and those who are doing the echocardiogram here, they must have seen it regularly in their echocardiography. What is the molecular mechanism? Is the dysynchrony downregulates the SERCA2A, that is calcium pump. It results in cytosolic calcium overload, and fibrosis and heterotrophy further ensues. And biomarker, there is elevation of galactine-3 and MP3, resulting in irreversible collagen deposition in lateral wall. Therefore, the myocardium now becomes fibrotic, and myocardium is no longer contracting, but the fibrotic part is not contributing into the contraction. Hemodynamics, there is a mitral regurgitation because of delay in papillary muscle activation. Pre-systolic MR due to the prolonged AV delay. Tricuspid regurgitation is there because there is a lead impingement and annular dilatation, and there is a reduction in the cardiac output by up to the tune of 20 to 30%. There are multiple trials who have shown that if there is a 40% need for the pacing, then there is a significant risk, 1.6 to 2.6 times increased risk of the heart failure in these patients in coming 2.5 to 3 years. The updated references says that it is not 40%. In fact, it is 20%, which is important. And if pacing is required up to 20%, then the patient will land up into the failure. So there is a study which also says that leadless pacemakers that you have just heard is also not safe in free from the heart failure. And transvenous VVI, PCIM, the p value is not significantly different. The mechanism is site of activation, not the leadless or no leadless. So the current trial of this CS spacing has shown that if we pace the conduction system, then this chances of getting heart failure is very, very, very low. And in fact, these are the patients who require the conduction system pacing right from the baseline itself. Those are the patients whose QRS duration is more than 120 milliseconds. Native PR interval is more than 200. Men are higher for the fibrosis, developing fibrosis, and if baseline LVEF is less than 50%, then go for the CS, that is conduction system pacing, rather than the normal pacing. Conduction system pacing versus the CRTD, we know that the conduction system pacing is better than the CRTD, because in CRTD also there is a myocyte to myocyte conduction, and in fact those patients who are non-responders, once we do the CS pacing, that is conduction system pacing, they become responders in these cases. So, first thing first, those patients who have already received the conventional pacing, there we can minimize the RV pacing by decreasing the minimal pacing rate, and allow permission for AV delay like up to 300 milliseconds. The implant strategy should be changed in the in the beginning itself. Avoid RV apex. Gold standard is conduction system pacing, that is H. Purkinje system or left ventricular pacing, alternative to CRTD. Surveillance echo should be done at every 12 months to see what is going on. The cascade of heart failure is triggered by the RV apical stimulation, electrical slow conduction, mechanical by septal flush, and molecular by circa and down regulation and fibrosis, structural by LV dilatation and functional MR, and clinically pacing induced cardiomyopathy is ensured therefore. So we are doing the physiological pacing routinely here. I am a national faculty for this, proctor for this physiological pacing, going to the multiple, even multiple medical colleges and teaching them how to do it. Here we localize the left bundle, and we pace the left bundle selectively. And once we pace the left bundle, the QRS is less than 120 milliseconds in each time. Here, that you can see, here is the lead going deep inside towards the ventricle, the left ventricle, and there are multiple evidences which says that the conduction system pacing is a lot better than the normal pacing in avoiding the heart failure. Data deep dive shows that the QRS duration is related to the LV function, and the lesser the QRS, more good the LV function remains uh, in the longer outcomes. The improvement in electrical and mechanical function lead to the better heart clinical endpoint in these cases. And here is my one case. So in home, we did the conduction system pacing. The EF was 30%, and once we did after 2 months, the EF came back to 45%. There is a lot CRT. I did in Varanasi, 6 years male, 20% ejection fraction post CABG, and this you can see there is flickering. This is left bundle without left bundle pacing, and once we synchronize, the QRS became less than 120 milliseconds. So to conclude, a superior to CRTD strategy is the left bundle pacing if we incorporate with the CRTD. A feasible alternative to H bundle pacing, safe and reproducible. And in fact, this is going to be the future technology for the pacing, because this reduces the heart failure and bring back heart to a near physiological level. Thank you so much.
Any questions? I think no more question. Yeah. Yeah.
So,
Anybody?
if there are no
Anything?
questions or comments, thank you so
Any
much.
comment? Thank you, sir. Thanks, sir. Thanks for a nice presentation. Now I will. Sir.
The next speaker is Dr. Amit Gupta. Sir is from Fortis Hospital, Shalimar Bagh, and I'm happy that he's from my college only, Government Medical College, Patiala, and has done his postdoctoral from Dayanand Medical College, Ludhiana. Amit will be speaking on device-based therapy for low ejection fraction, preventing sudden death. Dr. Amit, please.
Good Good afternoon, everyone. The topic for my presentation is device-based therapy for heart failure. Topic for my presentation is device-based therapy for heart failure patient, prevention of sudden cardiac death. Heart failure is the leading cause of high cardiovascular morbidity and mortality. Despite advances in guideline-directed medical therapy, patients with heart failure, particularly with LVEF less than 35%, are at high risk of lethal arrhythmia, mainly ventricular arrhythmia. Implantable cardiovascular defibrillator plays an important role in management of patients with heart failure. An ICD can detect this arrhythmia and treat with anti-tachycardia pacing, and if this is unsuccessful, they can defibrillate. Thus, by treating life-threatening arrhythmia, an ICD can prevent sudden cardiac death and improve survival and decrease mortality. So, who needs an ICD? There is primary prevention and there is secondary prevention. Secondary prevention candidates are those who have survived sudden cardiac death, who have episode of sudden ventricular tachycardia or ventricular fibrillation. Okay. So, who are the candidates of ICD? ICD can be given as primary prevention and secondary prevention. So, secondary prevention is given in those patients who have survived sudden cardiac death, who had sustained VT and VF. Sustained is defined as greater than 30 seconds in duration, or VT which is hemodynamically significant, or the patient who had sudden unexplained syncope that is inducible in EP study. Primary prevention ICD is given in the patient who had structural or electrical heart disease, which have increased risk of sudden cardiac death, but they do not have episode of cardiac arrest, syncope, or sustained VT. So, what does the guideline say? In patients with ischemic heart disease who have survived sudden cardiac death or who had episode of spontaneous monomorphic VT, if the cause of VT is due to revascularization, then patient should be assessed for revascularization and revascularization should be done. Otherwise, if ischemia is not the cause of VT, then patient should be assessed for ICD therapy. And if he is the candidate for ICD, then ICD should be implemented. Otherwise, patient should be started on guideline-directed medical therapy. If the patient of ischemic heart disease has syncope and it is due to cardiac in origin, and if LVEF is less than 35%, then he is candidate for ICD. Otherwise, if EF is not less than 35%, then EP study can be done. And if the patient has inducible VT on EP study, then ICD can be implemented in such a patient and it is class 1 level of evidence. Or otherwise, if there is no VT, then patient should be maintained on extended monitoring. Mind you, the ICD is implemented in those patients who has life expectancy of greater than 1 year, and in ischemic heart disease, the patient should have MI greater than 40 days. बंद हो गई. Now coming to primary prevention of sudden cardiac death in patient with ischemic heart disease. Primary prevention in patient with ischemic heart disease having LV ejection fraction less than 40%. First of all, look at if the patient has MI less than 40 days or revascularization less than 90 days. If that is the scenario, then patient should be started on guideline-directed medical therapy. If started on guideline-directed medical therapy, then if the patient is high risk, patient can be also given wearable cardiovascular defibrillator also, that is class 2 indication. In certain high risk patient, if patient can also be subjected to EP study, especially in the presence of NSVT that is of longer duration, and if the VT is inducible, then patient can be given ICD therapy. If the MI is greater than 40 days in duration or revascularization is past 90 days, and if the patient is of class NYHA class 2-3 symptom and EF is less than 35%, then he is candidate for ICD. If the patient has NYHA class 1 symptom and EF is less than 30%, then also is class 1 ICD patient. Uh, in patient who have ejection fraction less than 40% and who has non-sustained VT or indisposable VT or NCD, on EP study, such patient can also be given ICD. Otherwise, such patient can be subjected to guideline-directed medical therapy. If the patient is on class NYHA class 4, then he is candidate for advanced heart failure medical therapy. Now coming to secondary and primary prevention of sudden cardiac death in patient with non-ischemic cardiomyopathy. In patient with non-ischemic cardiac myopathy who are sudden cardiac arrest survivor who had sustained VT, such candidates are candidate for ICD. This is class 1 recommendation. Uh, if they don't have VT or sudden cardiac arrest, but they have arrhythmogenic syncope, that is cardiac in origin, then they can be subjected to ICD therapy also. Otherwise, if etiology is uncertain, then EP study can be done, and if on EP study we can induce VT, then ICD can be given. For primary prevention in non-ischemic cardiomyopathy, if the patient has class 2-3 symptom, heart failure symptom, and EF is less than 35%, then ICD can be given. If the patient has a new diagnosed heart failure less than 3 months in duration, then patient should be given guideline-directed medical therapy. And in high-risk cases, wearable cardioverter defibrillator should be given, and patient should be reassessed for LVF greater than 3 months. And if LVF is less than 35% and patient has class 2 or 3 heart failure symptom, then ICD can be given. Now summarizing class 1 indication for primary prevention in ischemic and non-ischemic cardiomyopathy. If the patient has NYHA class 2-3 symptom and LVF is less than 35%, then it is class 1 recommendation to put an ICD. And if the patient has NYHA class symptom and NYHA class 1 symptom and EF is less than 30%, then also patient can be subjected to ICD therapy. And in case of non-ischemic cardiomyopathy, if the patient LVF is less than 30%, and NYHA class 1 symptom, then ICD can be put in such patient. For NYHA class 4 patient, heart failure therapy should be implemented. So now coming to cardiac resynchronization therapy, patient with heart failure who also have QRS duration greater than 120 milliseconds due to bundle branch block, IVCD or RV pacing have electromechanical dyssynchrony. Dyssynchrony refer to impaired mechanical contraction due to impaired electrical activation of heart. Electrical dyssynchrony can be identified by prolonged QRS duration on ECG. But the rationale for CRTD? In patient with left bundle branch block, IVCD, RV apical pacing, there is replacement of rapid symmetrical contraction by this Purkinje system by slow myocardial conduction. This results in LV dilation, decrease in ejection fraction, and increase in mitral regurgitation, which increases heart failure and mortality in the patients. Now, what is CRT? CRT is the treatment of heart failure appropriate in the setting of sufficiently depressed LVEF and electrically dyschronous ventricular contraction. In CRT, the septum and the lateral ventricular wall contract simultaneously, producing improvement in left ventricular stroke volume. In CRT device, there are 3 leads. One lead is placed in right atrium, other lead is placed in RV, and third lead is placed in left ventricle via the venous system, coronary venous system, that result in pre-excitation of left ventricular wall. CRT produces a narrowing of the QRS complexes as the right ventricle and posterolateral ventricular wall are placed in synchrony to produce better left ventricular output. CRT system may include ICD protection, that is CRTD, or just provide pacing therapy, that is CRTP. CRT improves symptomatic status and survival of the heart failure patient with left ventricular dyssynchrony, but still there is 30% non-responder rate of the patient who do not respond to CRT. Looking at this, this is the looking at the left. This is the parasagittal short axis view of the patient who presented with low EF. In this, you can see that the septum, anterior septum contracts before than the posterior lateral wall. This results in LV dilatation and depressed ejection fraction. On the ECG, on the left, you can see there is left bundle branch block in this patient. After implementation of CRT, you can see that there is synchronous LV contraction. There is decrease in LV and diastolic volume and improvement in ejection fraction. The EF has improved from 30% to 55 to 60%. On the ECG front, after implementation of CRT, the QRS duration decreased from 160 to 125 milliseconds. How can you know the patient has implemented CRT? On ECG, you can find out that patient has CRT by looking at lead 1 and lead V1. In lead 1, if LV is stimulated before, then you will find Q wave in the lead 1, and in V1 there will be RBB pattern if the patient has been implemented with CRT. So CRT, application of CRT has improved quality of life, has reduced heart failure hospitalization and reduced mortality, particularly CRTD. There is also reverse modeling and greater than 50% decrease in end-diastolic volume and increase in ejection fraction. There is no increase in myocardial oxygen demand with use of CRT, despite improvement in systolic function. So what are the indications? Who are the candidates for CRTD? Patient with QRS duration more than 150 milliseconds with LVV morphology with LVEF less than 35% are class 1 indication for CRT implementation. These are the latest guidelines for CRT implementation. The patient with LVV with EF less than 35% with QRS duration greater than 150 milliseconds and NYHA class 3 to 4 symptom, ambulatory class 4 symptom should be implemented with CRT, and the patients with QRS duration less than 120 milliseconds should not be implemented with CRT because they will not get benefit from this. Summarizing, primary prevention ICD most precisely established in advanced ischemic and non-ischemic cardiomyopathy. It is based on ejection fraction and functional class. For ischemic cardiomyopathy, before implementation of ICD, one should wait for 40 days after MI and 3 months before PCI or CABG. CRT indication are based primarily on ejection fraction, LVB morphology, QRS duration, and NYHA functional class. Thank you.
Thank you, Amit. Very nice presentation. Any questions from the house regarding this?
Sir, what about cost of ICD and CRT?
Cost of ICD is about 5 to 6 lakhs and CRTD is about 9 to 10 lakhs.
Any questions from the house? Thank you.
Thank you. Thank you.
With this, we conclude this session.
Thanks, sir. Thanks a lot of all.
I said if you have any closing remarks, otherwise we are done, sir. Thank you. All right. Thank you. Thank you very much. I'll invite our chairpersons and our panelists to please join in for the felicitation ceremony, sir, on the left-hand side. And I will also invite our speakers for this session to also please join us for the felicitation on the left-hand side. And I see Dr. Tripathi is already walking for the same. Okay, so meanwhile, as we had promised, it is once again time for a quick lucky draw. And just like last time we did it, exactly the same fashion. You are the winners, you are the pullers, aap pull kijiye, and we will have multiple while we have the session. Sir, do the honors, sir. We'll do this quite quickly so that I have more to give away. Dr. Arun Kumar Yadav. Sir, please, if you can please step up. Dr. Arun Kumar Yadav, please, sir, if you can join us here. Ashish, sir, will help you. If you can please come in. Meanwhile, I'll go away. And Modi sir, please, sir, pull out one. अच्छा, अब वो नीचे से अगले वाले निकालेंगे.
Dr. Hitesh.
Dr. Hitesh, चले गए. Oh, क्या बात है. If he's here, please call him. Please invite him. I will wait for him if he's here. Dr. Hitesh. Okay, he's gone. Dr. Hitesh, chalo, I'm going to keep this here. and meanwhile come to the end. Sir, if you can do the pleasure for us and take out one more for me. Kaun aage, sir? Dr. Hitesh, sir, please, if you can be here. And meanwhile, I also have Dr. Sanjay Kumar Gupta. Dr. Sanjay Kumar Gupta. Dr. Sanjay Kumar Gupta. Sir, if you can please. Dr. Sanjay Kumar Gupta. हाँ सर घुमाओ मैं तो पूरा आपको मैंने इसीलिए आपको दे दिया कि यू डू द ऑनर नहीं तो फिर वो हमेशा ही रहता है यार अच्छे से यार इधर शेक नहीं हुआ था सो नाउ यू कैन शेक इट एज मच एज यू लाइक एंड द विनर इज सर आप पूजा है ओके डॉक्टर पूजा यस इट कुड बी डॉक्टर पूजा मैम इज इट यू डॉक्टर पूजा ओके ब्रिलियंट अरे इनका भी निकला है हितेश का भी ठीक है डॉक्टर पूजा प्लीज मैम if you can step up right here. All right, so I'll ask some more. Let me go this side and request you to say, you know, everybody's confused to, yes, if you can read the name, say the name.
किशोर किशोर ही समझ आ रहा है
Kishore. Okay, it just says Kishore, I think Tuteja. Yeah, Juneja. Tuteja, yeah, Juneja, I'm not sure, but Dr. Kishore, okay, he's not here. Any one of you, ma'am, if you can do the honors and pleasure for us. The winner is Dr. Jaipal Singh. Dr. Jaipal Singh. Dr. Jaipal Singh. नहीं है? अच्छा चलो ठीक है. लो सर, लो, please pull it out. दो रात एक मिनट तो निकालो ना सर निकालो ये लो आई कीप इट हियर ऐसे नहीं ये तो कुछ ज्यादा ही हो गया 5-6% कह रहे हैं इसमें मेरा निकला कि नहीं ये बताओ डॉक्टर एक और डॉक्टर संजीव कुमार हाँ प्लीज डॉक्टर संजीव कुमार हाँ एक मिनट कौन डॉक्टर संजीव कुमार सर बिकॉज दिस इज द सेकंड वन इफ आई कैन प्लीज रिक्वेस्ट यू टू वेरीफाई द फोन नंबर ऑन दिस वन प्लीज you're the winner sir please you're the winner sir वो पिछली बार नहीं निकला तो अभी कुछ खास नहीं हो सकता but you have to wait and now I'll take this away and bring it to you sir please pull it out हाँ तो अगला वाला आप और नीचे से निकालना हरमनदीप नहीं हरमन लग रहा है सर ये हरमन है ना हाँ Harmandeep, yes, please step up, sir. Harmandeep, sir, please step up. लो विकास सर आप भी निकालो अच्छा हो गया he's done okay all right please join us in ladies and gentlemen let me remind you कि ये luck thank you so much can I please entrust all of us to give in a round of applause to all the lucky draw winners for this round But one thing for sure, we've got 20 more to go. Okay, we've got 20 more lucky draws that will be pulled out. And we also have 50 early birds. 50 early bird goodies that we'll also be announcing post-lunch. But before we get to all of that, as Dr. Tripathi had earlier mentioned that unlike the regular, this time we want to have the lamp lighting ceremony just in the middle so that we have maximum and all of us to be a part of it. So this is precisely what we want to do at this point. I will start by inviting Dr. Tripathi and his team to please join us near the lamp lighting ceremony. And if I can also, we will, though we will invite and request all of you to be a part of this ceremony, but specifically, could I also please be inviting Dr. Vikas Sharma, Dr. Amardeep Sachdeva, Dr. Manish Mittal, Dr. KD, Dr. M.K. Singhal, Dr. Rakesh Diwan, Dr. V.K. Kohli, Dr. Vijay Soni, Dr. G.P. Kelly, Dr. Rupesh Sharma, and any of us who would be, we'll be highly honored if any of us would be interested to join us near the lamp for this ceremony, as this session is all because of us and for us. So please join us for the lamp lighting ceremony. So, gentlemen, ladies, if you can stay with us, right after this, we are breaking for a lunch break for 45 minutes, post which, when we come back, so if you can stay with us for just another 2 minutes. We'll be breaking for lunch for 45 minutes, post which we will still have our special quiz, our lucky draw, and we will also be announcing the name of the 50 early birds who will be awarded, who will be given a small token of our love post the lunch session. So please join us back after 45 minutes right here once again at 3:30. Thank you. slept off. Can I request everybody to give me a round of applause, please? Everybody, if you can still be with me. Thank you, sir. Thank you so much. Thank you, ma'am. Thank you, everyone. So, thank you for being back after this session. The previous session that we had, I'm sure, was very strong and very optimized, I think, from the business relevant, from the patient relevance, and from each of us as we got into sharing valuable insights. We'll continue the same. And of course, the fun factors will also continue. So there are three things that are happening. We are compiling the list of the early birds. There are about 50 of us, which would be given away. There are about 20 more lucky draws to be won. And there's similarly about 20 more questions to be asked as well. So we'll try to space that out as well so that we are kind of still in the energy. But right now, in the interest of time, without any further ado, we'll get into our next session, which is the electrophysiology. And for this session, let me start by inviting the session chairpersons, Dr. Sunil Gupta. I'll invite you, sir. I will also invite Dr. Krishna Kumar and Dr. Vaibhav Garg. If you can all three please join us and head the chairperson's table. Sir, please. Aye. And if I could also please invite our panelist for this session, Dr. Naresh Pamnani and Dr. Pavan Gupta, to also kindly take the table of the panelist here. Thank you very much. Now, continuing in the same memento as you heard and appreciated before lunch, we will once again have the similar fashion as we have the chairperson and panelist here. We will now be following with 4 presenters, each one presenting their own topics, followed by a short question-answer session, which you can please indulge yourself into, followed by a quiz, and then possibly lucky draw and an early bird. But meanwhile, I will head this over and give it to the chairpersons to please take this over from here.
Good afternoon, everyone. This session belongs to electrophysiology of heart. It is a very difficult topic for me. I think most of us are also feeling the same thing. For this session, I invite Dr. Arun Mohanty. He is a senior cardiologist in Gangaram Hospital. He is also heading the unit, is a director of intravascular surgery. Dr. Saab.
Hello. Yeah. So good evening, everyone, and thanks to organizer for this topic. This is a new baby in the market, recently launched. Sodium zirconium cyclocrystal substance is a crystal-rich substance for management of hyperkalemia. So why hyperkalemia is so important? We know we are treating more of heart failure patients. Heart failure burden all over world is tremendous, and India is underrepresented in the data. If you see this is 10 million, I would say it is much more. We are just seeing the top of the iceberg, and we have tremendous data for treatment. The good thing is that we are improving in our treatment modalities, and if you don't treat, the prognosis of this heart failure is quite high, and it is even worse than 5-year survival is even worse than many of the cancer like prostate cancer and certain hematological cancer, where the medical oncology also is making progress. Similarly, we are treating heart failure with guideline-directed medical therapy. It has a tremendous economic burden on the health system. And if you see the mortality in certain series where the treatment was not there, I would say these were earlier data, it's more than 50%. But the mainstay of the therapy are guideline-directed medical therapy. All of us are discussing now, which was not there 10, 15 years back, is 4 pillars of heart failure, which has renin-angiotensin system inhibitor in the form of MRAs or ARNIs or S inhibitor or ARBs, SGLT2 beta blockers. These are the four pillars of therapy, which has not only improved the morbidity, hospitalization, but also reduced the heart failure related mortality, and it has a class 1 recommendation. So what is our goal? Our goal is to treat every heart failure with reduced EF, whether hospitalized or non-hospitalized, with four pillars of therapy, as much as possible, targeting 100% therapy to all at a maximally tolerated dose. There are two terminology. One is maximally tolerated dose has shown benefit, and second, all four treatments should be given. But there are hiccups in that, because all of us we see in our clinical practice, if we see the therapy, unless until if you give for GDMT therapy, then the outcomes are much superior in maximal tolerated dose. But if you skip, then the news is not that good. It's a partial therapy is almost equal to non-treating this patient with GDMT. So that is the catch. So if you see how many percent of our patients are getting GDMT, this is not Indian data. All over world, only 1/3 of the population they get a guideline-directed medical therapy, which is 30% only. 75% of the patients, they are not able to continue maximally tolerated ARNI or eplerenone or aldactone, known as MRAs, because there are many such hindrance. What are the hindrance? Is electrolyte imbalance is one of the leading factor, and that is hyperkalemia. Hyperkalemia is much more higher. When we say it is more than 5.5, we have to think about our ARBs, S inhibitor, ARNI, and MRAs in the therapy. And if you are removing or downgrading or de-escalating the therapy to low doses, your outcomes are not going to be good. So this is always a problem. Not only a problem, once you are giving this therapy to a patient, you have to be very careful to see their electrolytes very frequently. If you are not monitoring, hyperkalemia per se is not presenting to you with any symptom, and the final event is always a fatal catastrophic event. So these are the subset where CKD, heart failure, dialysis dependent diabetic patients are much more at a higher risk. EGFR, lower EGFR at a higher risk again. And if you have a hyperkalemia, the cardiovascular mortality as such goes very high. These are the statistics, it's more than 2.8 times. And if a person develops hyperkalemia, the second hyperkalemia events are also very, very high. And they happen very frequently. That means if a person develops hyperkalemia today, he is at a higher risk of developing a second, and the second comes earlier than the first one, and the third comes even earlier. So one has to get their blood tests very frequently, and they are not usually tested. They are only 6% of the patients are tested for hyperkalemia. So now coming to the therapeutic option, how to treat this hyperkalemia, which is obstructing our GDMT. So if you treat these patients with appropriate agents, then only you can give your patients the benefit of ARNI or MRS. So these are the conventional thing. We know calcium gluconate, insulin, glucose, salbutamol, beta-2 adrenergic nebulizers, and all those things, even bronchodilators. Dialysis removes short-term for hyperkalemia in a very short-term goal. But I'll not go into details of that. We use these potassium binders, very commonly available as K-bind sachet. But this is a molecule which goes and binds the potassium in the colon only, not entire GI tract, and it can cause sometimes a fatal outcome of GI necrosis because of ischemic events to the GI, and this is a very fatal thing. If you are giving with sorbitol, there are high chances of getting a GI necrosis with K-bind sachet. So now I'll come to the I'll skip all these slides because the time is the limitation. I cannot go. Now coming to the newer molecule, we have this wonderful molecule known as sodium zirconium crystal, which is identical to the potassium binding site appropriately, snugly fits into the receptor, and it doesn't changes your magnesium and calcium level in the body. It exchanges sodium and potassium, and very, very highly selective for its for the site, so that it replaces potassium almost 100%. And it works also in the small intestine for potassium binding, also in the large intestine, and exits in the excreta. So entire length of the GI tract, it works to bind the excess potassium and gets out. It is not soluble, it doesn't get absorbed into the body, so there is no side effect of getting into the blood circulation. Now coming to the key trials, this is the first trial, and for K-bind, sachet and other therapy, we don't have a randomized trial. This is a randomized trial, very well conducted. They have given 48 hours, all hyperkalemic patients, those who are more than 5.1 potassium, they have given 10 milligram of sodium zirconium for TID for 48 hours to acutely bring down the potassium level. Then they have randomized to placebo, 5 milligram, 10 milligram, and 15 milligram of SGD crystals, and 28 days maintenance was given. After that, those who were normocalemic, they've extended the follow-up to 11 months to see whether there's a long-term outcome, whether they are better tolerated if you give it for a year, 2 years, whether there is any side effect or not. So this is the primary endpoint, was to see the potassium level and how effectively it is controlling. So I'll not go detail into this. The wonderful thing is that once you give this SGD complex or crystal, the potassium comes to a normal level within 2 hours of therapy, and by 48 hours, even if it is a hyperkalemia of 6, it comes to a baseline. And the primary endpoint, as compared to placebo, even 5 milligram, 10 milligram, or 15 milligram, whatever doses you are using, they are normocalemic range, and you can give your therapy effectively. And this slide says, if you give up to 48 hours, then extends up to 29 days, the level remains the same. If you extend it beyond 29 months, 30 days to 1 year, the effect is same. And this is another study where they have given a practical situation. Hyperkalemic patients, they have given MRAs and sodium zirconium at the same time, and those who are prone for hyperkalemia, they have given this therapy, and they have randomized this patient after non-calemic state, and they have given SGD complex or this this new molecule versus placebo and spironolactone, and now they have followed up for 1 week. One can see, if you are giving this complex, your spironolactone or arni is tolerated by 71% patients. So your heart failure patients can better tolerate this guideline directed therapy along with this potassium binder, and time to first hyperkalemia event was much more reduced. And if you see, the first instance to decrease of discontinuation of spironolactone was practically low, and 63% reduction. So key features of this molecule: effectively controls, normalizes the potassium within 48 hours, 2 hours is the earliest potassium reduction, and maintains up to 1 month. Then in a long term also it is very well maintained up to 11 months. This is very good tolerated. These are the real world evidences, and one can see, if you give these patients sodium zirconium crystals along with ARNI and MRAs, the MRA therapy and ARNI therapy can be tolerated up to 90%, and you need not to reduce your doses, so that you can give the benefit of this wonderful GDMT to these heart failure patients. To summarize, this is a rapidly potassium reducing agent. 9 out of 10 patients continued RAS inhibitors in the form of ARNI or MRAs, sustained potassium control over a time, and generally very, very well tolerated. Thank you for your time.
Thank you, Dr. Arun, for wonderful talk. The next speaker is
one more compound,
Dr.
Petty Romer,
Nityanand
is
Tripathi.
available also. Petty Romer is not available in the market. but theoretically, thank you. Another thing is strict diet control is important. So, thank you. Thank you very much.
May I start? Next speaker is Dr. Nityanand Tripathi, who needs no introduction. But for the sake of protocol, let me introduce. He is a principal director, cardiology and electrophysiology, Fortis Hospital. Dr. Tripathi.
Thank you, sir. Good afternoon, seniors and colleagues, chairpersons, and the panelists. Today, my presentation is management of atrial flutter. We talked a lot about the atrial fibrillation, but we forget that atrial flutter is second most common cardiac arrhythmia after atrial fibrillation. It is commonly associated with atrial fibrillation. If we do not treat atrial flutter, then it might convert to the sinus rhythm or frequently degenerate into atrial fibrillation. It is very unstable rhythm. Exact incidence and prevalence is not known because it is short-lived and commonly associated with the COPD, PAH, CHF, and atrial enlargement. More frequently in males than the females. This is how it happens. This is the normal sinus rhythm, and once it becomes abnormal, then there is a more atrial contraction than the ventricular one. Here you can see there is a sawtooth appearance in the ECG, and this is typical atrial flutter rhythms that is there. And it can be 1:1 block, 1:1 conduction at the 300 rate or 250 to 300, might be 2:1, frequently confused with the T wave where P wave is buried, then can be like 3:1, 4:1, or can be variable conduction. So in variable conduction, if there is a variable conduction, we frequently leave it as an atrial fibrillation because the RRR variable, but variability of RRA is not only criteria to diagnose the atrial fibrillation, rather than there should not be organized atrial activity. In atrial flutter, there is organized atrial activity as well. This is the different echocardiograms. Mechanism is atrial flutter is macro-oriented tachycardia, and depending on type of origin, site of origin, we can classify it as a typical or atypical atrial flutter. Most of the times, it is typical atrial flutter, which originates around the CTA, that is the tricuspid isthmus, and the rhythm initiated in the right atrium and near the tricuspid wall annulus, and its characteristic is persistent negative modulation observed in the inferior leads like 2-3 AVF and patent atrial deflection in lead 1 AVL. If you take the histories, most of the times they are asymptomatic. The common symptoms are palpitations, lightheadedness may occur, fatigue is possible symptoms, shortness of breath, especially during the rapid conduction, or decreased exercise tolerance can be there. The increased ventricular rate may lead to hypertension, syncope, or near syncope. Sudden onset complications may occur like heart failure, tachycardia-induced cardiomyopathy, or potential embolism. On examination, jugular venous distension might be there, and that might be irregular peripheral pulse. The most important evaluation is electrocardiogram, where you can see the undulating waves in 2-3 AVF. Echocardiogram is important to rule out the structural heart disease. Laboratory evaluation is important to know the electrolyte imbalances, abnormal thyroid functions, and other biochemical abnormalities. The pulmonary function test is important to rule out the COPD. So, coming to the treatment, how to treat these patients? To regulate the rhythm and regulate the rate. Regulating rhythm is more important because these might be degenerated into the atrial fibrillation. In acute setting, hemodynamically unstable patients, synchronized cardioversion is the key after treatment. In a stable patient, the pharmacological cardioversion can be tried. The drugs like amiodarone, flecainide, propanol, and verapamil has been tried, but most frequent drug which is used is the ibutylite. The key principle is pharmacological cardioversion is less effective than the electrical one and induced in stable patients with early onset atrial fibrillation, atrial flutter less than 7 days. Class 3 drugs, ibutylite is most effective, but QT monitoring is important because it prolongs the QT, and if QT is prolonged, patient might land up into the VF. The amiodarone is multi-channel blocker. It is safer in heart failure, but patients do not convert into the sinus rhythm immediately, and less of the patients remain into the sinus rhythm. Ibutylite is used in the dosage of 1 milligram IV over 10 minutes. Repeat once needed. Monitor ECG and QT prolongation and for ascites, and contraindication in prolonged QT and low sodium and magnesium situations. So this is very important. This can be given in any of the nursing home or can be given in any of the hospital, and it's a very effective, and it converts into the sinus rhythm in almost 80% of the cases. Rule out the atrial thrombus if it is more than 48 hours of the atrial flutter, and ensure electrolyte imbalance is not there. Efficacy is 60 to 70%. Flecainide amiodarone efficacy rate is very low, so it should be avoided. The pharmacological fails, then consider for electrocardioversion or go for the uh, radiofrequency ablation. Anticoagulation is required in these patients as it is indicated for the atrial fibrillation. Catheter ablation is alternative to those patients who are intolerant to drug or in whom drug has failed or in whom there is a frequent episodes despite being on the drug. It is 100% has a 100% success rate, but 10 to 15% of the patients might revert back to the atrial flutter again. There is no absolute contraindication. Bleeding disorders might be a negative relative contraindication. We map the atrium both left and right if required. Frequently, we map the right atrium and then ablate across the CTA. I will show you my two patients. One is the typical flutter, 65 years male, repeated palpitations, EF 25%, and CAD showed non-critical non-critical coronary artery disease. And this is how we can see that the two fronts are meeting together here, and we ablated along this line, and this patient was cured. This is voltage map for the same patient, and you can see beautifully how these two, the front is originating here, and it is coming down and meeting up to this point. Here we give the legend where you can see the this ball like structure here, and once we ablate it, there is no tachycardia which is continuing there, and patient is fine. His EF improved up to the 55%. This patient was a typical example of tachycardiomyopathy. The second patient was 76 years female, repeated palpitations, developed hypothyroid due to cortisol. On the previous attempt of RFA of AFL failed because that time the operator did the RFA on the CTA line, that is on the right side. And we again mapped this patient from right and as well as from the left one, and ablated from the left side, and this patient become normal. I will show you. You can see this is the right-sided one, and this is the left side. Left side. Here there are 4 pulmonary veins. The electrical signal is originating from here, peaking into the right atrium, and then traveling throughout the right atrium, and circuit is getting completed. We ablated this. We just disconnected this small isthmus through which the electrical signals are traveling, and patient is fine right now. And this I did last 6 months back. Patient is perfectly fine without drugs, and the squadron toxicity has also reverted, though the hypothyroid has not been reverted. So it says on the thyroid medicines. In conclusion, atrial flutter is the second most prevalent tachyarrhythmia. Unstable rhythm either converts into the sinus rhythm or frequently degenerate into the AF. Medical or electrocardioversion is indicated. Rhythm control is far superior than the rate control because in that case, patient is required to be on the anticoagulation therapy throughout the life with the risk of the bleeding. And radio frequency catheter ablation with 3D mapping is the most important modality to cure these patients because this is the permanent one. And a patient might get the second circuit, but that is the rare, less than 10% of the cases. Thank you so much. Thanks for patience hearing.
Thanks, Dr. Nityanand Tripathi, sir, for excellent talk on flutter because it's a very common issue. The patients who are having a multiple comorbidity, especially in the ICU. So, any question from the house?
So beta blocker is for rate control only. So it is not going to control the rhythm. For rhythm control, it is flecainide. Flecainide is too toxic medicine. And amiodarone is very toxic medicine. Almost 30% of the patients goes into either hyperthyroid or hypothyroid. And there is almost 5 to 10% of them have a LFT derangement. Less than 1% of the patient might develop the pulmonary fibrosis. So this is most frequently abused drug in the medical practice because it has multi-channel action. That is why wherever you give it, it acts like a blanket antiarrhythmic drug. But remind you, though there is a least antiarrhythmia which is produced with this amiodarone, still 4.5% of the patient might have arrhythmia because they are taking the amiodarone. This is proarrhythmia, that is what we call it. And some of them might die because of the VTV of this amiodarone. And frequently we are giving the amiodarone to monitor the QT interval. If QTC prolongs beyond 550 millisecond QTC, then these patients are at a very high risk of sudden death because of the tachytis dysphoitis. Some early ectopic will come on R and there will be R and T and patient will die.
Ablation is treatment of choice in athletes and CTI. Is it true? Ablation is treatment of choice in athletes and CTI. CTI.
Yes, sir. It's important and treatment of choice. 3D mapping and ablation.
Treatment of choice.
Yes, sir.
So medical treatment should not be tried.
Medical treatment, this is unstable rhythm. So patient will degenerate into the atrial fibrillation.
Sure. Thank you.
Thank you, sir. So it's a 10% of the patients. See, whenever there is electrical instability, patient will develop arrhythmia. Electrical instability after ablation can happen around the ablation line. The ablation line, we are creating ablation line, that is the fibrosis, going to fibrosis later on. But it's less than 1%, even 0.01% of the patients who develop the arrhythmia because of the ablation line. And patient, once we ablated this atrial flutter, patient can develop VT, VF or anything else because of the secondary regions like if he had CAD or something else.
So no more questions? Yeah.
See, if there is an underlying heart failure patient, then it is even more important that you stabilize the patient and go for the radiofrequency ablation.
Then what's the drug of choice for that?
Drug of choice is like if patient is in heart failure, that means that patient is hemodynamically unstable. Cardiovert that patient, heart failure will improve drastically.
Okay. If the patient is stable but his ejection fraction is decreased,
that is the cardiomyopathy.
But,
Once you control the heart rate, this tachycardiomyopathy will revert.
so for control of tachycardia, can we give sotalol or amiodarone or dophylated
Sotalol and
iodine?
amiodarone can be sotalol is going to restrict the rate. It will act as a beta blocker. Amiodarone again, it will be membrane stabilizing action. It will have a membrane stabilizing action and will reduce the rate because of the beta blocker effect. But simultaneous, there will be a lot of side effects as well. And patients remaining into the sinus rhythm with the amiodarone is as less as 30% or 40% like that.
So no more questions. Thanks, Dr. Nityanand Tripathi, sir.
Thank you, sir, for a very informative and engaging presentation.
For the next presentation, I invite Dr. Ankesh Kumar. He is senior consultant at Fortis Hospital, Shalimar Bagh. Sir has done DM cardiology from prestigious Safdarjung Hospital, New Delhi.
Good afternoon, all. Thank you for nice presentation. Thank you, Dr. Nityanand Tripathi, for giving me this opportunity to talk on this topic. Peeping inside the coronaries, velocity, how it helps the patient. So, sometimes routine coronary angiography are deceptive because what we are seeing isn't always what you get. So, we should get the whole picture. So, imaging help us see the beyond what we are seeing on the coronary angiography. So why this is the right coronary artery angiogram, which show in different views LO and RO different blockage. In LO we can see borderline region of around 6 to 70%, whereas in RO around 40% of the blockage. So sometimes angiography will not give us the correct picture. So why there is a limitation of this legacy tool? Because it's a navigator and routine of vessel, but it doesn't provide plaque structure, vessel wall characteristic and true dimensions. So angiography are essential, but these are deceptive blueprints. So why do angiography fail? Because different angle sometimes gives different severity of blockages. There are contrast, streaming, branch, vessel overlap, and foreshortening, calcification, osteal lesion. These are the artifacts which sometimes misleading on angiography. So we require imaging tools. So we have different imaging tools. CT coronary with the resolution of 600 micron. Angiography will give the resolution of 200 micron. The IVAS and OCT give the resolution of 100, and OCT is the having high resolution of 10 micron. So angiography evaluate the coronary anatomy as a planar silhouette, which gives us the luminogram only, where the imaging gives us the luminogram and vessel wall characteristics and plaque characteristics. So we should have a view from within the vessel. Uh, these are the imaging which shows the different characteristics of plaque and different severity of the lesion. So what is the OCT? OCT is the imaging modality which use the near infrared light for the high resolution imaging for vessel anatomy, tissue microstructure characteristic and strength. So it uses light, not the ultrasound, does not use an X-ray, give the faster acquisition of images. Images requirement are sharp, detailed and easy to interpret. So OCT, we done OCT by passing a catheter over the wire that will give and taking the pullback of vessel will give the imaging of vessel in three layer, adventitia, media and intima. Clearly we can see. OCT also define the plaque characteristics. Either it's the fibrous plaque, which is the bright pixel image, finely textured and homogeneous in texture. And the way is the fibrous plaque, which have dark pixels, low penetration and homogeneous in character, where the calcified plaque have sharp images, sharp edges and thick nodule, kind of heterogeneous on OCT. Uh, OCT also define whether there is a stent positions are correct, malposition can be defined, and that these are the stent is totally under expanded. Sizing of the stent is also can be detected on imaging. So OCT gives the different kind of picture and plaque vulnerability for the rupture in acute ACS cases, thin cap fibroatherioma, which is prone for rupture and result in the ACS patients, microchannels, lipid deposition, and calcium nodules. So pathophysiology of ACS, culprit lesion on OCT. Plaque rupture is the most common pathology in ACS patient, almost resulting in 70% of patient. Plaque erosion, we can see there is a plaque which can erode and lead to the plaque rupture and further ACS. So OCT help us for pre-procedure optimization of the lesion. Will tell us the morphology of the lesion, length of the lesion, and diameter of the vessel. Post-procedure OCT tell us whether there is a proximal distal edge dissection are there, stent position and expansion of the stents, whether under expanded or proper expansion of the stent. So it will help to improve the outcome. Our goal is to achieve the maximum minimal stent area. So what evidence says, current body of evidence says either in the calcified lesion, osteal lesions, CTOs, bifurcation lesion, left main osteal lesion, long lesion, and ISR, There are a lot of studies which give all cases should be do under guidance of imaging. So imaging result in the lower maze, reduce the stent thrombosis, and reduce repeat revascularization, and long-term outcome improve with the imaging. So clinical data of OCT, there are various studies which shows long-term reduced rate of the maze, reduce revascularization, reduce repeat admission due to the repeat stent thrombosis. So ultimate ADAPT DAS IVS Excel trial shows reduce the risk of cardiovascular death, target vessel failure, and MACE over long-term period. So how OCD, I have two cases. So how OCD helps the patient. One is the case where we have done the imaging on angiogram, which was looking the severe lesion. So on imaging, we found there is no significant stenosis, so we avoided the stents. So this is 60-year-old male, diabetic, hypertensive patient, non-smoker, patient had the angina, and patient had cardiac arrest, which was resuscitated and revived. ECG shows LVV, drop were positive. Echo shows severe LV dysfunction of 25%. Patient was stabilized and taken for CAD. CAD shows the significant distal left main osteoproximal hazy lesion. This is the angiogram. This shows the distal left main was diseased, and osteoproximal LAD shows the this the haziness when look like tight lesion on angiography. So we decided to do the imaging. So we took the LCX and LAD OCT pullback. This was the LAD OCT pullback was taken. And this is the proximal LAD to left main OCD tracing. This shows there is a lipid plaque is there, but there was no significant stenosis were there on the proximal LAD, nostril LAD. Left one was okay. This is the three-dimensional picture of OCT. This is the pullback from the LCX. This shows there is a fibrous plaque in the distal LCX. This is a quite normal portion of the LCX. This was the left main. Left main shows some sort of fibrous and calcified nodule were there, but there was this is a calcification were there in the left main, but there was no significant ostial L6 disease were there. So this is the analysis of the LAD pre-PCI pullback tracing, which shows the mid LAD of good area of 12.2, proximal LAD of 6.6, and ostial LAD of 7.26. Left main were 17. So there were no significant blockage were found on the OCD and LAD and distal left main, which was seen on the angiogram. This was the LCX pullback tracing, which shows quite good distal L6 size. There were the slight plaque and less than 50% blockage at the mid LCX. Ostial L6 was quite okay. Left one was okay. So this patient was left on medications without any intervention. Patient is now in follow-up. Patient is okay. So other patient is the young patient who had OCT guided imaging intervention. So this is a 35 or male, non-diabetic, non-hypertensive, non-smoker, without family history of ischemic heart disease. Patient presented with the chest pain of 6 hours, radiating to the jaw left arm. ECG shows ST depression in the lateral lead, drop were positive. Echo shows lateral wall hypokinesia. Patient were diagnosed with NSTMI and patient were taken for the coronary angiography. This was the left side of angiogram. LAD was quite okay. There was some plaque in the LAD. Mid-distal L6 was showing the borderline lesion on angiogram. So we took the OCT imaging of this. This is the OCT of LCX. This shows there is a plaque rupture at the site of the lesion, and that there is almost 70-80% stenosis with the plaque rupture. So this patient underwent is the analysis of this OCT imaging. Distal L6 were okay. Then distal to mid L6 is area of 4.3. This is the plaque rupture area that lead to the ACS to the patient. There was a dissected flap. This is the fibro clot were there in the proximal LCX. So this patient underwent angioplasty to the LCX. The patient was the pre-dilated and taken 2.75, 38 of stent. This was placed, and again OCT was taken to see the whether optimization of the stent expansion or whether there is malposition or there or not. So on OCT imaging we can see whether some of malposition was there. These were the stents were not opposed to the vessel. So again stent post dilated with the higher pressure. This was the result on angiogram with a quite good result after imaging. So my take home is angiography remains the navigator, but it is insufficient for precision. OCT provides the high resolution detail necessary for optimal post-PCI quality control, opposition expansion of the stent. So adoption of the intravascular imaging now just the option. It is the modern standard of care. Translate directly for lower long-term risks for the patient. Thank you.
Thanks, Dr. Ankesh, for excellent lecture on the OCT. So the question is, can we use it in the CKD patients because we require the contrast for this?
Because OCT require a lot of contrast, so another imaging modality, either we should do the low contrast or sometimes we are using agitated saline also. IVUS is where we are not using contrast. So we prefer IVUS imaging in those subset of the patients.
How do we compare OCT with IVUS? Which is better?
OCT is having high resolution but low penetration, where the IVUS has higher penetration, low resolution. OCT we can see the bright, good quality of images, where the IVUS we have dark images. But for the ostial lesion, CTO lesion, and bifurcation lesion, IVUS is definitely better for the OCT. We have to penetrate the cap with the CTO lesion, so IVUS definitely help in those subset.
Thank you, Dr. Ankesh. I'm sure this OCT has been one of the path-breaking invention in intervention cardiology. Our next speaker, I would like to invite Dr. Sumit Niranjan. Is he around? Okay, he's not around. Okay. Then that concludes this session.
Thank you. Thank you so much. I'll invite you to please join us for the felicitation, sir. On the left-hand side, please. I'll invite Dr. Tripathi, if he's here, for the felicitation, please. We'd once again thank Dr. Sunil Gupta, Dr. Abhishek Pachuri, Dr. Amit Singhal, Dr. Naresh, Dr. Pavan. We'll also invite our speakers, Dr. Arun and Dr. Ankesh, to please join us for the felicitation as well. And with this, in the interest of time, as our preceding speaker has to hurry to the next one, so we'll straight away get into our next session, which is the structural diseases. To preside this session, let me please invite Dr. Hitesh Agarwal and Dr. Deepak Agarwal to please take on the stage as the chairperson for this session. And I will also invite Dr. Rachna Kashyap and Dr. Supriya to please take over as panelists for this particular session as we go further. Let me also tell you, ladies and gentlemen, that this session will be preceded by a chat session as well. So stick around, you don't want to miss that very interesting session here. But with this, I will pass the baton to Dr. Hitesh and Dr. Deepak as chairperson to take it further from here, sir. Yours. Please go ahead.
Hello. For this session, I would like to invite Dr. Nagendra Chauhan. He is Senior Director, Intervention Cardiology, Medanta, Gurgaon. Welcome, sir. He'll be enlightening us on aortic valve intervention.
So, good evening, dear friends, and I want to thank Dr. Nityan for inviting me for this wonderful meeting. So, my job is to give you some idea about aortic valve intervention, what we are doing now today. So, things are changing very fast, and now we all know, I think, that TAVR is considered equivalent to surgical aortic valve replacement. And these are the guideline indications for TAVR and SAVR. And you can see even in low risk patient and intermediate risk patient, both are considered class 2A or class 1, which is equally good for all patients. For definitely high risk patient, TAVR is preferred over SAVR, but otherwise also it is a good indication. So all patients who are 65 years and more, this is practically a good indication if there is no contraindication for TAVR. So now we are going more forward toward further things, like this data was only for tricuspid valve. Now we are doing so many bicuspid valves. Now we are doing even younger patients. Now we are exploring aortic regurgitation also and going toward the other routes also. So this is a recent trial published which has evaluated that can we do early TAVR in asymptomatic patients, is it better or not? So what we say is if we don't do TAVR, aortic valve replacement early in patients, then this causes multiple problems. So we have to be cautious in terms of that heart function should not go down. So these are the two trials which have the early TAVR and TAVR and load, which has also proven that if we do early, then chances of LV dysfunction and future problems are much less and outcomes are better. So now the question comes to TAVR versus SAVR. We all know that TAVR and SAVR are the two standard options, but we have to decide which one is to be best for our patient. So most important thing, we have to assess the risk of surgery, risk of TAVR, our experience as we are doing it, and patient choice. All the things are to be decided. So any patient who is frail, very old, definitely he is not a good candidate for surgery. So physical appearance and general diseases like lungs, liver can decide that who is a good candidate for surgery. If he is not good candidate for surgery, TAVR can be done. TAVR's risk can only be decided by a CT scan. So nowadays, what we do, all patients coming to our hospital for aortic stenosis, we first go for a CT scan and then we decide what is best for the patient. So risk benefit is very important. Patient processes mismatch is a major issue. If patient has a small annulus and if you put a very small valve, it is not a good idea. So if surgeon is putting a valve, generally if they are not extending the root in a small annulus, they will put a very small valve. If we are doing a TAVR and coronaries are very low, we can occlude coronaries. So we have to assess all these issues before we decide for the TAVR versus SAVR. So the planning and heart team approach is very important in this. And there are certain situations where still it is controversial and not a first choice. So now the recent trial is there that asymptomatic patient you can do it, but still it is not a first choice because it's not in guideline right now, but possibly it will come in guideline. Severe alveolar calcification, small annulus, very low coronaries, if femorals are not very good, if patient is very young, all these surgery is preferred over TAVR. Otherwise, in all patients above 65 years, what we have to see, there are three major concerns I think right now. One is valve durability. A surgical tissue valve versus a TAVR tissue valve which is crimped, is durability equal or not? Second is if patient has excess which is not very good, what will you do? And third is if patient coronaries are not suitable, or what will happen to him in future once you are going for a second valve. So if patient outlives the life of the valve and you have to put a second valve inside the first valve, then it's a major challenge. So multiple company of valves are available now. So these are some examples which are available in India now. There are more which are available now. This is slightly older slide, maybe 4 or 5 are now. So multiple companies are coming and everyone is pushing for this therapy. So we should decide what is best for the patient. Durability issue is not that important because many trials have come which has shown that surgical valve durability is generally considered to be 10 to 15 years, and TAVR valve durability is shown to be almost equal. You can see 13.9 versus 12.5 or 2.7 versus 1.8. So no major difference in terms of durability till now for up to 10 years data. The major advancement in this is now there is a dry tissue valve available which can live even 15 years. So possibly in near future we will have no issue of durability. The valve will last longer for life. But till now we have to assess that patient, if outlives the valve life, then what will happen to him? Second important issue is about excesses. So now we do TAVR in many patients in which femoral arteries are not very good. Like this is an example. So what we need is a good femoral access for valve to go inside. what we need is at least 5.5 millimeter the size of the artery or the femoral artery so that we can go inside. But you can see here that some places artery size is very less, 2.9 versus 3.3, 3.36, 4.9. So here the valve can't go inside. So in this patient, what we have done, we have gone from the subclavian artery and the tower was done because subclavian artery was quite big size. Another example, again 76-year-old patient, very high risk, and femorals are very small. But in this case, carotids were quite good. So we have gone with the carotid access, and this is surgical carotid access taken, and with this, the tower procedure could be done without any problem, and patient was saved. So all these high-risk patients where previously surgery was not possible, now there are options available that we can do tower, and even in difficult patient, we can do this also. So this is just an example of patient. Another very interesting example is the patient where all the accesses are not very good. Like all the arteries like carotid, subclavian, femoral, all are very small. So in this now there is a new approach available. You can go from IVC, enter in the IVC in abdomen, make a hole from IVC into aorta. So this is how it is made. So this takes a lot of planning, but you can do this. This we have done a case. So you make a hole from IVC to aorta and go inside from IVC to aorta and then implant the valve. And once you are coming out, you have to seal the close the aortic leak and you can come out. This was done, I think, 5 years back, and patient is fine and surviving. So this is a patient in which nothing was possible. Surgeons have excluded that she is not a good candidate for surgery. But then there are many patients, so we have to decide what is good for patient. So these are few examples. Like if you see that calcium is extending into LVOT, like you can see here, all the cases, calcium is extending to LVOT. These are the high-risk patient for tower. So if you go for tower in these patients, there is risk of root rupture. So you have to decide if patient surgical risk is not very high, then better to go for surgery. If surgical risk is very high, then we have to decide which valve is to be taken. We have to explain to the patient that surgical risk is high and we are still going, the chances are very high. So this is very important. The most important issue now which we are facing is patients who are not so old. So all patients less than 70 years for tower are considered younger patients because they can outlive the life of the valve. Means if we consider life of the valve with 10 to 12 years, a 70-year-old patient can live 80, 82 years, and at that time he may need a second valve. What will happen at that time when you put a second valve inside a valve? So we have to assess the lifetime management. So if you are putting a valve in a younger patient, you have to assess what will happen for his second valve. So this is just an example. This again a case we have done when patient was 60 years. She came first in 2012. This was the first time we were started. The initial valve was in India, and we have done this case. She was doing fine for next. So see, we have done this. So in this patient, the aortic annulus was small. So this is a simple thing that if small size arteries annulus is there, then we have to put a valve which can give us a good surface area. So we have chosen a self-expanding valve. So there are two kinds of valves available. One is self-expanding valve, other is balloon-expandable valve. Everyone has its advantages and disadvantages. These are shown in here that how they fit in. So self-expanding valves are slightly bigger size valves, balloon-small valves are slightly smaller size valves. So there are certain advantages of one valve and certain of others. So in small annulus, we always prefer a supraannular valve. So we have chosen that and we have implanted that valve in this patient. And we thought this was a good job and everything is fine. But patient outlived the valve life. And now she presented after 13 years that valve has degenerated. Now we have to do it again. Now there is a problem. So I will just explain what is the problem. So now this is after 13 years when the valve is degenerated. Then we have done a second tower surgery, the CT scan. And now the CT planning is much more different because what is happening basically is the first valve has a leaflet. So once we put a new valve inside, all those leaflets will be pinned toward the side. So they will obstruct the coronary arteries. So now there will not be any coronary access if you put the valve in a normal position. So this is like this. I will just give you an example. So this is the first valve. So this is what happens here. So what we have to see is that coronary should be filled. So I will just give you an example in this. So this is, I think, a better thing. So this is how we decide that if the coronaries are very low, then it will be a problem. So this is just a cartoon example which shows that what is the coronary disc plane and what is the annular plane. So if we put a valve here, then you can see, then the coronary has to fill. So here there is some space. Coronary can be filled here, but here there is no space. So there is no space for coronary to fill. So if we put a valve here, then it will not be a good idea. We have to put a valve very low. But if we put a valve very low, then the previous valve will also be there. So there will be two valves hanging, and we don't know what happened to this. So now we are more wise to see that how to manage these patients and how to decide for the first valve. So now this is very important that we should decide for the first valve at the time, and we should think of the second valve after 12 years also. So this is how this therapy is expanding. These are certain other importance that how coronaries will be failed, where the coronary is, how to position it, what is the commissural alignment. So all these things are very important in these patients. So now we know how this works and we can do it. So in this patient, this is done. And finally, we could have a good outcome. And these are the images. You can see there is no gradient. This was the gradient at before 65 between the aorta and LV, and now there is no gradient. So this is important that we should know what happens to the patient. And as a doctor, I can say that now we are more wiser. If this patient comes to us now, possibly we will taken a different decision. We have chosen a small, different kind of valve now. So very important to understand that if we have done a tower, although we can say that surgery is still possible and tower valve can be removed, but it is not easy. The mortality of tower valve surgery is very high. So thinking that we'll do tower now and then after 15 years surgery can be done is not a very good option. So with this, just want to conclude that always remember that whatever we are doing on the basis of trials, and trials have an outcome which says that mortality, the event rate is very low in these patients because the risk is very low. The stroke events in tower versus tower was less than 1%. Success rate was more than 95%. So if we are doing it, our results should match the benchmark. Heart team decision making is very important because it's patient's life. Just doing a procedure is not sufficient. Always consider surgical option if anatomy is not suitable, and always decide about future procedure when we are deciding for the first procedure, especially in younger patients like less than 70 years. And you should select the right valve for right patient at right time so that a second procedure can also be possible. There should not be issue with coronary. There should not be issue with patient processes mismatch. So nowadays, it's very important. Patient's anatomy and patient choice is also important in decision making. So we have to assess all these things, and accordingly, we should decide what is best for the patient. Thank you.
Hello, doctor. Good evening. Actually, when we are going for the resurgery, do we have different types of size that we have to, because next time the surgery will be difficult. So do
if
we
are
have
going for
sizes?
tower, we have different sizes available, but everything depends on patient size. If patient's annulus is small, we have to put a small valve. So that is a more important thing. In surgical things, if surgeon is trained enough, he can extend the annulus. But that is also a problem. No surgeon is extending the annulus, and most of the time we are seeing a very small valve is implanted in aortic valve, and even after surgery, the gradient is high. So this is a major problem because aortic annulus root enlargement is not an easy thing. It is difficult. So most of surgeons are not doing it. Ideally, everyone should do it in a small annulus. Now with advent of tower, surgeons are even doing better jobs because now they know if they don't do a better job, it will be a problem for them. So now many new surgeons are learning how to do a root enlargement, and they are doing it. And it's beneficial for both of surgical field and for us also.
Okay, thank you.
Sir, in overall, the half-life of the
life is also 12 to 15 years, and this life now we have data for 10 years. In 10 years data, they say that life is equal to surgical valve. So this is we are discussing about tissue valve, because tissue valve there is no need for anticoagulation. That's why they are preferred in older patients. That's why we are saying this is for patients who are more than 65 years or patient in his surgery is not possible.
Okay.
For
If
younger
the-
patients, still we prefer metallic valve, which can last for 20, 30 years. But then you need to have anticoagulation. Warfarin is to be taken lifelong.
Thank you, sir.
Okay, thank you, Dr. Nagendra. Thanks for the nice talk. Next, I would like to invite Dr. T.S. Clare. He is Chairman and HOD BLK Max Cardiology. Welcome, sir. Dr. T.S. Clare would like to enlighten us on catheter-based therapy of ventricular tachycardia.
So ventricular tachycardia, I think, is a very important subject for cardiology, because this is one disease which makes the cardiologist nervous most of the times, particularly if you have a fast BP and BP is borderline or BP is going down, and it can produce a lot of anxiety on the part of the cardiologist. So it's an important topic. how can I go forward? I want to go forward. This. Right. So this is how the VT ablation catheter-based therapy has evolved. It was 53, the first time they thought that there was a correlation between cardiac aneurysm and a ventricular tachycardia. And 1956, what they noted that the patient who had VT and they did aneurysmectomy of this patient and VT resolution occurred. Then came 73, so then they started doing aneurysm excision plus myocardial revascularization. Again, it was published that this was a case with a refractory VT. They did both the things, removed the aneurysm and also did the revascularization. It was published. So then came 1979, endocardial excision introduced to treat ischemic ventricular tachycardia. It was first time 1983 when catheter-based ablation was used. Initially, it was a high energy with DC current. So you give DC current to those areas, and it was used in 1983. And ultimately, 1992, when radio frequency was developed, and people started using radio frequency for VT ablation. It was again a paper in circulation. And then after that, 1993 came the current models how to ablate ventricular tachycardia. But ultimately, a revolution in ventricular tachycardia ablation, or even otherwise complex arrhythmia ablation, came in year 2000 when electroanatomical mapping came into the medical practice. For those people who don't know about electroanatomical mapping, this is a system which can tell you three-dimensional wavefront, original wavefront propagation. It can tell you the areas of scar, how a circuit is revolving in the myocardium or in the heart. So this is very, very useful information. These days, practically nobody, no electrophysiologist will be doing VT ablation without electroanatomical mapping. And so it is almost like 20 years of VT ablation. And now when we talk about VT ablation, you first understand that the heart is normal or there is a structural heart disease. They are very different things. Normal heart VT versus structural heart disease are 180 degrees apart. So when we have normal VT, normal heart, the common ones are RV, outflow tachycardia, left ventricular outflow tachycardia, fascicular ventricular tachycardia, whether coming from the anterior fascicle or posterior, or it is a aortomitral continuity. It's called annular VT. It is a very common VT in normal heart. Then you have crux VT, which is called apex VT, and Purkinje triggered ventricular fibrillation and Brugada syndrome. In these, like Brugada syndrome, also the heart structure is totally normal. Now, when we come to VT in structural heart disease, most important is post-myocardial infarction scar. Then you have non-ischemic cardiomyopathy, ARVC, sarcoid infiltrative disease, amyloid, Chagas disease, much more in South America. We don't have in India Chagas disease. Then post-operative scar VT, like you have repaired VSG, there is a scar, so you can have a scar related to ventricular tachycardia. Congenital heart disease, tetralogy fellow, or miscellaneous valvular heart disease, or mitral valve collapse. In nutshell, I can say you one thing, that structural heart, no heart normal, and you have VT. The preferred line of therapy is ablation. We don't believe these days that they should be put on continuous medical therapy. Okay, if somebody had a fascicular VT once in a lifetime, I don't care. Tell them if it occurs again, then we need ablation. But we don't believe in keeping them on medicine for the rest of their life if it's a normal heart. Why? Because the results of normal heart VT are very good. Almost like 90% cases, we can eradicate the ventricular tachycardia. When we talk about structural heart disease, ablation is not the first choice. First choice is the treatment of that disease. Like sarcoid, we put them on appropriate steroid or immunosuppressant and medical therapy. The role of catheter ablation in structural heart disease will come once the medical therapy fails. So this is a clear distinction between these two things. And there have been like a lot of these trials. I showed you the previous slide. This is a SMASH BT. It came in 2007, and it showed that survival-free ICD therapy, free from ICD therapy survival was better with ablation, but overall survival there was no difference. Then came 2010 VTAC trial. Again, BTVF free survival was better after ablation, and in this trial they showed also hospitalization free survival was also better after ablation. And when we talk about VTAC trial of 2010, this is actually preventive catheter ablation. These patients, they did preventive, they mapped these patients, induced the VT, or they saw scar in these patients, they did ablation versus the medical therapy. Here, if you see that preventive ablation was not really very useful if the ejection fraction less than 30%. But patients, their ejection fraction was better, more than 30%. There was a clear benefit of survival free from BTVF after the ablation. And then came the Vanish trial in 2016. Again, here, if you see that this was a trial basically to compare catheter ablation versus escalation of antiarrhythmic therapy. These patients are already on some kind of antiarrhythmic therapy. So then the dilemma is whether they should be switched to ablation or we just add on or change the antiarrhythmic therapy. Here also we show that ablation was superior as compared to escalation of the therapy. But when we talk about probability of survival, it didn't make any difference in this 2016 trial. So primary benefit in the reduction of VT storm and appropriate ICD shocks after ablation. And the same trial to show that benefit was seen only in patients using amiodarone at baseline. So that was an important observation in this trial. And not only that, then there came Berlin trial. Again, preventive catheter ablation versus deferred. In this trial, there was no benefit of preventive catheter ablation. Deferred ablation was better. Deferred means you tried medical therapy. If it failed, then only you go for ablation. No improvement for preventive catheter ablation in this trial. And then the preventive catheter was significant in this. This was a situation that they decreased the ventricular arrhythmia burden and ICD shocks. But overall survival benefit, again, there was no difference in this trial. So, however, preventive catheter ablation was associated with increased hospitalization in this trial. There are those patients that develop more heart failure. I tell you why. Because when you do ablation in these patients, they have extensive scar. So you have to ablate many places. And these are long procedures. Sometimes patient can go to heart failure even during procedure. They are sick patients. So that is why the hospitalization was more in this trial. So then came 2022. These are recent trials. This was a trial, catheter ablation versus antiarrhythmic therapy. Antiarrhythmic therapy was basically amiodarone plus beta blocker or sotalol plus beta blocker. So this trial showed there were similar rates of appropriate ICD therapy, similar rate of total mortality, but there was a reduced in-center undetected ventricular tachycardia. There was a reduced cardiac hospitalization. So then came the survivability trial. This is a randomized. There are 9 centers are involved in this trial. Again, it showed their primary benefit in heart failure hospitalization, reduction in VT storm plus undetected ventricular tachycardia, and also there was the advantage for heart failure hospitalization after VT ablation in this trial. And when we talk about treatment-related adverse effects, and if you show very clearly that antiarrhythmic arm, the complications were much more as compared to ablation. So ablation was relatively superior, of course, because if you do ablation, you can avoid antiarrhythmic side effects because they are not very benign medicine. So treatment-related adverse effects were more in antiarrhythmic therapy versus catheter ablation in these patients. And then came the pause sudden cardiac death trial in 2022. Again, this trial showed that the freedom from composite endpoint was better with ablation, and even the freedom from DT recurrence was better after catheter ablation in these patients, and the requirement of ICD therapy was decreased. However, in this trial, there was no difference in cardiovascular hospitalization and death in these patients. Another systemic review in 2022, a lot of data, so I don't want to go into the depth. And in this trial also, they showed that VT catheter ablation is beneficial in reducing appropriate ICD shock, appropriate ICD therapy. When the difference between shock and therapy, that therapy means it is also anti-tachycardia patient. So both were decreased, VT storm incidence decreased, cardiovascular hospitalization decreased as per this trial. So again, this trial was, these are the numbers. Again, ICD therapy was less in the patient after ablation and fewer hospitalization admissions. This is a very recent data, 2023. Even this showed that there was some mortality benefit in subgroup when we see. So catheter ablation for VT demonstrate lower risk of VT recurrence, ICD shocks, and hospitalization compared to medical therapy. And the subgroup of early catheter ablation, ejection fraction less than 35, but demonstrate even better outcomes in this trial. So I think we can go up to the kind of conclusion. This is the role of in hypertrophic cardiomyopathy. I think there is a topic behind that. In hypertrophic cardiomyopathy also now we do VT ablation in those patients where we cannot control with medical therapy or there are repeated ICD shocks in these patients. And I think I'll go to the last slide in the interest of the time that let me just go to the last slide. There are a lot of examples which I don't want to bore you. These are the in any patient. This is the algorithm. Again, a long slide, and whenever you have a active inflammatory disease in the myocardium, active, that time you should avoid catheter ablation. You should treat them medically. Now, one thing I want to emphasize again, that any ventricular arrhythmia, there's a lot of role of cardiac MRI to understand the real disease, to understand the scarring, to understand if there is an inflammatory process. If you have an inflammatory process, then you have also need to do cardiac PET to understand the activity, how active the disease. If the disease is active, during the active disease, as far as possible, we will avoid catheter ablation. We will treat them with medication, even in VT storm. Sometimes you may have to be forced to do the ablation because there are recurrent shocks. There have been patients, we flew one patient from Kathmandu 3-4 years back. He had 50 shocks in one day. We had to ablate him in the night, and 3-4 years he was any ventricular tachycardia again. So these are very sick patients. This is an interesting slide. I don't know anybody will like to read it. This patient came to us from Middle East with the diagnosis AF ablation, because you see here it's a narrow complex tachycardia and irregular. But this was not a atrial fibrillation. We went to the atrium. There was no activity at all. There was no arrhythmia at all. But this was a parahesian VPC is coming. So this patient we ablated. This is the site to show. And 3 months follow ECG, you see it's absolutely normal. So sometimes AF versus VT, this is a very good case, and the patient is doing very well. This is the example of a 11-year-old boy. He came with VT repetitive episodes, and this slide is a very good slide to understand how to differentiate VT versus supraventricular tachycardia. Many of the physicians will diagnose this ECG as the SVT with abrasion. I can tell you 90 or 80% will diagnose that because it looks like a narrow, but it is not really narrow. Narrow complex means the QRS less than 110 milliseconds. If you measure, it will be 123, 124 kind of ECG. Anything more than 120 is a broad complex tachycardia. In this, I don't know whether there is a arrow. Yeah. See this beat. This is a escape beat. And if you have a escape beat in a tachycardia, it is a 100% BT, and there are some fusion beats. There is AV dissociation. It's a very good ECG to make people understand how to differentiate VT versus supraventricular tachycardia. Anyway, this child also we ablated. It was a fascicular VT from the anterior fascicle, and he done very well. these patients. Again, this patient came with idiopathic VF. This was a patient where there is a VPC-induced VF. So if it's a VPC-induced ventricular fibrillation, you can ablate the VPC, and then you can get rid of the ventricular fibrillation in this patient. So this is how we map these patients. We have looked for the mid-diastolic potential. We do entrainment mapping. So I don't want to go into that depth because there are people who are physicians or they may not have that kind of interest in electrophysiology. A lot of patients, this is 5 years of follow-up, patient did very well. So I think let me just go to the last slide. All these are cases, our own cases. In the interest of time, I'm not going into the details. And now there is something, even ablation in Brugada syndrome. I don't know whether people know it or not. Brugada syndrome is a syndrome with a normal heart. These patients develop ventricular fibrillation. And in the area of the RV outflow tract, we have to go epicardial in these patients, not endocardially. So you get signals there, and that will be arrhythmogenic place. So you ablate that area, and patient can be free from ventricular fibrillation. Of course, still most of these patients we will require as a ICD has to be implanted because sudden cardiac death risk is not eliminated 100%. But yes, you can ablate these patients, and VF can be eliminated in these patients. Okay, so to summarize, VT catheter ablation has become a standard of care for secondary prevention of ventricular arrhythmias. Note that I'm saying secondary prevention of arrhythmias. VT ablation for prevention of ventricular arrhythmia may be beneficial but has some evidence to be associated with increased heart failure. So preventive ablation we don't recommend. Catheter ablation in place of escalation of therapy, it decreases VT recurrence, it decreases appropriate IG shocks, so it's a good idea rather than pushing medicine. Ablation is a good idea. And if your patient is not controlled on 1 or 2 antiarrhythmic, it's a good idea to refer them for catheter ablation. In subgroup population, ejection fraction less than 35%, VT catheter ablation may be associated with mortality benefit. This is a group where there has been demonstrated mortality benefit also. And non-ischemic cardiomyopathy, again, catheter ablation is effective and associated with the moderate success. It's not such a high success as ischemic VT, but even non-ischemic, when you have repeated VTs or patients getting repeated shocks, yes, catheter ablation should be done. But in dilated cardiomyopathy or non-ischemic cardiomyopathy, many times the focus is epicardial. Again, usually we will always go endocardial first, but at least 30% of the patients we have to go epicardial to ablate these patients in ischemic cardiomyopathy. Now, one of the tachycardia which occurs in cardiomyopathy, non-ischemic cardiomyopathy, is what is called the bundle branch reentry. So if you have a bundle branch reentry, usually the ECG will look like either right bundle branch or left bundle branch block. And ablation of one bundle, usually we do right bundle ablation, is curative in these patients. You can get rid of tachycardia. So you should know there is some entity called bundle branch reentry that is more common in cardiomyopathy, not in ischemic heart disease. Again, at the same time, I would like to tell people that we have a conference on 3rd and 4th April. We do every year. This is our 4th version. Indian Complex Arrhythmia Summit and Advanced Cardiovascular Therapeutics. We cover one hall for electrophysiology, one hall for interventional cardiology. So I will request all of you to attend this meeting and we will send you the information. And as nobody alone can do anything great, so I want to thank my team who are part of my group. And these are the people, because of their help, I'm able to do such kind of work. So thank you very much. If there are any questions, I will be happy to answer that.
Sir, actually, I would like to ask how crucial is post-procedure monitoring? And post-procedure monitoring, how crucial is it? And for how long?
Yeah. See, usually we keep these patients just one night after the ablation, and post procedure we have to look at their echoes so that there is no pericardial effusion. Then we have to titrate medication, proper heart failure, those 4 pillars of medical therapy we have applied. The another thing which you should understand is that this kind of ablation is possible only in advanced EP centers. It cannot be done if you know EP, you are a single person, it's not possible. You have to have a team, you have to have an anesthetist in the lab. Many of these patients, all patients will be monitored with lactate levels, with blood pressure, with urine output, and some of the sick patients, you need some kind of left ventricular assist device. Either you do it on kind of impella or you may have to put them on ECMO. ECMO is more useful because in impella you have a catheter in the LV, so that will interfere with your catheter manipulation. In ECMO, at least that problem is not there. So very sick patients, dilated heart, they have come with heart failure, multiple IT shocks, so you have to use some kind of mechanical device. The only thing, the good thing I want to tell you that though these patients are very sick, but believe me, we have not lost any patient on the table. We have lost one patient. Third day, after that, he went into hypovolemia, hypotension, and lactate started coming up. I think some degree of infection, but third day we lost him. But good thing is that we have not lost any patient in the cath lab during the procedure.
Sir, what was the cause of VT with a normal heart in that 11-year-old boy, and what is the chance of recurrence after cardiac ablation?
Right. See, the thing is that most of the patients with a normal heart, it is either after depolarization or it is automaticity. Mechanism is automaticity. It's not a scar. It's not re-entry. It is automaticity. Automaticity in simple terms means that few cells start firing indiscriminately. So there is an electrophysiological mechanism to make you understand, but that is much more complicated. But the thing is that there is no scar in these patients. It's just the cells firing. Even the same thing is after depolarization. Cell, no scarring, but it's a electrical phenomenon.
Thank you, sir. Thanks for the nice informative talk. I would like to request you to remain on stage for the next session, which is a panel discussion. And I would like to invite Dr. Ashish Jayakishan, Fortis Escorts, Senior Consultant Cardiology, and Dr. Arun Mohanty, Director Intravascular Cardiology, Sir Gangaram Hospital. The topic is HOCM treatment and management with Meva Kementum, a game changer, which is a panel discussion. Please arrange for chairs.
Yeah. So good evening, everyone, and thanks, organizer. Again, this is another new molecule. Hypertrophic cardiomyopathy is not rare. It is a very common disease. Genetic predisposition there, and it's autosomal dominant. Though the sporadic cases are also found, and there are more. But unfortunately, they are underdiagnosed, and the first manifestation could be a certain cardiac death or a fatal ventricular tachycardia or VF, as Dr. Claire was explaining us how to ablate a VT. So, on the second disappointment on this is we never had a specific therapy for this disease, though we understood the pathophysiology, but we never had a definitive therapy for addressing to the pathophysiology. So, as I was telling, it's not uncommon, but it's underdiagnosed. Now, the pathophysiology is this is a normal sarcomere myocardial cell where we know actin-myosin binding happens in a myocyte and in any muscle cell, and this is a sarcomere dysfunction. And in a hypertrophic cardiomyopathy, in a simple term, these are non-active actin-myosin filament. Many of them in a hypertrophic cardiomyopathy, these are all hyperactive actin and myosin, which binds in a very aggressive fashion, so that it causes more contractility. At the same time, it causes stiffness to the ventricle. and relaxation is impaired. Once the myocardium is hypertrophied, more contractile, it will require more oxygen, more blood flow. So that's where there is ischemia, injury, scarring, and all kind of ventricular tachycardia, atrial arrhythmias, and all those things presenting with sudden cardiac death. As I was discussing, till now, within last 50 years of hypertrophic cardiomyopathy, we have given our patients beta blocker, which is a non-specific drug to reduce the heart rate, as well as the cardiac contractility as a negative inotropic effect because they are hypercontractile. Calcium channel blocker, non-hydropyridine group like verapamil or diltiazem. The similar mechanism. Diazepamide somehow is a negative inotropic agent, but it's not very effective, non-specific drug. So we never had a specific therapy. This mavacamten is a direct inhibitor of actin-myosin binding pathology. So that's how it's working at the tissue level and the pathophysiological level to give us the answer. So this is how it happens. If you see, this is a normal hypertrophic cardiomyopathy with aggressive binding of actin-myosin. All filaments are binding. Once you give mavacamten, some of the actin-myosins are inhibited directly, and this contractile hypercontractility of the ventricle comes down. Same time, it improves the relaxation and other symptom. It improves the cardiac function, improves symptom, and impact on cardiac structure as ongoing fibrosis never happens. So because of the time, I'll go to two major trials. One trial, because none of the beta blocker, calcium channel blocker were studied in any clinical trial. This is a landmark clinical trial where it is randomized trial with placebo. One can see Explorer SCM. Here there are 251 patients in multiple centers. They were randomized to mavacamten 5 milligram versus placebo up to 30 weeks, and they were followed up for 38 weeks. And there was an extension of this study. Those who were tolerating mavacamten, and they were followed up in a single arm up to 252 weeks. That means more than 3.5 years. So the goal is to see whether acutely it is working or not. Same time, whether if we continue this patient, because hypertrophic cardiomyopathy is not going anywhere. So if you continue this treatment for long term, what happens to this therapy? So the composite was VO2 max, that is mean maximum oxygen consumption and peak exercise, NIHA class improvement in different parameters, and secondary parameters were post-exercise LVOT gradient reduction and baseline gradient reduction, and change from the cardiac biomarkers, and some diastolic parameters were studied like left atrial volume index. I'll skip the inclusion criteria. They were well matched, 123 versus 128. And if you see, they are genetically tested cardiomyopathies in 75%. So it's not a bias to remove the bias of any other hypertrophy. These are genetically tested hypertrophic cardiomyopathy patients. So if you see the result, there will be primary endpoints were reduced. That means the composite of VO2 max and NIHA class improvement happens in 37% in the treatment arm as compared to 17% in the placebo arm. And all these parameters, composite 1, composite 2, that means improvement in the VO2 max and NIHA class improvement were seen with mavacamten. If you see the post-exercise LVOT gradient, which was significantly decreased by mavacamten, that is 47 millimeter. Imagine the reduction of gradient, post-exercise gradient reduced by 47, which is 38. If somebody has less than 50 post-exercise gradient, practically they are asymptomatic. And if it is less than 30, they are practically normal. That didn't happen in the placebo arm. If you see the mavacamten reduced post-exercise LVOT gradient was seen in 74% of the patients with mavacamten, and placebo was 21%. Mavacamten reduced post-exercise LVOT peak gradient below threshold, that is less than 30. By 50% of the patient had a less than 30, which is practically a normal kind of myocardium response. And functional class improvement was 1.4 on the average as compared to nothing in the placebo that is expected. So it is working wonderfully, and change in baseline NaOH class was more than one class was in 65% with mavacamten, and the NaOH functional class improved over follow-up 14 weeks and 30 weeks subsequently. The Kansas City cardiomyopathy questionnaire for quality of life and hypertrophic cardiomyopathy shortness of breath questionnaire were significantly better with mavacamten. And if you see the anti-proBNP, which is marker for heart failure, significantly again reduced by this. I'll take 2 more minutes. And so in 30 days, symptom capacity NaOH class improved. Post-exercise LVOT gradient came down. Exercise capacity was much better. Clinically assessed symptom of NaOH class improved. Self-assessed quality of life cardiomyopathy questionnaires were much better. And the adverse effect which we are really feared of is reduction, because it's a negative ionotropic agent, is acting on actin-myosin binding, so it can reduce LVEF, which was not seen in many patients, though there was 3 or 4 patients, those who had asymptomatic drop in LVEF of less than 50%. That is an indication for discontinuing the therapy or de-escalating the therapy, where the LVEF again regained back to the normal. So this is LVEF chart, which was not significant. This is a late follow-up, extended follow-up up to 3.5 years. You can see the benefit continues till 3.5 years. If you continue, there is no harm in continuing for long term. And their NaOH class improvement over 3.5 year was progressively increasing. More and more patients became class 1 and class 2 from class 3, class 4. These are the biomarkers. I'll go skip. I'll come to another trial, which is a very short trial, Valor SCM trial, which is this is a very interesting trial. There's a crossover trial. These patients were all so symptomatic patients. They were advised septal reduction therapy by alcohol septal ablation or myomectomy as a surgical procedure, because this is the only definitive answer to that. So they were randomized to mavacamten or placebo followed by mavacamten for 32 weeks, and there is a long-term follow-up of up to 120 weeks of mavacamten to see whether giving mavacamten reduces the need for septal reduction or myomectomy. So that's what happened exactly. If you come to the benefit, those patients were on mavacamten, 82% of patients were no more requiring any septal reduction therapy at the end of 16 weeks. So their gradient came down. So by gradient criteria, they were not qualifying for any septal reduction. And mavacamten reduced post-exercise LVOT, again 39 millimeter mercury. And NaOH class similarly improved, like we saw in the Explorer trial. And anti-proBNP cardiac troponin, which is a marker for cardiomyocyte stress, or these enzymes were significantly low. And LVEF, there was no fall in LVEF, significant fall in LVEF at 16 weeks, and long-term follow-up was also similar with improvement of NaOH class and other parameters like LVOT gradient, other things. So to conclude, this is the recommendation we have now. So I would say till now we are giving in diabetics metformin as the first choice. Of late, European Society, American Society, they have given, even if the patient is drug naive, you can start with SGLT2 because enough data is coming. So I'm sure with mavacamten coming into the clinical practice, these beta blockers and calcium channel blockers will not be used in many of the patients, and the first drug to be used will be mavacamten, though it's not cost effective as of now. With time passing now on, we may have cheaper options available, and after a patent, we can extend this therapy to many of these needy patients so that we can give them this drug as the first agent, which is working at the tissue level, improving all the parameters which has been studied in a randomized back-to-back trial. Thank you very much for the time.
So thank you, Arun. This is a very important topic, and it is really a very good addition to our therapy for hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, there are two challenges. One is sudden cardiac death. So you need to assess the risk profile of those patients. The another is symptoms. they remain symptomatic. वो चलता रहता है, बीटा ब्लॉकर दे दो ये, हाँ जी, the symptoms are never relieved very well. So this is a new addition, and I think it will be a very useful drug to be used. But remember one thing, it's not shown to decrease chance of sudden cardiac death so far. So if your patient has a probability of sudden cardiac death, there is a formula to calculate how much the risk of sudden cardiac death. So those patients should be protected by ICD. That's very clear. Now there's another thing I want to comment, because we have a lot of this talk going on in our country. Um,
Each one of you to be here with us. Yes. If I could also please invite the speakers of this session to also please join us, including, of course, our moderators, Dr. Hitesh Agarwal, Dr. Deepak Agarwal, our panelists, Dr. Rachna, Dr. Supriya, along with Dr. Nagendra, Dr. Mukesh, Dr. Arun, Dr. Ashish, if I invite all of you to be here. Meanwhile, ladies and gentlemen, while we have this session going on, a lot of us have been asking us बहुत जल्दी से एक opportunity लेना चाहते हैं to give away these small tokens of our appreciation for you being on time as early birds. So this is what we will do. We will quickly rattle these names. I will call out your name, and if your name is announced, I will invite you to please join us to the front actually, and I will invite you to receive your gift here in the front of the section. Dr. Arun Chabra and Dr. Amadit sir, gentlemen, I will invite you if you can be here to give away these. ऊपर ही कर देते हैं, हाँ, हाँ, वो, it's a pleasure, so please, if you can be here. Quickly, Dr. Saurabh Narayan. So as I call your name, if you're here, just raise your hand and then you can slowly make your way to the stage. Dr. Saurabh Narayan, Dr. B. Lal K, Dr. Sunil Kumar. Sir, please, just raise your hand and then you can easily start walking to the stage and receive your gift. I just want to make a note that who is here so that you can receive it. Dr. Praveen Jain, Dr. Praveen Jain, Dr. Bhaskar Narayan. Sir, please join us in. Dr. Bhaskar Narayan, Dr. Upendra Prasad, Dr. Nishar Ahmed, Dr. Anil Dogra, Dr. Vivek Mang. Sir, please, Dr. Vijay Saini, Dr. Ketan Tiwari, Dr. Mohit Tiwari. All right. Dr. Ravindra Kumar Saran, Dr. Ravindra Kumar Saran, Dr. Vaibhav Garg, okay. Dr. A.K. Diwan, please sir, welcome in. Dr. Anand Agarwal, Dr. Jaipal Singh Chauhan, Dr. Bharat Bhasin, Dr. Kushagar Garg, Dr. Amit Goyal, so of course he has to be here, maybe he might have stepped out. Okay, Dr. Naval Kishore Goyal, Dr. Ashok Kumar Yadav, all right, Dr. Rati Jain, Dr. Amit Jain, Dr. Vijay Kumar Karkam, Dr. Jay Prakash, Dr. Nirat Yadav, Dr. Alka Sharma. All right. Dr. Surendra Sharma, Dr. Pradeep Maurya, Tiwari. Alka ma'am was, of course, here. Yes, there you are. Dr. Kishore Tuteja, Dr. Rakesh Kumar Gupta. All right, thank you, ma'am. Thank you so much. Let me still remind you that we still have the lucky draws that are still pending. This is just the early bird as a thank you, gratitude towards you to be here in time and be part of this conference is wonderful. All those who are receiving these mementos now are the ones who have actually came the earliest and are still here. So thank you so much for your support. Meanwhile, we continue and invite Dr. Ashish Bindal. सर अभी मैम सर अभी थोड़ा सा और है डॉक्टर आशीष बिंदल डॉक्टर अश्विनी साही डॉक्टर अंजलि साही डॉक्टर विजय सोनी सर डॉक्टर अंश शर्मा अंकित अग्रवाल डॉक्टर अरुण कुमार यादव डॉक्टर डीपी शर्मा Dr. Praveen Kumar Jain, Dr. Satya Prakash, Dr. Rohit Goyal, Dr. Darshana, and Dr. Rupesh. Dr. Ruchi Singhal, welcome, ma'am. Thank you so much. Thank you once again. Thank you. Thank you so much. Please join us in. Thank you so much. I think this was wonderful to also wake all of us up and डॉक्टर दर्शना डॉक्टर आप उनके बिहाफ पे ले सकते हैं एंड डॉक्टर संजय मोदी संजय सर तो of course he has been leading our panel the first panel and since he has been here Dr. Supriya Gupta. Supriya ma'am, please. Thank you. Thank you. It is fantastic. Thank you. Thank you, sir. Thank you very much. Thank you, Dr. Vikas, as well. All right. So, ladies and gentlemen, with this, I guess we will quickly get back into action. This also must have acted like a small breather for all of us, just to rejuvenate ourselves. And once again, we express our gratitude for each one of you who has stayed with us for this entire day. But we are sure that whatever happened during this entire day was very productive and informative and a sense of learning for all of us. Now, with this, we want to get into the next session, which is the topic is chronic heart failure. Now, of course, despite all the advanced diagnostics and interventions, chronic heart failure still remains as a topic of concern. And that is precisely what we will be divulging into. The topic that is there for this particular session is CHF, redefining management and improving outcomes. Now, for this session, we will invite the chair to begin with. I will invite Dr. Vikas Sharma to please join in, along with Dr. K.D. Tiwari and Dr. N.N. Jha. If I could invite all three of you fine esteemed gentlemen to please take the chair as the chairperson for this session. Welcome, sir. And on the panel, I would also invite Dr. M.K. Singhal and Dr. Amit Goyal to please join in on the panel of this session. And if I can please invite Dr. Rashi Khare to also please join the panelist here. Welcome, ma'am. And ladies and gentlemen, if I can please interest you to give in a round of applause to our panelist and our chairperson for this particular session. Thank you so much. Yet another very important topic of discussion that we want to divulge into. So I will hand it over to the chairpersons now to please take it over.
Good evening. Good evening. Now we're starting the session, and the first lecture is by Dr. Vishal Batra. He's a professor in cardiology at G. Pant Hospital, very prestigious G. Pant Hospital. And his topic is newer drugs in CHF management. There have been a lot of development in the newer drugs like ARNI, then DV4 emitters, SGLT emitters, and we heard GDMT. So these are things I was going to discuss about these things and newer developments in the congestive heart failure. So I invite Dr. Vishal Batra. Vishal Batra. Sorry. Dr. Vishal Batra, please.
Thank you, sir, for the invitation. Thank you, organizers, for inviting me here for this topic. So, can I have my slides? So, coming to treatment of heart failure, there have been a lot of advances in last decade. So, heart failure has a significant impact on patients. We have a large heart failure population all over the world, and they have repeat hospitalizations and very high mortality over the next 6 months of hospitalization. And the median survival is almost 3 years. And worsening heart failure is one of the important cause of repeat rehospitalization and death. So what is new? What is worsening heart failure? This is new term which we have come across in last few years, which is characterized by development of progressively escalating signs and symptoms of heart failure, which requires intensification of therapy, even IV diuretics, or increase in dose of diuretics, or increase in dose of heart failure therapy, or hospitalization. So why this is important? Whenever we have a repeat hospitalization, the risk of mortality and repeat rehospitalization increases over next 50% in next 30 days. So over the last decade, what all new drugs we have come across in heart failure? In 2014, it was ARNIs in Paradigm heart failure trial. Then after 5 years in 2019, it was the DAPA heart failure trial, which showed SGLT2 inhibitors have a role in heart failure management. Then came Victoria with vericiguat, then empagliflozin, and now omecamtiv mecarbil, which is used for heart failure, still not approved in guidelines. So these are the drugs which we have to treat in heart failure: ACE inhibitors, ARBs, ARNIs. Then comes the beta blockers, SGLT2 inhibitors, mineral corticoid receptor antagonist. These four are the cornerstones or four pillars of heart failure management. Other than these four pillars, we have IV iron therapy, hydrolysine nitrate therapy, then interventions like mitral valve S2H repair, which were discussed in the last presentation, then CRTs, ICDs, and other class 2 drugs like ivabradine and vericiguat. And in the end, LVADs for heart failure. So why these are called four fantastic pillars? Because if we give all four of them, the mortality is significantly reduced. And even if one pillar goes out, the mortality starts increasing. So these four pillars are very important. Even in the CHAMP HF trial, if the patient, most of the patients does not receive all these four pillars of management. If we go retrospectively, only 1/4 of the patient receives all four therapies, and they receive in less than 50% of the target dose. And only 1% patient receive target doses of all three guideline directed medical therapies. We should remember this trial was before SGLT2 inhibitors. So what is rapid sequencing in heart failure? conventionally, what we used to do, we used to give ACE inhibitors, then we used to add beta blockers, then add MRAs or switch ACE inhibitors to ARNIs. But now what is proposed is rapid sequencing. Start straight away with all 4 drugs. Beta blockers are first line because they decrease the risk of sudden cardiac death. SGLT2 inhibitors because they have minimal effect on hemodynamics. Start ARNIs and MRAs. So how to go ahead with this? On day 1, start all 4 of them in minimal doses. Then as we go up, titrate as they tolerate the patient. Within every 1 to 2 weeks, increase the dose first of beta blockers, then go for ARNI, beta blockers and MRAs. SGLT2 has a single dose. So if we start all 4 drugs simultaneously, the relative risk reduction is 73% and absolute risk reduction is 26%. And the number needed to prevent one event is 4. So every 4 patients, we are preventing one event if we start all 4 drugs simultaneously. So what are the potential advantages? How these therapies potentiate each other? So if we give SGLT2 inhibitors, the risk of hyperkalemia is decreased, which is increased with ARNIs and MRAs. There is slow progression of renal dysfunction, which complements ARNIs and MRAs. There is minimal effect on hemodynamics, which is the hemodynamic compromise is there with ARNIs and beta blockers, which causes hypotension. And the risk of hyperkalemia is decreased when ARNI is used instead of ACE inhibitors with MRAs. So delaying initiation of SGLT2 inhibitors or switching from ACE to ARNI needlessly exposes the patient to risk of hyperkalemia and MRA's discontinuation. So it is advisable to start SGLT2 inhibitor as early as possible and switch to ARNI from ACE inhibitors or ARBs. So what about tolerability? Tolerability is also enhanced when all the drugs are started in low doses. SGLT2 and MRAs rarely causes symptomatic side effects, so they can be started initially at the first go itself. And the side effects are also reduced when the all 4 drugs are started in minimal doses. So now coming to neotherapies, which prevents worsening heart failure admission, it came the vericiguate with Victoria trial. It improves myocardial function, ventricular remodeling, improve vascular function, decrease fibrosis and inflammation. So it was started in patients who were in NYHA class 2 to 4 with EF less than 45% on all heart failure therapies and who had an episode of worsening hospitalization. So started with 2.5 milligram OD with a target dose of 10 milligram OD. And the first primary endpoint was either heart failure, hospitalization or cardiovascular death. These hard points were there. And what we saw in this trial, there was absolute risk reduction was 33.6 event reduced per 100 patient years. There was decrease in heart failure hospitalization. So after this trial, it became a class 2B indication from the ESC 2021 guidelines that vericiguate can be started in patients who had worsening heart failure. Then came the Victor trial. What was the need for Victor trial? There is still a residual risk in all these patients who are on these guideline directed medical therapy on all these 4 pillars. This was shown in DAPA-HF trial. So that's why now we need this Victor trial in patients who are still ambulatory and in heart failure patients. So this was published in Lancet. So again, the same dose, 2.5 and target is 10. But the eligibility criteria is a little different. NYHA class 2 to 4 on guideline directed medical therapy with EF less than 40. Even there is no heart failure hospitalization for last 6 months, no outpatient visit or no IV diuretic use in last 3 months, and EGFR more than 15. So these were the stable patients, not the worsening heart failure patients. And again, we studied the same thing, CV mortality and heart failure hospitalization. More than 6,000 patients. Again, they had all comorbidities, CAD, AF, hypertension, diabetes, anemia. And the baseline population was on guideline directed medical therapy. Almost more than 90% patients were on ACE inhibitors, ARB and beta blockers and on loop diuretics. The other therapies in this trial were also equally matched. As compared to other trials, the patients were more on guideline directed medical therapy or on 4 pillars. So what this trial showed, this trial did not show any reduced hospitalization, but it showed there was a decreased cardiovascular mortality in patients who were on vericiguate. So still, it can be the 5th pillar. It can complement guideline-directed medical therapy, and it can provide additional insights into the CV risk and sudden cardiac risk of patients with heart failure, reduced ejection fraction. Now, coming to the next drug, newer drug, omecamtiv mecarbil, which is a mechanical cycle of myosin. What it does, it increases the duration of systole, increases stroke volume. So there is no increase in myocyte calcium, no change in dP by dt, so there is no increase in LVDP. So it also showed decrease in heart failure hospitalization, but there was no mortality benefit. Still has to be included in guidelines. There was no serious adverse event as compared to the placebo. So in summary, what all we have other than these four pillars, we can add vericiguat, we can give them mitral S2S repair, CRTs, ICDs. Ivabradine can be given if heart rate is more than 70. Digitalis can be added if the heart rate is still not controlled and patient does not have any other drugs to complement. Some drugs which are of unproven value, calcium channel blockers to be avoided, not to be given. Hormonal supplements, no role. There is no role of antiarrhythmic drugs. There is clear lack of evidence from vitamin D, thiamine, carnitine, which is used all over the world in many prescriptions. These are to be avoided. They have no role. Even the trial of coenzyme Q was negative. There was no benefit of coenzyme Q in heart failure with reduced ejection fraction. There are some harmful drugs. We should always check of these patients. If they are any of these drug is there in their prescription, it has to be avoided, like NSAIDs, which are very common, thiazolidines, DPP-4 inhibitors, class 1C antiarrhythmics, then many anti-cancer drugs, anti-hypertensive drugs like calcium channel blockers, dihydropyridine, calcium channel blockers. These have to be avoided. Coming to the last role, what is the role of revascularization in patients with heart failure with reduced ejection fraction? So if patient has underlying CAD, EF less than 35%, the data from STITCH trial shows that with optical medical management, if CABG is done, it did not reduce any primary endpoint all-cause mortality, but at 10 years follow-up, it resulted in significant reduction in all-cause mortality, cardiovascular mortality, and death from any cardiovascular cause. Whereas otherwise, if we go for PCI, the revived BCIS2 trial, which was published 2 years back in NAGM, which compared PCI with OMT, did not result in a lower incidence of death from any cause or hospitalization for heart failure. So CABG is still preferred for these patients if they have heart failure with underlying CAD. So this is the flow chart. If targets are good, consider for CABG. If targets are not good, patients still have angina, go for PCI for symptomatic relief, but the improved survival is still not there with PCI. And if the patient is not a candidate for revascularization, go for ICDs, CRTs, or LVADs and supportive care and other guideline-directed medical therapy. Thank you.
Hello.
If there are any questions?
Hello. Sir, one question from my side. What is the role coenzyme or omega-3 and other? You told this, but many doctors are prescribed in cardio disease.
See, there are a lot of prescriptions of these agents, but in trials, they have not shown any benefit.
Acha, about the you said GDMT, 4 drugs. We Vericia, what is can use
So
as
it
a
can
fifth
become
drug?
it can
Fifth
become
drug or can be part of the guideline of GDMT. You can add 5 drugs. GDMT.
It can become, but still hard data is still awaited because the first trial showed decreased heart failure hospitalization, but that trial was done when there were no SGLT2 inhibitors in those patients. It was done before the usage of SGLT2 inhibitors. Now the next trial has not shown any decrease in hospitalization, and it has shown some reduction in mortality. So data is still debatable from these two trials. So I think for it to become a fifth pillar, it will take some more time and some more real world data.
And one of the most common drug, digoxin, has got any role or still?
Only last resort, if no other drug is working, you can give digoxin, but no mortality benefit.
Particularly in AF patients, at times we have added quadrone and beta blockers and dilzem, but still we are not able to control the rate. And we add 0.125 dilzem, and sometimes it beautifully controls the rate. So in particularly AF patients with heart failure, digoxin at times works. We can always try it as a second line therapy.
As a salvage therapy.
Yeah. So, Dr. Vishal, it was a very enlightening talk, simplified to everybody to understand nicely. I would like to ask you, Vericiguat is the newer kid on the block. So, can you just tell us about the side effects, the adverse effects you have seen in your practice till now?
So there are hardly any adverse effects. It's hemodynamically very safe. If the blood pressure is more than 100, you can add Vericiguat. It causes minimal hypotension. Only thing is we have to see the EGFR. If EGFR is more than 30, we can safely give and try to up titrate the drug as it is.
Any comments on the GI side effects? Have you ever witnessed like abdominal discomfort, nausea?
Yeah, some patients do complain, but that is because of Vericiguat per se or abdominal congestion because of heart failure is difficult to justify. So as such,
Because in my practice, I've seen adding Vericiguat, actually patients complain more frequently of abdominal. I even reported it to the company that maybe investigate more on this. Thank you.
Thank you. Next speaker, our Dr. Vikas Thakran. He is a consultant interventional cardiologist at Manipal Hospital from Dwarka. Our topic is device in CHF management. Dr. Vikas Thakran.
Good evening, everyone, and thank you, organizers, for the invitation to this forum. And I'll be speaking about device therapies for heart failure. Rightly, Dr. Vishal has now set the context that 4 pillars, 5 pillars, and still not working. So, speaking about the global burden, in India we have around 10 million population, and this is again a huge number. And we have a mortality of around 0.1 to 0.16 million per year. And we know that these patients are sicker. And how do they differ? They differ that we present at a mean age of 53 years as compared to 73 years in West, and our mortality in hospital is 30% as compared to 4%. And post-discharge, with 6 months, we lose around 26% of these patients. So GDMT has done wonders. So if the patient can be added devices, so how do we approach that? In step 1, we establish the diagnosis of heart failure with reduced ejection fraction, keep the patient on these medications, and see if it is improving, then we continue with the therapy. So before a device, it is said that maybe 3 months GDMT, if the patient is stable enough, has not suffered any life-threatening arrhythmias, then maybe we can give it a medical therapy trial to look at if the ejection fraction improves, and totally we can avoid these devices. But if that is not happening, then we look at how the patient is ECG wise, and if we see that okay, there is a wide QRS LVV pattern, then we advise these patients benefit of CRT, and if not, then ICD can be given. In ischemic, it is not debatable. Maybe CRTD is the best choice, which is the combination of two. But in non-ischemic, we can at times get away with the CRT-P only if the patient has financial issues. If all these efforts fail, then we go to the surgical methods, which is the cardiac transplant, LVAD devices. I will not be touching on that. And rightly, this was discussed that ejection fraction is improved by the therapies. And if you look at what do we have, CRTs, mitra clip. Mitra clip, again, it was beautifully described by Dr. Ankesh in previous talk. I'll be shortly touching it. So my emphasis would be, if the therapy fails, what do we do? Let us understand the mechanism first, because we have these patients which have wide QRS, both LVV and RVV. Left bundle branch block, the evidence is much more established. For right bundle branch, that is as a dire, need. We do it for the patient who is not responding to any therapy, especially when the QRS is more than 150 milliseconds and there is absence of S waves which are likely to respond. So speaking about left bundle branch block, we have, because of that block, there is a lack of AV and V2V synchrony, which leads to poor cardiac function. There is mitral regurgitation in these patients because there is this LVV. I'll be explaining this mechanism later on, leads to improper LV filling. And there is again AA and AV dysynchrony, leading to the progressive dilation of heart and severe MR. We should be very careful that these severe MR patients with LVB should not be taken as a candidate for mitral clip, which was previously discussed, because as we synchronize the ventricle with the CRT device, or maybe we are now having left bundle branch pacing also, the mitral regurgitation dramatically goes away. So this is the dysynchrony part to be understood, that there is a mechanical dysynchrony between left ventricle and right ventricle. I try to explain it this way, that we have two separate wires for left ventricle and right ventricle, which conduct nearly synchronously. If we do not conduct on the left side, then right ventricle contracts first, and this contraction leads to the bulge of the interventricular septum, and it impedes the filling. And when right ventricle has contracted, then left ventricle contracts from not top to down, from but basal up. In that case, it leads to impedance to the filling and mitral regurgitation. This cycle with every beat continues, and this is a chain which leads to wider the QRS, more is the mortality. As seen in these West study, that those patients who had extreme of the QRS more than 220 had a very greater mortality as compared to when the QRS was narrower. So we can safely say that as the QRS is widening, the lifespan is contracting. So this is a classical left bundle branch pattern. So if a patient comes to me, okay, he has been on medication, still not getting better. So which device? Look at the ECG. Wide QRS, okay, maybe CRT. Normal coronary, maybe CRTP only, if not affording, or CRTD for all the patients who have the coronary artery disease. First thing, we should be making sure that we have revascularized the vessels. Otherwise, if there is a burden of ischemia, there is no point putting in a device in a left main disease. So this mortality with LVV, I told you, increases, especially when it is more than 140 milliseconds. And this therapy of CRT is placing an additional lead on the left ventricle. As I said, that left bundle is gone. So why do we, why should we not provide a left bundle there? In this regard, we go through coronary sinus and place a lead on the left ventricular epicardial aspect. It is very hard to go retrogradely aortic, and how do we manage that? So safely through this coronary sinus, it has been since last 20 years that a LV lead is placed, and rest of it is just like a conventional pacemaker of the atrial and ventricular leads. So once it is there, then these leads can synchronize and take over the total cardiac function of the heart. Now it is absolutely 100% of the ventricular pacings by the CRT. So this has shown its benefit, that once this LVV is corrected, QRS is narrowed, these patients have improved ejection fraction, and they have increased 6-minute walk, and there is a decrease in the all-cause cardiac mortality in heart failure hospitalization. And this is nearly a miracle for these patients. As I told you, that now the AV synchronous and they have normal coronaries, they are super responders. If teenage they are having normal coronary, I look back on that more than 90% of the patients are going to respond. So these are the trials which have established over 20 years, providing its benefit. And this is again the summary of mechanism. And if I look at the therapy indications, especially if the patient has ejection fraction of less than 30%, even NYHA patient can be given this therapy benefit. And if it is less than 35% at least, NYHA 2 symptoms should be there. And I spoke about right bundle branch block, then QRS of more than 150. And what is the clinical impact? The readmission rates are decreased by 50%, 1-year mortality decreased by 35%. So it makes a great impact on the patient. These are again the trials. And if I speak about a newer therapy, which is left bundle branch block, pacing that can be corrected by a lead which goes into the septum and corrects the left bundle directly. As I previously mentioned, in CRT, we have the lead which goes to the coronary sinus and goes on the epicardial aspect. What if we can directly go to the left bundle and stimulate it? It again works as beautifully as CRT and even better, because now the QRS becomes absolutely physiological. This is now coming up in big way, because even with CRT, there are 70% patients who are responding, maybe 30% because of the lead issues, or maybe not having the right area that is scarred. And even after all the good things, CRT, these 30% patients are not responding. The number goes with careful monitoring, reprogramming to 20%, but still bundle pacing appears to be more physiological and is coming in big way. So this is the left bundle optimized resynchronization therapy, which is called as LOT CRT. Like in CRT, I told that this is LV epicardial and RV apical, which makes the contraction synchronized. In this, the component which is pacing is the left bundle lead. So better physiological outcomes can be there. And especially those patients who are not responding to CRT, it has been shown in this trial in 2022 that LV dimension decrease, ejection fraction improvement, and QRS narrowing is much better than this LOT CRT. And especially few operators are directly opting for this upfront rather than a backup therapy. And this leads to the decrease in the functional MR, and it can be seen as early as 1 month, and hemodynamics even improve on table also. So these are the guidelines. I would say every patient of CRT can be offered LOT CRT. And if there is a patient who is in need of a pacemaker, less than 35%, you go with the CRT, LOT CRT. But between 36 to 50% ejection fraction, these patients are going to get progressive LV dysfunction if the patient is conventionally paced. So these patients are to be offered either bundle branch pacing or CRT. So this is again final few words about the ICD. If the QRS is narrow, then these are the patients for ICD, which is single chamber, I would say. Especially if the patient is recent MI, then after 42 days, recent PTCA, then after 3 months, and ejection fraction again less than 35% for NYHA2, less than 30% for the NYHA1. And MR has been discussed, so I would skip the mitral clip part. Thank you very much.
If there are any comments or questions?
Dr. Vikas, wonderful talk. This was not very clear cut about the CRT and CRTD. So that difference has to be done, and very simple and very effective management of heart failure in resistant cases. So thank you.
Thank you so much, sir.
Rashi, you want to say something?
So I think he explained everything very nicely, and definitely LOT CRT and HOT CRT are coming up very nicely. And I've personally seen many patients. We did LOT CRT, and the EF improved from 18% to 45% within the span of 4 to 5 months. QRS was less than 100. So beautiful results. Thank you.
Possible we can give above 35 also CRTD?
So the point
Any
is,
advantage?
about 35 also there were trials. In 35, when you have a QRS, which is sometimes they if the lead is not in right position, you actually end up widening the QRS. So if more than 35 you have these patients, if there is a need of pacing, then you can go for CRT or the bundle branch pacing. But otherwise, keep on medical therapy.
Sir, one more thing I'd like to say that in CRT, we have 30 to 40% patients who are non-responders. Even when we do a CRTD, patient is not going to respond. That percentage is very low with this LOT and HOT CRT, particularly LOT CRT.
Thank you.
Thank you, sir.
Thanks, sir. Next session is Dr. Sunil Modi, Senior International Cardiovascularist at Indraprastha Apollo Hospital. Today, topic optimized medical management of resistant HD. Hypertension. Thank you, Dr. Modi.
Thank you very much. Thanks, Dr. Tripathi, for invitation and making it possible for us to meet here together. Yeah. This. Okay. So 10, 12 minutes, we'll be talking about resistant hypertension. In last maybe 3 or 4 minutes, I'll give you some very new and very markedly new developments which is going on in this field, which I also didn't know till about 6 months ago. Every third or fourth adult in the world is hypertensive. Hypertension is number one killer and accounts for 15% of all deaths all over the world. Several large outcome trials have shown that one third of the participants could not achieve target blood pressure in spite of more than 3 antihypertensive medicines. Suboptimal blood pressure control is the most common attributable risk for death worldwide. Now, resistant hypertension is not very new fashion, but it's increasing. You know, the reports, the publications, the papers, the researches are increasing every year. And this is just to give you an idea that number of papers published for resistant hypertension has rapidly grown up. Now, what is resistant hypertension? Conventionally defined by JNC7, which probably needs to be changed. I'll convince you that it needs to be changed now, as blood pressure that is above the patient's goal despite the use of 3 or more antihypertensive agents from different classes at optimal doses, and one of which should preferably, ideally no, not ideally, preferably be a diuretic. Estimated prevalence of resistant hypertension in general practice is about 5%, 1 out of 20, 1 out of 15. And in the specialized hypertension clinics, which often go to nephrologists, is as high as 50%. Who are these patients who have resistant hypertension? Typically, you will see in your practice that those patients who have very high baseline systolic blood pressure, usually elderly age, presence of marked LVH, obese, serum creatinine above 1.5, excessive salt ingestion, diabetic, black race, female gender. These are typical those patients who are difficult to manage or hard to control blood pressure. Now, Finnish study found some genetic mutation link also, which I'm not going into details, but probably there is something in the genes which make you resistant to usual antihypertensive therapy. Now, treatable cause of resistant hypertension means that we think that it is resistant hypertension, but actually it can be brought down to non-resistant hypertension, which includes pseudo-resistance, poor compliance, drug interactions, underdosing, improper combinations, obesity, alcohol, volume overload, sleep apnea, secondary hypertension. We'll just touch upon some of these quickly. Pseudo-resistance is important because being busy in the clinics, we quite often have suboptimal blood pressure measurements, white coat effect, and clinical inertia. What is clinical inertia? All of you know very well now, is that conscious decision by a clinician not to adequately treat a condition despite knowing that it is present and treatable. You know, very often patient comes on the follow-up from 170, the blood pressure comes to 145, and we seem to be happy that, okay, let's leave it like that. So that is what, and we know that criteria, ideally it should be below 130, but then we leave it on the higher levels just because of, not to the extent of caring that much. What is clinical inertia? That is clinical inertia. Now, substances which interfere with blood pressure controls, all of you know very well. I'm not going to go into details. NSAIDs, alcohol, oral contraceptive, sympathomimetics, antidepressants, less commonly corticosteroids, cyclosporine, erythropoietin, and some dietary herbal supplements. Secondary causes of hypertension, which look like resistant hypertension, are very well known. They should be seen, they should be cared upon. And commonly, obstructive sleep apnea is one of the very common findings in resistant hypertension, which is a treatable condition. So you know how to diagnose, how to suspect, how to treat obstructive sleep apnea, and you should always look for that if you think that blood pressure is not coming down to the desirable goals. Obesity is one of the most important reversible cause of hypertension. It has its own, hormonal disturbances because of obesity, plasma aldosterone, endothelin are increased, progressively higher doses of antihypertensive drugs are required, and weight loss undoubtedly has been shown to reduce both systolic and diastolic blood pressure. Primary hyperaldosteronism is present in about 15 to 20% of cases. They are what we were told in our physiology days as low renin hypertensions, and they will only and mostly respond to the spironolactone or eplerenone or amiloride, those kind of drugs which are anti-aldosterone antagonist drugs. CKD is one of the very practically very common cause of resistant hypertension. As the renal functions decline, there is a more and more need of antihypertensive agents. Diuretics play a central role, and diuretics need to be changed from thiazide diuretics to the loop diuretics if patient has CKD. And dialysis at some stage becomes a very attractive treatment for resistant hypertension in ESRD patient. Now, what else can be added? We have consumed RAS blocker, one of the RAS blocker, one of the calcium blocker, and diuretic. That is what is called 3-drug. Blood pressure is not responding adequately. What else can be done? Now, there are many options which can be which we can do. Can we just go to the previous slide, please? I don't know. Okay, I can do that. Right. So spironolactone, beta blocker, alpha blocker, centrally acting drugs, hydralazine, so on and so forth. And in the last, some very novel and emerging molecules, which I'll discuss in few seconds. Now, do not forget beta blockers in the treatment of hypertension. I often hear from our colleagues, GP colleagues, that beta blockers should not be given in hypertension unless, so beta blockers are still very, very useful drugs in beta blockers, and look for those patients who need beta blockers. Young hypertensives, obese, smokers, diabetics, hypertension with IHD, hypertension with congestive heart failure. These are the typical patients who will need beta blockers. Beta blocker is an essential part of treatment of hypertension in these sympathetic overactivity patients. So never think that the beta blockers should not be used in hypertension. Now, spironolactone in resistant hypertension was studied in last decade very elegantly, and some surprising findings were found. They conducted pathway trials. It is prevention and treatment of hypertension with algorithm-based therapy, which is pathway trial 1, pathway trial 2, pathway trial 3. Pathway trial 2 showed that spironolactone had superior blood pressure control as compared to placebo, alpha blocker, and bisoprolol in those patients where the hypertension was resistant. And first randomized clinical trial, pathway 2 trial, showed that spironolactone 25 to 50 milligram is the most effective drug treatment for resistant hypertension. The spironolactone controlled blood pressure in almost like 60% of cases with resistant hypertension, which is 3 times as likely to be the patient's best add-on drug after triple drug combination. Results of pathway 2 should influence treatment guidelines, and patients should not be defined as resistant hypertension. This is the thinking of the committee which did this trial, that patients should not be defined as resistant hypertension unless their blood pressure remains uncontrolled, even on spironolactone. So spironolactone is very good drug for resistant hypertension because we know that 15 to 20% patients will be low renin hypertension. Pathway 3 showed that amiloride and hydrochlorothiazide combination has a very good blood pressure effect on resistant hypertension. If our colleagues of our time remember, we used to be bidiurate drug, very common drug which we used in the 80s and 90s, which was a combination of amiloride and hydrochlorothiazide only. Now, novel and emerging therapies for systemic hypertension. This is some amazing molecules are coming in, not late, very next 5 years or maybe even 3 years, which you and me will be using very elegantly, and they will change the whole scene of resistant hypertension. 3 groups mainly I'm focusing: dual endothelin receptor antagonist, angiotensinogen synthesis inhibition, and aldosterone synthase inhibitors. Now, why these 3 drugs are very attractive? Because they all 3 are their mechanism of action is totally different than what drugs we already had in our pocket so far. All the drugs which we are using till today have different mechanism of action, and these drugs have totally different mechanism of action. For example, dual endothelin receptor antagonists, the endothelin receptors A and B both are blocked by these aprocitentan. The phase 2, phase 3 trials are already there, and it has shown that it is very, very effective drug in reducing hypertension. I think it will be approved very soon for common use, although it is still experimental use, and phase 3 trials are going on. Now, second is angiotensinogen inhibitor. The whole RAS cycle starts from angiotensinogen. So if you just reduce angiotensinogen synthesis by the RNA interference, thereby producing less of angiotensinogen, the whole RAS cycle is inhibited. So there the drug, just give me 1 minute more, the gilebesiran, which is the drug already on trial on phase 3 basis, it has shown very, very effective drugs. And the good part of these drugs are that they're very, very long-acting drugs. You give one subcutaneous injection of gilebesiran and it acts for 6 months. So you will need twice a year subcutaneous prick of this drug to keep the blood pressure under control. Just like inclisiran for LDL, these drugs are coming very soon. I think within a year or two, you will be using these drugs. So this is angiotensinogen synthesis inhibitor. Last is aldosterone synthase inhibitor. You are talking of a mineralocorticoid receptor antagonist. So there the aldosterone is already formed. Increased aldosterone is already there, and then you are trying to block the aldosterone effect on the receptor. Instead of that, if we can reduce the synthesis of aldosterone itself by some newer drugs, the trials are already there. They are very effective drugs, and I think very, very soon you will be able to use these drugs in the... Now, don't forget that GLP-1 agonist and SGLT2 inhibitor, which we are using regularly now, are also very good antihypertensive drugs. They can be called to be used in resistant hypertension. Friends, not all patients with uncontrolled hypertension are resistant hypertension. Just a small group is real resistant hypertension. The all other uncontrolled hypertensions should be taken care by. Combination therapy is always better than, and more number of drugs combination will work better than less number of drugs. So we are convinced that antihypertensive agents combination is required to control the blood pressure. Medicines are nothing in themselves if not properly used, but the very hands of gods if employed with reason and prudence. Thank you very much.
Any question from the audience? Sir, Dr. Modi, sir, this side, sir. Time-tested resistant hypertension, 3 drugs, sometimes 4 drugs. As a general practitioner or as a physician, we used to use the centrally acting drugs, clonidine, the tenoracamine. So what is the role? Because that has been very, very effective for the last so many years. I've been using BP is controlled very nicely if you use the clonidine.
Oh, definitely, centrally acting drugs are still used very commonly, particularly with our nephrologist colleagues, because there they want the drugs which do not affect the renal outcomes. So, drugs like clonidine, moxinidine, they are still very, very good antihypertensives. So I didn't mention that for the lack of time, but those drugs are being used by you and me for many, many years, and we still use it.
That was very good for this resistant hypertension. Like we used to have quite almost...
See, again, definition of resistant hypertension, as I said in the beginning, is not very nice definition. They said 3 or more drugs. What does it mean? If it is not controlled by 6 drugs or 5 drugs or 4 drugs, we don't know. So in the practice, resistant means when you have consumed all your drugs and still blood pressure is not able to come down. So main change in the thinking has been after pathway trial that you must use spironolactone if there is no contraindication, and the contraindications of spironolactone. Use spironolactone before calling it a resistant hypertension.
As per definition, 3 and 1 has to be a diuretic. That is one of the definition.
Diuretic and preferably spironolactone.
Spironolactone.
Recent days in Delhi, there is increase in air quality, poor air quality, especially particle 2.5. We are seeing that patient above 60 or just 55 plus, almost 50% are having increased blood pressure on the same drugs on which he or she was controlled. And only drug effective I am observing is either amlodipine or cilnidipine, calcium channel blocker or a vasodilator, because something related with the endothelium, especially 2.5 micron particle.
No, both statements are absolutely correct. Pollution definitely, without any doubt, has relationship with the cardiovascular disease, including hypertension. Nobody can doubt that. There are ICMR researches of crores of rupees. ICMR researches are going on pollution, and you will see the results maybe by next year or so. Secondly, amlodipine is the most potent antihypertensive drug, not cilnidipine. Sorry, sir. Amlodipine and cilnidipine, amlodipine is far more potent antihypertensive drug. Yes, 20 milligrams of cilnidipine is equivalent to 5 milligram of amlodipine. That I agree. So they are the most effective drug always. Even in last two decades, the most effective antihypertensive we have found is amlodipine. So both statements are absolutely correct. So pollution is 100% related to not only hypertension, heart failure, ACS, coronary artery, atherosclerosis, everything.
So I would like to say this statement is absolutely correct that at least 30 to 40% of the patients who were previously controlled with only single drug or two drugs now coming as resistant hypertension in the last 1 to 2 months. And maybe once this winter season and the pollution subsides, maybe the blood pressure, because we have to drastically increase the drugs, add 3 drug, 4 drug. Even one patient came to me who was advised RDN because since the past 2 months his blood pressure had not been controlled.
I can't deny it. If you are thinking that way, that it may be because of pollution, nobody has any denial for that.
So not exactly pollution.
Only thing is that we
maybe-
have to study it systematically. And as I said, ICMR has taken 2 or 3 mega projects through with the All India Institute, Medical Sciences, with all India Institute of the countries. I think they are doing a lot of work to know the effect of pollution, and we should all participate in that. But there is nothing for me to deny that pollution does not have this kind of effect.
Maybe the contributory effect of the vasoconstriction because
Naturally.
of this season
Naturally.
and the pollution both.
Pollution is definitely contributing factor, but
pollution
no
is
hard data is
not
there.
for blood pressure only. It has increased the incidence of MI, the acute coronary syndromes, heart failures, everything.
Thank you, sir. Thank you for the wonderful talk, sir. Thank you.
Next topic is case presentation. I welcome Dr. Veerbhan Balai. He is consultant interventional cardiologist at Manipal Hospital, Dwarka.
So ये play कहाँ से होगा? प्ले इसको प्ले करें. इसको फुल उस पे प्ले करने का. अच्छा ठीक. So good evening everyone. I'm Dr. Veerbhan Balai. I'm working at Manipal Hospital, Dwarka. So I'll be showing a case of complex calcified coronary arteries. So our patient is a 84-year-old gentleman, and he presented to us with complaints of exertional angina, even on minimal exertion, since last 6 months. So he had comorbidities in form of diabetes, hypertension, and CKD. His baseline serum creatinine was around 1.9, which brings his GFR around 35. So his ECG showed an right bundle branch block morphology. The echo done showed the LAD territory redden hypokinesia with an LVEF of around 45%. So in view of symptomatic ischemia, he was evaluated at a center outside where he was advised for an CT coronary angio. And during CT angio, his calcium load was seen to be very high. So subsequently, his CT angio was cancelled and he was advised for a conventional catheter angiography. So obviously, he came to us for an coronary angiogram in view of his symptoms. So after an informed consent, he was taken for a diagnostic coronary angiogram through right radial artery approach. And he received adequate hydration before an angiogram in view of nephropathy. So we took the left coronary artery diagnostic sort. And here we can see that the mid LAD is heavily calcified, around 95 to 99% stenosis with TIMI 2 flow. The LAD also had an distal around 80% stenosis and his right coronary artery was normal. So obviously in view of the critical lesion and symptoms, it was decided to revascularize this vessel with the PCI. So we planned the PCI, obviously because there is presence of heavy calcium, so this patient will require some form of calcium modification therapy, preferably the atherectomy either in rota or the orbital atherectomy. So our plan was to cross this lesion with the help of microcatheter with the regular workhorse guide wire, and then to exchange it, because we planned the orbital atherectomy in this case. So to exchange this regular workhorse wire with the Viper wire. So we did took the microcatheter and the regular workhorse guide wire, and initially after some difficulties we did cross the regular workhorse guide wire distally, but somehow we could not exchange it with the Viper wire, and the everything we have to remove. So subsequently we plan to cross the lesion with the Viper flex tip wire only, and after initial difficulties we were able to cross the lesion. But here we can see that the wire appears to be in the some small branch. So obviously we can't start burying when the wire in the small branch. So we did redirected the branch in the main vessel. We did confirm that wire is in the true channel, and then we took the orbital atherectomy burr till the proximal of the lesion, and then we started burying with the 1.25 mm diamond burr at 80,000 revolution per minute within gradual 1 to 2 mm per second. And subsequently, after multiple run of burying, we were able to cross the lesion. And then the polishing run was taken, and then after the burying, we took the 2.508 mm NC balloon just to prepare the lesion adequately. So it was inflated at 2.5, the 2.508 mm NC balloon at 14 to 16 atmospheric pressure. And then an IVOS run was taken to see the calcium fracture and to the lesion for lesion length and the vessel sizing. And after adequate lesion preparation, we took a 2.75 or 28 mm DES, and it was deployed at 12 atmospheric pressure. Subsequently, it was post-dilated with 308 mm balloon at 14 to 16 atmospheric pressure. And it was fine. This was the final result. So then patient also had a calcified lesion in the distal LCX, and we also decided to fix this lesion. So we crossed this lesion also with the Viper wire only, and then again we took the orbital atherectomy burr, and we did the burring. The multiple runs were taken in the LCX also, and after that again the lesion was pre-dilated with 2.508 mm balloon at 12 to 14 atmospheric pressure. And after lesion preparation, then we deployed the 3016 mm DES at 12 atmospheric pressure. This stent was also post-dilated with 308 mm balloon at 14 to 16 atmospheric pressure. And then this was the final result. Patient had a good TIMI3 flow in the both vessels. So the take-home message is that the treating calcified disease may require a combination of modification techniques, and imaging can help in deciding the right strategy. Appropriately leveraging the available calcium modification technique like cutting balloon, orbital atherectomy, rota, or even the intravascular lithotripsy can significantly improve the treatment outcome. So I think that's it. Thank you so much.
हमें तो कंप्रेस सिंपल समझ में नहीं आता, कंप्रेस क्या समझ में आएगा? आई थिंक डॉक्टर राशि आप कुछ कमेंट कर
Sir, yes, it was a very nicely done case. Given the patient was having deranged RFTs, so you used IVUS for imaging, and
yes, ma'am.
it was nicely done because it was a long calcified lesion, so, and because it had a TIMI 1 or 2 flow distally, so definitely orbital was the treatment of modality of choice.
Yes,
then we use imaging. IVUS was the correct choice, and beautiful results. Just one thing. Didn't you think that maybe we could do LCX on this in the next sitting because of the creatinine values, because dye maybe, but it was perfectly done, nicely done, definitely a very nice result.
That was also a calcified vessel, and
Yeah.
we had an orbital, so
Yeah.
this is how we decided
Yeah,
to
yeah,
go.
definitely. But whoever is on the table, he's the best judge to
And
decide.
he was 84-year-old, so we didn't want
Yeah.
to bring him again and again.
Yeah, very nicely done.
Thank you so much.
I think with this we end this session and hand over the mic to the organizers. Organizer, please.
Thank you, sir. Thank you very much. If I could invite our chairperson and also our panelists for the felicitation ceremony, please, onto your left-hand side. All right, so while we have our felicitation going on, and before we get into our last session, we will very quickly, since we are few of us, let's very quickly do a lucky draw. But इस बार मैं चाहता हूँ कि कोई मेरी लगातार हेल्प करे, क्योंकि मुझे लगता है कि हमें काफी सारे नाम शायद निकालने पड़ सकते हैं, बिकॉज रूल वही रहेगा कि हाँ सर मैं आ रहा हूँ, आपके पास आ रहा हूँ, आई एम जस्ट शफलिंग दिस अप. रूल वही रहेगा दैट यू हैव टू बी हियर टू विन इट. एंड सिंस आई सी हमारे अर्ली बर्ड्स ही अभी तक हैं, तो सर आप निकाल के देते रहो, एंड इफ वी हैव द विनर तो फिर वी विल डू इट. ओके, डॉक्टर सत्य प्रकाश. डॉक्टर सत्य प्रकाश इज नॉट हियर. आई एम प्रिज्यूमिंग कि काफी सारे नाम अभी शायद नहीं होंगे. डॉक्टर प्रिंस यादव. डॉक्टर प्रिंस यादव. ओके, ये तो है. सुधांशु सर. सुधांशु सर है. चले, सुधांशु सर भी नहीं है. अच्छा, ओके, डन. सो he must have got, yeah, no, I understand. Dr. Aishwarya Dabas. Dr. Aishwarya Dabas. Dr. Aishwarya. Dr. Suresh Kumar Jain. Dr. Sir, please, आइए. Sir, please, I'll invite you to step up here. And Ashish sir, if you're here, please help us with, I think we can give it, yeah. Sir, we'll come and give it to you, sir. All right. Dr. Kuldeep Kumar. Dr. Kuldeep Kumar. Acha, Kuldeep sir is gone. Dr. Sanjay Kumar Gupta. Dr. Sanjay Kumar Gupta. I think अब मैं सर किसी और को ट्रबल देता हूँ. Okay. Dr. Shubham Sharma. Dr. Shubham Sharma. And Dr. Anurag Garg. Dr. Anurag Garg, not here. अब मैं सर थोड़ा सा पीछे भी चांस देता हूँ. हाँ, अब मैं. So ma'am, I'll have to invite you to do the same trick. But we want you to be there. So Dr. Jay Bharti. Dr. Jay Bharti. Ma'am, please. Dr. Oh, you're here. Sorry. Thank you so much. Thank you, Dr. Bharti. Congratulations. Dr. M.K. Wahi. Sorry, ma'am. Dr. M.K. Wahi. Acha, theek hai. Dr. Alok Agarwal, I'm presuming. Dr. Alok Agarwal. Dr. Alok Agarwal. Harshit Goyal. Harshit Goyal. Dr. Bhavik. Dr. Bhavik. Dr. Bhavik is not here. Dr. JB. Looks like Dr. JB. Dr. JB Dang. Dr. JB Dang. Dr. Rabindra Gupta. Dr. Rabindra Gupta. Dr. Saurabh Narayan. Dr. Saurabh Narayan is gone as well. Okay. Yes, why not, ma'am? Why not? Why not? Please. इनके सामने रख दो, because she's been making, she's been really studying. So she deserves every bit of it. आप देते रहो. Yes. Dr. Deepti. Looks like Deepti. Dr. Deepti. ये तो है. Dr. Amardeep. Acha, ma'am, please. This is yours then. You're most welcome. All right. Dr. Bharat. Dr. Bharat. Okay. Dr. Kelly is gone, right? Dr. Kelly is gone. Okay. Dr. Amit Singhal. Dr. Amit sir, we gay. Okay, we'll do the last one. Dr. R.M. Chavla, I'm presuming. Dr. Chavla. Chavla, no, sir. All right. Thank you. All right. Dr. Ravindra Kumar Gupta. Dr. Ravindra Kumar Gupta. Okay. Let's do out the next one. And here we go, ma'am. Dr. Vaibhav. Dr. Vaibhav. Dr. Vaibhav, we'll do a couple of more. Looks like Alka. Dr. Alka Tiwari, right? Dr. Alka Tiwari. Ma'am, please, congratulations. If you can hand it over to Alka, ma'am. Okay, there you are. Dr. Alka Tiwari. Dr. Kuldeep Kumar. Dr. Kuldeep is gone. Dr. Bimlesh. Bimlesh. Ma'am, अरे वाह क्या बात है, please. All right, thank you so much, thank you very much. I will take this away. Huh. All right, thank you very much for your patience, ladies and gentlemen. We will have one more and we will try to wrap that up at a later point of time. But right now, हम अपने आखिरी सेशन की ओर अब proceed कर रहे हैं. So those who are following the agenda, ladies and gentlemen, we are moving into our last session, and of course, yet another critical one, which is the most decisive pillar of the cardiovascular care, lipid management. And for this session, to moderate the session and chair it, let me invite Dr. P.C. Bhanu. Dr. P.C. Bhanu, if you can please join us on the chairperson table, along with Dr. Sandeep Miglani and Dr. Amardeep Sachdeva. If you can please be here on the chairperson table now. And to have it on the panelist, let me invite Dr. Ruchi Singhal, Dr. Ranjit Ranjan, and Dr. S.K. Sharma to please take up on the panel table here. And as I want to bring to your notice once again that this shall be the last session for our day today, where we wrap up this session as well, followed by, of course, a networking that we are all shall be really leveraging tonight. So over to the chairperson. The desk is yours, sir.
Good evening, all delegates for the last session of this CardioCon. So I want to invite
Dr. Ankesh, Dr. Ankesh, I'll also invite you to please join us on the panelist here. So sorry, ma'am. We just have Dr. Asha.
So I would like to invite our first speaker, Dr. R.M. Chabda. I think there is no one who is not knowing Dr. R.M. Chabda in Delhi and Pitampura and Rohini especially. He is Senior Consultant Physician, Director Chabra Medical Center, Pitampura, attached with MEC, Shalimar Bagh and Saroj Hospital. And he'll speak about recent guidelines for lipid management in CAD. Thank you.
I will also invite Dr. Dinesh to please join us on the panelist. Dr. Dinesh, if you can be please here on the panelist. Please, Dr. Chabda, please, sir.
यहाँ कुछ लिखा गया आपने लैपटॉप वगैरह वहीं से देखना पड़ेगा इंडिकेटर वगैरह अच्छा वहीं से देखना पड़ेगा डायरेक्ट First of all, I would like to thank the organizer for giving the opportunity. Especially thanks to Dr. Nityanand Tripathi. आपको भी हाँ आपने मेरे को चांस दिया पहले भाई साहब thank you sir thank you very much thank you very much. So dear friends, today I have noted a very interesting topic, the recent guidelines for the lipid management in the CAD. We always follow the guidelines as the American Association or the European Association. But nowadays we are following the guidelines given by the CSI, that is the Cardiological Society of India. So dear friend, the dyslipidemia is a major risk factor of the CVD, like the hypertension, obesity, or so many risk factors, but the dyslipidemia is a major risk factor for the CVD. Major cardiovascular society, major cardiovascular societies have updated the lipid management recommendations to refine the risk assessment and intensify lipid lowering strategy. So how we will take how we whether we have to treat or not, what are the levels of the lipids we should keep. So dear friend, our aim lower is the better. Early reduction is very important. The lipid management. So, what is the dyslipidemic in Indian burden? What are the risk factors? Total cholesterol about the 200 milligram ranges from the 4.6 7.9 to 45.6 to 55.3. And what about the LDL? Very important cholesterol. That is a 130 milligram from 4.6 to 6.2 to 46.8 to the 52.6, 52.1. And what about the triglyceride? 150 milligram from 21 to 22.7 and 43 to 47%. If we talk about the low HDL, as you know, the HDL is a very important topic. It is a production of the heart. So the low HDL cholesterol ranges from 51.8 to the 83.1. So if you see, we have divided the risk factor accordingly. The person who is extremely at high risk, according to the atherosclerotic cardiovascular disease, recurrent episode within the 2 years in the same territory or the different polyvascular ASD. So the extremely high risk and other than very high risk atherosclerotic vascular cardiovascular disease, the CAD, PVD, and the other cardiovascular disease, or the imaging more than 50% of the lesions in the two major vessels, or the diabetic mellitus more than 20 years, or within the multiple risk factors, that is the triple vessel disease, or the heart failure, or the CKD. This is the very high risk and high risk, the diabetic mellitus, or the CKD, or the heart failure, or the hypertension, or the one or more renal failure, and hypertension, or the TOD, and moderate risk factors. Moderate risk factor any ये सब मजा नहीं आ रहा ध्यान से दिख ही नहीं रहा यार. Any single vessel disease, or the hypertension, or the tobacco consumption, or the young atherosclerotic disease, and low risk, no heart failure. So the lipid goals, LDL, lipid goal, LDL, we have to keep the less than 40 milligram, and non-HDL, that is less than 70. And in the very high risk, LDL, we have to keep the 55 milligram, and the non-HDL with the 85 milligram. And with the high risk, then the LDL less than 70, and the non-HDL, that is the less than 100. In the moderate risk, there's the LDL 100 milligram, less than 100 milligram, or the non-HDL, that is the 130 milligram. In the low risk, the LDL more than 100, or the less than 100, or the 100 with the 200, or the HDL with the 130. So these are the levels we have to keep according to the risk of the patient. If you talk about the evaluation, how will evaluate the lipid parameters? HDL, LDL, I have told you the low risk and less than 100, and the non-HDL less than 130, and HDL more than 40, and triglyceride less than 150, or the lipoprotein that is less than 50. Moderate risk less than 100, 130, and 40 in the male, and the 50 in the female. And triglyceride less than 150, and lipoprotein less than 50. High risk There is a parameter for the high risk and low risk. These are the things. Very high risk, that is less than 55 and less than 85, and male and female HDL, the same 40 and the 50, and the triglyceride one less than 50, and lipoprotein the 50. So these are the how to manage the lipid management, the acute coronary syndrome. If there is a acute coronary syndrome, then how we will manage? If there is a non-fasting lipid profile within 24 hours, we have elderly patient, more than 75, a CKD stage 3 to 5, or the on lipid lowering drug therapy and loading doses. Loading dose. We have to start the 40 milligram the rosuvastatin with the estamamide, or the 80 milligram atorvastatin with the estamamide. And if we have to LDL is achieved by the 50 less than 55%, then we have to if it is not achieved, then we have to add the LDL. If it is not achieved less than 55, or the non HDL less than 55, then we have to add the other drug. And if it is after the 4 week it is achieved, then we have to keep the same drug. If it is not achieved, then we have to add the bempedoic acid or the lipid. If it is not achieved after the 8 weeks, we have to get it done. If it is less than 55, then we continue. If it is not achieved, then we have to add the PCSK9 or the insulin. If it is achieved, then you have to continue the same. Lipid profile management in the atherosclerotic coronary disease. In the stable patient, you start lipid profile fasting level start with the 20 milligram. There we started the 40 milligram. Here we start the 20 milligram rosuvastatin or the 40 milligram atorvastatin. Lipid as a 4 week we have to start. If it is not achieved, then we have to add the agitamide 10 milligram. If after the 8 week, if it is not, then we have to add the other drug to reduce the lipid profile. So similarly, why there is a combination? Combination, it is more effective. Rosuvastatin, if we have to increase by 40 milligram, or the atorvastatin 40 to 80 milligram, up to 6 to 8% reduction of the LDL. We have to increase the dose. And if you use the combination, it is safe and less side effect, and adherence compliance is more with the combination therapy. So rosuvastatin and atorvastatin we have to use along with the agitamide. What is statin? Statin is drug of the choice in the lipid realm, definitely, and it is a proven protective effect in the all critical situation. And according to in the South Asian and the Indian are the hyper respond to the statin. They require the less statin because they respond to the statin. If we give the low dose, they definitely respond. And useful in the lowering the total and the LDL cholesterol in the triglycerides in the high dosage, and effect are dose dependent, and lipid lowering efficacy vary from the different statin. Rosuvastatin, it is a water soluble, and atorvastatin is a fat soluble. So rosuvastatin and atorvastatin are considered the most potent statin, and lowering the dose of these agents are considered as a modern statin. We have to use the statin. Right. So statin and the dyslipidemia management, safety, all the statins are the safe. And management of the statin, especially with the muscle system, we have to stop the statin if there is it is later any symptom like the leg cramps, we have to stop it for the some time, then we have to restart again if there is no symptom. So the transition and the novel statin, other estamamide or the bempedoic acid, we have to use non-statin drugs, and another insulin or the fibrate for the triglyceride. So the traditional and the novel notostatin lipid profile, these are chart we have to use. And management of the hyperglycemia, these are chart, these are algorithm. Time is very short. Then I will go to the dietary. Everybody knows what are the dietary advice to reduce the lipids. So in the last specific community stroke, then we have to keep the LDL less than 50. In the peripheral artery disease, then less than 50. Conjunctivitis less than 50. And diabetic mellitus, then we have to diabetes with the ASD, atherosclerotic cardiovascular disease, more than 20 years, then we have to keep the LDL less than 55. Similarly, these are CKD, we have to keep the low lipids. In the special question, I will take these are familiar. Hypercholesterolemia is very, very important. We have to start even the young patient in the stadium. So in the last, this is also important. Apolipoprotein B is also important. Ideal remark, it have to reduce. Similarly, non-adherence and the strategy to improve the adherence. So in the last conclusion, lipid management is crucial for the CAD prevention and the management, and dyslipidemia are the widely prevalent in the general population and the CAD patient, and lowering LDL cholesterol using the statin and the other non-statin drugs can reduce the incidence of the primary CAD events and also prevent the recurrent events of the established ASCVD patient. And according to the CS clinical practice guidelines for the lipid management, has focused on the common drugs available in the India and their evidence guided and the expert opinion based on the better management. So the guidance, this guidelines discuss the lipid management in the specific comorbidities and the patient phenotypes and the better health care literacy and the final support and the use of the algorithm-based technology can improve the initiation and the continuation. Thank you very much.
Sir, I have a question.
Andy?
I have a question.
बताइए.
Sir, in many physicians' prescription, what I have seen there, matlab statins are there outrightly, and statins causes very severe myalgia in many patients. So, is it? I don't know if what is the baseline hypercholesteremia, so that we should prescribe. Not everyone we should prescribe the statins.
Very good question. If there is no risk factor, then you can keep the LDL up to the 100. If patient is diabetic or with the other comorbidity, then you have to reduce it to 70. If already there is a coronary artery syndrome or the cardiovascular disease, you have to keep as low as possible, even in the 55, or sometimes they say even up to 35 you have to keep the LDL. If there is any risk factor.
सर मिडिल एज दिल्ली में एलडीएल सभी का हाई है, सो सबको स्टैटिन प्रिस्क्राइब करना इज वाइज विदाउट एनी कोमॉर्बिडिटी.
मेरे most probably 60 to 70% are not under control. This is the observation. But we have to try to control if there is a comorbidity less than 55. If not, then we can keep up to the 100. In the diabetic patient, you have to keep definitely. In the diabetes is very, very important. If diabetic patient with a cardiovascular disease, you have to control the LDL definitely.
Thank you very much.
Thank you.
Next slide. So any question from audience? No. So I would like to invite our next speaker, Dr. Amit Sharma. They said it is a second speaker.
Can I also please request Dr. Kshitij to join us on the chair table? Dr. Kshitij?
I think Dr. Amit Sharma is not here.
No. So Dr. Jha.
So we go on to the next topic.
Our next speaker is Dr. N.N. Jha. And the topic, and he is a principal consultant at Fortis. And the topic is recent advances in lipid management.
Dr. N.N. Jha is a well-known personality. He's a principal consultant Fortis Shalimar Bagh, and he has his own roaring practice in Shastri Nagar.
Roaring.
And he's at present president, North Delhi Physician Forum. And please welcome Dr. N.N. Jha.
Thank you for the nice words. My topic is recent advancement in lipid management. तो आधा काम तो डॉक्टर छाबड़ा ने कर दिया है. There are two advancements. One is the lipid guidelines, lot of lipid guidelines there, ACC, AHA, the European Society of Cardiology, Lipid Association of India, and of course what Dr. Chara said, the CSI guidelines. So half the job is done. Another part is the recent drugs. A lot of drugs have come in the recent years, and they are very, very effective in managing this lipidemia. This, is the LDL is the biggest culprit. So if it is high, you need help to avoid any complications of cardiac disease or this. So as customary, there will be introductions. Cardiovascular disease is the leading cause of death worldwide as well as in India. It's the major risk factor is the increased LDL. That is the biggest culprit for any cardiovascular disease. We have drugs, multiple drugs like statins, fibrates have been successful in reducing LDL to healthy condition, not fibrates. The statins, they have been a very, very useful drug. In fact, we have been so much using the statins that is considered as a multivitamin. So everybody should get the statins. And you're asking about the use of statin in high cases. So the recent concept, the statin could be as low as 10 or 15. There is no harm. So it is like a multivitamin, everybody should take. There's one thought is about this. And atherosclerosis is the biggest problem in having the high LDL. So they established anti-lipid drugs. The statin is the HMG coenzyme A reductase inhibitors. It decreases hepatic production via synthesis blockage of LDL. It is the most effective in reducing the low density lipoprotein. Then other niacin, the triglyceride has been a very problematic. We have very little drugs for the reduction of triglycerides. So niacin has been the use, but not very effective. One company also brought some changes, but has not been very successful. So it's not used now for side effects like flushing and other problems. Then bile acid agents, we don't use much. It binds to the bile and prevents cholesterol stores reabsorption and leading to depleting the LDL cholesterol, which is the harmful lipid. Then fibrates, this is used for reducing the triglyceride. So it causes increased synthesis of HDL, which is a good cholesterol. It is used in a hypertriglyceridemia. Then, of course, ezetimibe, it is blocks absorption of LDL from intestine. So absorb LDL from the bloodstream is an adjuvant drug. It's not used alone. It is used with combination with the statins, which has very good effect. And other drugs are omega-3 fatty acids, reduces VLDL and triglycerides. There is also supporting drug if you are not being controlled on these things. Then bempedoic acid is a new drug, is a newly approved for lowering LDL as adjunct to other anti-lipid drugs like the statins. The problem is that it causes hyperuricemia, plus bone fractures and bone diseases can happen. Bempedoic acid, but using it quite commonly in adjunct to the statins. Then, of course, glitajas, PPAR alpha and gamma agonist reduces also triglycerides. I'll talk about details. So there are other cholesterol lowering drugs one has to take. In fact, everybody has to take who has got a high cholesterol. So what is the need of the new drugs? With such a good drugs, statin, fibrates, bempedoic acid, ezetimibe, all are there. So what is the need of the newer drugs? So limitations of the established therapies are like statins. Statin reduces LDL cholesterol by only 35 to 40% maximum tolerated dose. As Dr. Ruchi Singh was saying, that people get this myalgia, these things. So one has to see what is the maximum tolerated dose, and in that case also reduces only 35 to 40%, and reduces cardiovascular risk by over 30 to 35%. Side effects, myopathy, GI intolerance, some new onset type 2 diabetes, and delayed liver enzymes. So delayed liver enzymes are common. More than 2 times is significant. If it is less than 2 times, not significant, one doesn't have to discontinue the drug. And target levels is normally, as Dr. Chawra has said, target levels are not achieved very consistently. So that is the need of the newer drugs. So what are the patients requiring newer drugs? LDL cholesterol is not achieved by current therapies. Most patients with heterozygous familial hypercholesteremia, there is a genetic disorder, and almost all patients with homozygous, that is, both the parents are hypercholesteremia, so they are called homozygous. Heterozygous is when one parent is hypercholesteremia. Then, of course, statin tolerance. Few people that are tolerate statins, and there are some drug interactions with the statins. In those cases, patient require newer drugs. So, newer lipid-lowering drugs, very common, available in India. Inclisiran, that is a small interfering RNA therapy. It silences PCSK gene in liver. So reduces PSK9, PCSK9 protein production. So this increases LDL receptors leading to the lowering of the low density lipoprotein. The second is PCSK inhibitors, is also available in India, though a bit costly. Monoclonal antibodies that degrade PCSK protein in hepatocytes and blood, so enhancing LDL clearance. So it also reduces the LDL in a significant manner. The newer drug, which is not available in India, lomitapide is an MTP inhibitor that reduces LDL, requires careful monitoring due to potential liver-related side effects. It is not available for clinical use, only for the research purposes. Just I'm giving the name of these drugs which are in the pipeline and what are used. This is an anti-sense Mipomarcin. This is an anti-sense oligonucleotide inhibits ApoB100, a key protein involved in LDL, VLDL formation by blocking ApoB synthesis in the liver. It reduces LDL cholesterol by 25 to 50%. Dose is 200 mg weekly, injection subcutaneous, given by the healthcare practitioner only for side effects, liver toxicity, and injection ASA. It's not available in India at the moment. Then again, NGPTL3 inhibitors, that is ibinacumab, it blocks the ANGPTL3 protein, which regulates LDL cholesterol and triglycerides. It is not also in India. Then PPAR alpha, I was telling us here. So pemafabrate, a newer drug, icosapent ethyl, which is available in India. Now, it activates PPAR alpha and primarily reduces the triglycerides. So it's a very good drug for the hypertriglyceridemia, as in the market at the moment. Then one more antisense oligonucleotide, volanesorsen, very difficult names, and targets and reduces the production of apoprotein C3. This will also lowers the triglycerides. So these are the drugs. Then one experimental oral pill is there. This is ilicitide, is an experimental oral drug with potent LDL-C lowering effects. It is useful in statin-resistant patients. These are in the pipeline. So these are the newer drugs. On the inclusion, PCSK inhibitors are the available as present among the newer drugs. Inclusion, few more words about the inclusion because they're available. Again, small interfering RNA that silences the PCSK gene in the liver, reducing the PCSK protein production. So increasing the LDL cells, leading to lowering the LDL cholesterol. So repetitions. So dose is initial dose first, then the second dose after 3 months, then after every 6 months. So 2 doses in a year. So very, very comfortable. Only 2 doses in a year after 6 months. Is very long acting. It's a subcutaneous injection. It should be given by the healthcare professionals, and it reduces LDL cholesterol by about 50 to 60% compared to the statin, which is maximum is 25 to 30%. It's a, what are adverse events? It's a caution liver disease, limited data in LDL disease, minimal interaction. Sometimes in the injection site there's reaction, and sometimes also flu-like symptoms there, but they're very rare and not very significant. Symptomatic treatment is quite effective. Then PCSK inhibitors is a monoclonal antibodies, is a Repatha and the Prolent, inhibits PSK protein in liver and bloodstream. So it prevents degradation, enhancing LDL cholesterol clearance, leading to the lower LDL. This is also subcutaneous injection. It is given every 2 to 4 weeks. It can be given by self-administration and also reduces LDL by 50 to 60%. So generally safe. Again, liver enzyme monitoring is good. Rare injection site reaction. So cost is the very limiting factor. Incretin is about 90,000 per dose, but it is twice in a month. Available as Liquipio by Novartis is available in India, and people are using with a very good effect. And PC investors, Ivilucumab, rupees 18,000 per dose, but is given about 2 to 3 weeks, every 2 weeks. So is available as Repatha by Dr. Reddy's lab, and Prolent is not available in India. So what are the key takeaways? Among newer drugs, inclisiran, PCSK inhibitors are very promising and available in our country. Both are well tolerated, but injection reactions are common more in inclisiran. It has inclisiran has fewer doses twice a year, thus reducing the risk of side effects. Cost is, of course, prohibitive at the moment. And PCK inhibitors have more data on long-term safety, but require more frequent dosing, like every 2 weeks. Liver and kidney function to be monitored frequently in both. And pregnant and breastfeeding should avoid both drugs due to lack of safety data. So thank you.
Thank you.
I have finished in time.
Thank you, Dr. Jha. I'll request Dr. Miglani to please sum up. Mike, please.
Like the same topic, Dr. Rajiv Gupta will also be speaking. So let's we have a discussion. And maybe like he will.
Nay cover me, sir.
Why Dr. Rajiv?
So
He may be adding some more thing also. No.
I'd like to introduce Dr. Rajiv Gupta. He's a senior consultant attached to Fortis Hospital, Shalimar Bagh, and he's a very intelligent fellow. My personal opinion, and he will be speaking on newer drugs in lipid management.
Since this topic, thank you, chairpersons, and thank you, Dr. Ananthi Pati in particular, for giving me this opportunity. Topic is being repeated 3 times, but let me make it a little more interesting. And I'll answer a few questions that have been asked. First thing is, what's new in the lipid lowering? As you know, next slide, please. Let's say we have this. What's just a minute. Okay. You know, LDL cholesterol is the male culprit, and all our resources are now focused on reducing LDL cholesterol to targets. We have decided targets. Now, why LDL cholesterol? Because early trials of VOSCOPS, FSCOPS, TEXT, SCOT, LLA trial, lipid lowering arm trial, clearly underscored the value of LDL cholesterol as a primary target for reduction of atherosclerotic cardiovascular disease and stroke. Now, another meta-analysis demonstrated very clearly that 1 millimole fall in LDL cholesterol reduces the MACE or risk of cardiovascular disease and death by 21%. So focus remains on LDL cholesterol in particular. But we have other factors also, which we'll discuss shortly. Now, what is the targets? Target people for high-risk patients is less than 70 of LDL cholesterol. Now, these are non-fasting samples, mind you. Nowadays, we are not asking for fasting lipid profile. Non-fasting lipid profile, nowadays we should order. Now, secondly, in very high-risk patients, I just have been told by Dr. Chabra earlier, I will not dwell until you want me to dwell on it. Very high-risk patients should be less than 55. For others, as Madam asked, in general population. In general population, normally we don't treat LDL cholesterol of less than 160. So if the LDL cholesterol is more than 160, we think of treating those cases, right? In patients who have less than 160, but they have high ASCVD score. Now we have apps available. You can calculate the risk profile of this patient by calculating ASCVD score. Less than 10, 10 to 20, or more than 20. Now that takes into account various factors: age, non-HDL cholesterol, total cholesterol, weight of patient, ethnic profile of patients. A lot of things are taken into that, and you can easily score the patient sitting in front of you and calculate the score if it is more than 20. Risk is high if it is more than 20. So you should treat this patient. Any patient who has more than 20 score must be treated with moderate to high dose statins, high intensity statins. Now, what is high intensity statin? Any statin dose which can reduce LDL by more than 50%. We call it high dose. Generally, it is 20 to 40 milligram of rosuvastatin and 40 to 80 milligram of torvastatin. Now, just nowadays, the guidelines and other things are suggesting probably lower is better. LDL lower than even up to 45 is better. You know, infant and children, they normally have LDL of 40, 45, and nothing happens. The growth is normal. Their steroid production is normal. Their brain function is normal. So nowadays, we are more reasonable. We bring down LDL to up to 45 in patients who have very high risk. In patients who are very high risk, we keep on lowering the product. Second part, the patients who has a LDL of 100. Target is at least 50% reduction. That is, his LDL has to come down to 50, right? 50 may not be, it is little less than the target, what we are discussing, but you have to keep it at least 50% of what the existing level were. So that is important, and this is what our paradigm nowadays. Now, as has been told, statins are the main bulwark, the main benchmark treatment for management of dyslipidemia. Now, however, you will agree with me that many patients do not reach these targets. The targets are quite stringent. You give high dose statin, still the patient is LDL is more than say 100, 120, 160. So what do you do in the patient who do not reach targets? Now we have drugs which can make immense contribution to lowering of LDL cholesterol. Patients who have statin intolerance, Madam asked, yes, patients do not tolerate statin. Myalgias are common. Whenever you have myalgia, get their CPK done. If it is more than 4 times normal, you may stop statin or reduce the dose and see what happens. If there is less than fourfold rise in CPK-MB, kindly find out other causes for myalgias, because many of the myalgia are not related to statin. So people give vitamin D, people give some muscle tonics, other things in these cases, or you look for a disease, which is primary myopathic disease in these patients. So most of the time, statin intolerance is uncommon. However, it does matter. It happens. No, have you talked about, Dr. Ananja talked about ezetimibe, bempedoic acid, etc. So I don't have to dwell on it. These are easily available. Patients who don't reach target on statin, you just add one of these 2 drugs. Or patients who are not tolerant, you can give these drugs. What is interesting is PCSK9s, which were well known by Dr. Ananja, and other drug is microRNA, that is inclisiran. So we'll talk a bit about these drugs. PCSK9 inhibitors are wonderful drugs. Whatever we could not achieve with statin can easily be achieved with PCSK9 inhibitor. Very potent lipid-lowering agents, right? And they are given in the form of injections, 2 weekly injections or monthly injections, and they can bring down LDL cholesterol by 50 to 59%. It's very important. You have evolocumab, you have alirocumab. They are both available clinically. They can be used, and other drugs are bococizumab. They are all there. Now, they are clearly very potent drugs, and those people who continue to have LDL more than 70 on statin, maximum tolerated dose of statin, you have to start them. Unfortunately, we don't start them. Very few people in India are on PCSK9 inhibitors. Major hurdle is cost, but there is also clinicians' inertia. We do not know that there is something beyond statin, which can be given, very powerful agents which can be given to bring down the cholesterol. Any person who is having recurrent problems, patient has undergone angioplasty, stenting, still has pain, patient has undergone bypass, still has pain, angina pain, what do? You bring down the LDL further. And that is you can do by using PCSK9. Very effective agent. Mechanism of action has been told. I will not dwell into that. The second thing is, not only that people who have established cardiovascular disease, PCSK9 has been shown to be very valuable in patients with primary prevention. People who have not developed any heart disease but have risk factors. There's a trial, Vesalius CV trial, evolocumab brought down the incidence of events by 20%. Right? So even in primary prevention, people who have not had any heart disease, you can still use PCSK9 inhibitors. Now, even injections could be an issue with people. Now we have orally available, oral Elicitide, which is also oral PCSK9 inhibitor, which is now available, not in India, but elsewhere. Now, inclisiran, microRNA. Now, those 2 trials were conducted, Orion 10, Orion 11. In these trials, these were given in the form of injection at 0 months, 3 months, and 6 months. See the impressive fall in the LDL right in the beginning. At 3 months, you see a dramatic fall, and that fall continues as up to something like 40 weeks. So, and this is a very impressive reduction in LDL cholesterol over and above statins. These patients are all receiving statins. So beyond statin, we have PCSK9, and I exhort you to use it. Kindly read about them, kindly see how they can be used, and at least you introduce the patient to this particular form of treatment, PCSK9. Very effective and must be used more often. Now, other thing is combinations. Now we are having fixed dose combinations of OB, citrafib, which is a CTEP inhibitor, and ezetimibe. And that there was that was seen in tandem trial. You see, in patients who have high risk for ASCVD, or patients who are heterozygous hypercholesteremia or statin intolerance having LDL more than 70. Now, at day 84, this combination reduced LDL by 48%. So instead of single drug, we can use combination of drugs, and new drugs are available in combination form. A fixed dose combination is available, else we are not in India. Now, besides LDL, there is a still very significant residual risk. You will agree with me, despite highest doses of LDL, highest doses of statins and other things, patients continue to have events. What is that, and how we should look at it? This is another atherosclerotic molecule present in your blood. This is LP little a. Now, LP little a is more atherogenic, mind you. It is far more atherogenic than LDL. It is more pro-inflammatory, pro-thrombotic, and pro-atherosclerotic. This is basically your LDL molecule on which ApoA has been attached, which makes it more atherosclerotic and more pro-thrombotic. Now, this particular molecule is genetically determined, and it is heritable and independently associated, has an independent causal risk factor for ASCVD. Now, mind you, as the child grows to 6 months, LP little a starts coming in the blood. And by the age of 5 years, it reaches its peak and remains there. It remains there as throughout the life. So this molecule must be tested at least once in a lifetime for every individuals, including doctors, because risk goes up if it is more than 50, independently if it goes up beyond 50. Now, 1 in 5% worldwide and 25% Indians have a level which is risky, that is more than 50. Now, this is clearly linked to MI, stroke, heart failure, aortic stenosis, cardiovascular, and total mortality. And why we were not earlier talking? Because earlier we had hardly anything to reduce LP little a. Now we have drugs. And you know, PCSK9 inhibitor and Cicliran, they reduce level by 25%. And another very potent drug is pilacarsen, which is an antisense oligonucleotide, which reduce LP little a by 80%. So this is likely to take care of some of the residual risk persisting after statins. Another treatment which is very interesting and is hold promise for the future is this treatment, CRISPR gene editing therapy. Now this target NHPLAT3, and this recently a trial was published in which 15 patients, human patients, were given single injection of this drug, and they found what happened was it reduced LDL by 50% and triglyceride by equal amount, 50%, within 2 weeks. And just single injections, even after 60 days post injection, the levels were maintained, lower levels were maintained. So this is a treatment for future. Just one time treatment, and you don't need any statin or PCSK9. So such kind of treatments are going to come, and we are watching with keen interest about these treatments. Thank you very much. I'll appreciate if there are any questions.
So you have specified about many new drugs which we'll have to read about. But one basic question, if the TG is high, which is the first drug, ezetimibe or fenofibrate to add? Because there's a lot of confusion. Many people start fenofibrate, many people start ezetimibe.
First, let us understand, should we treat hypertriglyceridemia? That's the first question. I say routinely no. Triglyceride, elevation in triglyceride is a surrogate marker. It's not an actual causative factor for causation of atherosclerotic cardiovascular disease. When I treat triglycerides, if they are more than 500, in fact, sometimes 1,000, they increase the risk of pancreatitis. Now, pancreatitis risk goes up. I am worried more for pancreatitis than for atherosclerotic cardiovascular disease. That means if there are more than 500, I would like to treat with using fibrates omega-3 fatty acids, right? These are the good one, and lipaglyn, that is,
Saroglitazole.
yes, saraglitazole. They effectively bring it down. Fibrates can also be used, but unfortunately, with fibrates, you use fibrate, they bring down TG by 25%, no doubt. But they increase the creatinine level. There is dose-dependent increase in creatinine. Must tell the patient because creatinine goes up in many of these patients because it prevents the excretion of creatinine from the kidney. So tell the patient that creatinine might go up and don't worry about it. You stop the drug, creatinine comes down. But fibrates are good. But unfortunately, cardiovascular benefits are difficult to demonstrate with fibrates. That is why they are there, but still we are not using them that much.
So
Other thing was ethyl, what was that? The drug which was used in one trial, low, reduced trial. The ethyl something. That is there in Europe, not in India. I don't know if it's available. Dr. Tripathi can tell. Ethyl something, what was that? It is available in India. Okay, ecosyl something that is available, but I have no experience. This is also supposed to reduce. The trial itself has now under clouds. The trial, there are problems with the trial because placebo use mineral oil, which is not a good oil. It is bad for heart. So there could be artificial benefit that could come from that trial. So okay. So that is, these are the drugs you can use. But I tell you, kindly be careful. Triglyceride should only be lowered if they're high. Though they say keep it around 150. Why they say that? High triglycerides are indirect evidence of increased oxidative stress. Increased oxidative stress. So look at the stress. What are causing that oxidative stress? These are the markers, but not the causative factors.
So what about PCSK9 inhibitors? So have they been used frequently over here in India, and they are only injectables and very costly?
Cardiologists have started using it. I have an interaction with cardiologists. I have no personal experience, but cardiologists have started using it. We prompt other people to at least offer this treatment, that such treatments are available. That's not, Inclisiran somehow is more favorite
That
of
is a monthly
cardiologists.
injection,
They
I
take
think.
it for themselves and they are giving it to patients also.
But they're monthly injection, I think.
They are
Every 2
injections.
weeks.
They are injections. PCSK9 2 weekly. One therapy is about a month, and this one is 0, 3, and 6 months. Inclisiran 0, 3, and 6 months.
And sir, what about oral PCSK9 inhibitor LEC? Is it available in the market?
I just went through the literature. I found this interesting because
So
only,
it's
I
not
am not sure. I am not sure.
Oh, it's
I have no idea.
LEC died.
Dr. Tripathi, is it available?
And what is the cost of it?
Okay. Any other question?
With statins, fenofibrates, and ezetimibe. And if they are not controlled, we are switching over to this inclisiran. And we are switching over to inclisiran in those patients also who are intolerant to this statins.
One point I'd like to mention, one interesting point. Ezetimibe. Now, you give ezetimibe with statin, something very interesting happens. 40 milligram rosuvastatin versus 10 milligram rosuvastatin with 10 milligram ezetimibe have similar effect. So you can bring down the dose of rosuvastatin by simple addition of 10 milligram ezetimibe, and you may reduce the side effect associated with statin by doing this, and the effect is the same. So dose can be reduced by 1/4 to 50%.
I have something to add some comment. Like initially, we have a lot of interest in the statins, and statins were supposed to act not by lowering the LDL level, but they were plaque stabilization and plaque passivation as well. They were supposed to be anti-inflammatory, and they act as an anti-inflammatory as well. So then came this ezetimibe, and since this ezetimibe lacked all these additional benefits, so it went into disfavor. Then came this inclisiran and other things who said that that LDL lowering is the key and other things are useless. So again focus shifted to the ezetimibe and this inclisiran and other things. Still we don't know if with this statins we have long evidences, and we have our experiences. But with these new medicines, what they do, will come to know in coming 5 years, and they will be wiser.
True. I think the audience should carry the message LDL. Focus on LDL, LDL, LDL. That is what we need. Triglyceride, forget for some time. Except I've told you a few conditions where you can use it. Otherwise, focus only on LDL, LDL.
As you rightly said, we are more concerned with the pancreatitis, equally lethal. As pancreatitis is equally lethal as MI.
Okay.
So we should also be concerned with it. And if it goes LDL, this triglyceride goes more beyond 400, it must be treated. Should have been done.
Sir, last question. If we start the patient on ezetimibe combination with statin, what is the criteria to stop ezetimibe and then shift to plain statin? What is
See, the question
criteria?
is achieve the targets. We just go, you have to know the risk of the patients and you have to know which level of LDL you are going to achieve. Secondly, you hardly will get any chance to reduce ezetimibe. Ezetimibe is a very simple drug and not very costly. So I think promote the use of ezetimibe. We have a trial in diabetics where early use of ezetimibe post MI or post event was very beneficial, right? So do not avoid ezetimibe. In fact, use it more and more and more. Wherever you get a chance, kindly add ezetimibe.
Would you like to use different statin in primary prevention or secondary prevention? Atorvastatin versus rosuvastatin? There's no
Trials are with both. See, we have that S4 trial with atorvastatin, which was primary prevention trial, where it was showing a good response, 35% reduction S4 trial, and atorvastatin was used much more, instead of rosuvastatin. But rosuvastatin is more powerful, no doubt. But the incidence of diabetes, becomes more with rosuvastatin. I'd say up to normally say 2 to 3%. It is up to 10%. You can have with the rosuvastatin. However, anti-inflammatory effect of rosuvastatin has been demonstrated in the trial. So there are issues. Some people will prefer rosuvastatin, other will atorvastatin. I think there is hardly any choice. You can use 40 milligram rosuvastatin or 80 milligram of atorvastatin. No, there is no much difference.
So
This is guidelines.
No head-to-head comparison, but the evidences that we have more with, as Sir said, more with the atorvastatin in primary prevention and more with the rosuvastatin in secondary prevention. With rosuvastatin came into light when there was a lot of the trials which came like TIMI-23 and others who showed that anti-inflammatory markers were markedly decreased with the rosuvastatin, and primary angioplasty, primary ACS outcomes become better and better with the suppression of the anti-inflammatory marker. So if we extend this logic, so primary prevention atorvastatin and secondary prevention like rosuvastatin are better.
Because there is data more with atorvastatin in primary.
So you get triglycerides or LDL increase with the hypothyroidism or hyperthyroid or disease
Exactly.
or
See,
liver disease
whenever
also.
you have dyslipidemia, kindly rule out some important secondary causes. One of them is hypothyroidism. Always do their thyroid profile. That's very important. You are absolutely right. You will miss some cases and treatment will not be effective, right? So all patients should have, thyroid profile done whenever you have dyslipidemia.
Thank you, sir. Thank you, sir, for such a lucid talk and interactive session.
Thank you.
We go on to the next session. Next session is by Dr. Praveen Bhatia, who is at present president of Indian Medical Association, DNZ, and he runs his own center, Bhatia Hospital in GT Karnal Road. He's a senior consultant physician, and he'll be speaking on repeated coronary restenosis. What is the role of aggressive lipid lowering? Welcome, Dr. Praveen Bhatia.
Very good evening, friends, and thanks for the kind words, Dr. Amandeep. Now we're going to a very challenging topic after listening to Dr. Jha, Dr. Chabda, and Dr. Rajiv Gupta about the role of LDLs and lipid profiles, everything. Very challenging part by a cardiologist about the restenosis. Repeated coronary restenosis. Is there any role for the aggressive lipid lowering agents? This is a very important question which the cardiologist faces and all the physicians definitely face. The coronary restenosis remains a clinical challenge for all of us. And despite so many advancements in the stent technologies, repeated restenosis increases the morbidity and mortality also. So what basically is restenosis? Renarrowing of the coronary artery after PCI. How much renarrowing? It should be 50% or more than 50% will be taken as restenosis. The reason can be neointimal hyperplasia, and it is to be differentiated from the stent thrombosis. This is different thing, stent thrombosis, which is acute emergency, maybe within 24 hours, or maybe within few weeks or month. In emergency, within 24 hours, if there is stent thrombosis there, patient is immediately to be shifted to cath lab and replacement of stent may be required. What is the epidemiology? What's the incidence of restenosis? With the old generation stents, bare metal stents, it is around about 10 to 30%. And newer stents, drug-eluting stents, 5 to 10%. And moreover, it is more frequent in diabetes, CKD, hypertensive heart disease, more of comorbidities. So why the very important question is why restenosis? There can be some vascular injury because of, I'm sorry to say for the cardiologist, some misplacement of stents can be there, or there can be inflammation, or stent can be at the bifurcation, or there can be smooth muscle cell proliferation. What are the risk factors? Which group of patients are likely to have the restenosis is diabetes mellitus, smoking, chronic kidney disease, or vessel diameter is small, or there is under expansion of the coronary artery. There can be sometimes failure of multiple PCIs, and sometimes the stenosis can be diffuse and aggressive. In this particular patient, we must advise CABG. And one more aspect is therapeutic dilemma. All my colleagues have talked about LDL, LDL, LDL. Dr. Rajiv Gupta, Dr. Jha, Dr. Chabra. So again, since last 1 decade, we are seeing that there had been a lot of focus on the LDL. How much should be the LDL levels, and what is the role of LDL and statins to avoid the restenosis? So what is the role of lipids? Already focused by Dr. Rajiv. LDL promotes atherosclerosis, it triggers inflammation and impairs the endothelial healing. So the conclusion is that LDL must be kept under control. This is a very important question. What is the LDL targets? In general population, as Dr. Rajiv has pointed out, it is to be taken as 160, but every size doesn't fit everyone. This must be taken into consideration. With diabetes, this level can be 70. In very high risk, we should maintain at 55. In extreme risk, it should be less than 40. And few days back, I was attending a conference, and a formula was given at the time of whenever there's first incidence of ACS, that should be taken as a criteria. Supposing there is incidence of ACS at the age of 50 years, the level of LDL must be 50, less than 50. So we learn from each other, everyone learns from each other. So that was the lesson from that particular conference. As far as the statins are concerned, how the statins are going to affect the restenosis, how it's going to help us. They are anti-inflammatory, they improve the endothelial function, and they stabilizes the plaque. This is well-known fact. Evidence has shown that statins reduce the stenosis, they lower the repeat revascularization, and dose-dependent benefits are definitely there. Ideally, atorvastatin 40 to 80 mg per day, rosuvastatin 20 to 40 mg are recommended after post-PCI for a long time. And PCSK9 inhibitors must be given to the all high-risk patient, especially statin intolerant. They definitely help in profound LDL reduction and reduce atheroma volume and potential benefit in the recurrent restenosis already talked about. Various clinical trials have shown the efficacy of the PCSK9 inhibitors. They help in reducing the LDL levels up to the level of around about 50 to 60%. Plaque regression is around about 55%, and less of the new atherosclerosis with the statins. LDL drives the vascular inflammation. Aggressive lowering reduces CRP, means less of inflammation, and it has got a synergistic benefit. Who is going to benefit more with the statins? Diabetics, multivessel disease, multiple stenosis, and the previous history of ISR. That is, ISR to be differentiated from the restenosis. This is basically the inside the stent restenosis, ISR, intra-stent restenosis. So what should the practical strategy? We must start early high intensity statins after PCI and add ezetimibe and escalate to PCSK9 inhibitors if patient is statin intolerant and is high risk. Still, the few questions which are unanswered. What is the optimal LDL target for ICR? ICR is basically intra-stent restenosis. What should be the level of optimal LDL target? What is the duration of therapy? For how much time we have to give it? I think in the high-risk patient, as my opinion goes, as the guidelines suggest, it should be given lifelong. And cost effectiveness is also to be seen, especially for the PCSK9 inhibitors. So with this my talk, what message we have to take? Repeated recurrent restenosis is at extreme risk, and aggressive lipid lowering is logical and must be done, and it is going to improve the long-term outcomes and is going to reduce the morbidity and the mortality. Thank you very much.
Thank you, Dr. Praveen Bhatia. Any questions from the audience? Thank you. Thank you, sir. Now we go on to the next session. Now there's a slight change in the program. Now Dr. Nidhi Rana from the team of Dr. Amit Sharma will present her complex case study. Dr. Nidhi Rana, please. मैं कुछ बोल दूं क्या गाना गाऊं सर पढ़ाई का मूड डिस्टर्ब हो जाएगा सर सारा कुछ और मेरा गाना सुन के सब यहाँ से भाग जाएंगे फिर आपका डिनर सब वेस्ट हो जाएगा So, in the meantime, are there any lucky draws? The management team? Are there any lucky draws? Please bring the bowl. I'll do that in the meantime.
Yes, ma'am, we can definitely, and we have lots of them to give away.
Yeah, sure.
So,
Okay, I'll take out the names quickly. Whoever is here will get the. Yeah, you take it out and give it to me.
Yellow.
Rati Jain, Dr. Deepak Agarwal, Dr. Dr. Brij Bhushan Gupta, Dr. BB Gupta कहाँ है भाई? यहीं पे थे?
Case presentation slides have come.
Dr. Deepak 9818023043. मैं अपना नाम ले लूं? Okay, good idea. Dr. Jaiprakash, Dr. Shivam Chauhan, Dr. Kuldeep Kumar. May I know your name, please? Then whoever is not here will not get. This is lucky draw. Lucky draw, you have to be here. What's your name? Shivam Chauhan. Please. Okay.
I think वो भी आ गई शिवम चौहान
वैभव ये सब नहीं है वैभव और ये फेंकने हैं तो तब तक ये तो निकालो ना स्लाइड अपनी तैयार कर रहे हैं डॉक्टर रविंदर कुमार गुप्ता Okay, so we'll We'll take a break now and go to our academics. So I'd like to present Dr. Nidhi Rana, who is a DM Cardiology Senior Resident. And in place of Dr. Amit Sharma, she'll present complex cases.
So, good evening to all panelists and chairperson. I'm Dr. Nidhi Rana. I'm presenting on behalf of my teacher, Dr. Amit Sharma sir, head of department at Subharti Meerut. So I just want to say that it's an absolute pleasure and privilege to present in front of Dr. Tripathi sir, under whose guidance Dr. Amit Sharma sir has received his training. So I'll start off with the case. So there was a 54-year-old male diabetic smoker presented to emergency ICU, uh, emergency Subharti, with chest pain and dyspnea at rest since 3 to 4 days. So he had similar complaints 2 months back, and he went to outside OPD for the same complaints. Outside he was diagnosed with MI, but he didn't refuse for further intervention and went back home. So now, when he presented to our emergency, he was tachycardic, tachypneic. He required inotropic support, immediately started on NORAD at 4 ml per hour. He had bilateral basal creps, and pulse was at 100 beats. So we did ECG, that shows changes of anterior wall MI. We did echo, that showed LED territory akinesia and severe systolic dysfunction. Then we counseled the patient, plan for coronary angiography.
The video is not working, please. Yeah, start.
Yeah. So we performed coronary angiography. LED showed proximal 100% stenosis. LCX mid 100% stenosis. RCA showed mid 100% stenosis. So patient was diagnosed with triple vessel disease. We counseled him for CABG, but he refused. So we planned for high-risk PCI for the patient. So now considering that RCA, we initially planned for LED, but it was akinetic. So now considering RCA was a dominant vessel in the patient and supplying large myocardial territory. So PCI to RCA, we planned on attempting that, and considering that revascularizing the largest ischemic territory gives maximum hemodynamic and prognostic benefit. And also the patient was not hemodynamically stable at the time. We stabilized him and shifted him for coronary angioplasty. So now RCA was hooked with guiding catheter, lesion was crossed. We did dilatation with balloon initially at 1.5 by 10 mm balloon, and then at 10 atmospheric pressure, and then 2 by 12 mm balloon. In proximal to mid RCA, we deployed stent of size 3.5 by 38 mm, and TIMI 3 flow was achieved. We planned for LED stenting, but the patient's condition worsened, and we had to shift. He required bilateral basal creps were present in all lung fields. He required more inotropic support, so we had to drop the plan, and we planned for stage PCR late after 3 weeks, and we shifted him out. So as per take-home message in this case will be that in multi-vessel lesions, prioritization for revascularization is based on ischemic burden, myocardial relevance, and hemodynamic stability. Culprit vessel is not always the vessel to be opened first. Revascularize the vessel with maximum viable myocardial territory, and stage PCI to be planned after stabilization. Thank you.
Thank you. Thank you. Dr. Nityanand Tripathi, any comments?
In this case,
Sir के पास भेज दो.
It's a great case and challenging. In fact, all the 3 arteries are blocked, and that too in MI situation. Great work done. Really great work done.
Thank you, sir.
I think there should be a backup support. I know backup support in the form of balloon insertion, or in the form of some other LV assist device. These cases are very, very critical cases. Little more issue and you lose the patient on the table. See, so normally I would have wanted that probably LV assist device if the patient can afford, or other things, sub balloon insertion.
So actually,
Those,
we are a
because
tertiary.
EF is 20%.
Yes, sir.
20% EF is triple vessel, all critically blocked vessels. I think he's a high risk
So,
patient.
yeah, this is a tertiary care center. There is not much available
So,
for the further
actually,
intervention.
should I say something? It's only impeller device which has been shown to improve the mortality and morbidity, not the IABP. And in these patients who are stable hemodynamically, and I think this patient has been hemodynamically stable throughout. So we do not require an impeller device, particularly in the patients who are of acute MI. Definitely, I agree with you that there should be backup so that it can be used whenever it is required. And I think you didn't require it throughout it because you never had a hemodynamic compromise in this patient as you presented.
Yes.
So you know better what was there, and whatever you presented, I think the case was best way it was done. It could have been done anywhere. Thank you.
Thank you, sir.
Thank you, Dr. Nidhi Rana.
Thank
you. A big round of applause for Dr. Nidhi Rana, budding new cardiologist in the field.
Thank you, ma'am.
Good. Now we have the change of stream. Now we will be listening to a very interactive and very nice other angles of medical field. So now we have Dr. Manikant Singhal, who is formerly head pulmonary medicine ESI hospital and consultant chest physician and intensivist. Now at present he's an advocate Delhi High Court and is a medical social activist. He'll be speaking on sudden cardiac death legal angle.
Thank you.
Over to you, sir.
Thank you, Dr. Amardeep, for the introduction. Thank you, Dr. Amardeep, for the nice introduction. So today, since morning, this is the last session, and I will not keep you away from your dinner. Since morning, you have been hearing how to save a patient from a sudden cardiac death. Now is the time when you should know how to save yourself. Sudden cardiac death is something which is not always cardiac. You must have seen a lot of videos when a patient is moving around and he is getting collapsed and everybody says, iska to dil gaya. It is not always that. There can be non-cardiac causes of the sudden death. For doctors, sudden cardiac death involves two things. One, the patient and his attendants are not willing to accept that my patient died suddenly without any reason. There has to be some reason which can be explained, and some of the times we do not have the investigation or the clinical settings which we can attribute to that this was the cause of death. So in that case, because you must have heard about a lot of people having the death on table. Why the death on table occurred? Did it occur because of the negligence of the surgeon? Did it occur because of the negligence of the anesthetist? Did it occur because of something having been cut, the aorta having been cut? These are the vague kind of things that people have in perception, and we have to somehow face them. This sudden unexpectation is to be decided by us. So doctors are always skilled to save the patient from the sudden death of all causes. But how should you save yourself from litigation is something which I am going to dwell upon shortly. When the deaths occur, we must exclude pulmonary embolism, intracranial hemorrhage, poisoning, anaphylaxis, ruptured aneurysms. These are things which come as catastrophes. And these catastrophes have to be addressed in a way that can be done. Doctors face the situation of death in two circumstances. One, where you have to attend the death as a medical practitioner. you have been given a person or you have been called to see a person and see that this person is dead or not. And if yes, then you have to certify the cause of death. So should you always do it? There are other circumstances where you are alleged as responsible for the death. So when you have to attend a death in a hospital, it is very simple. There are a lot of people to do the job. There are protocols which we have to follow, and there is a team code blue which comes and attends the patients, and the whole drama is there. So the patients are generally satisfied by the protocols having been followed. But what saves us as a later litigation is whether we have followed the protocols which have been set by the hospital or not. Documentation of all the circumstances which can also formulate what was the cause of death, that is also very important. The role of team is defined. So the consultant has to do his job, the RMO has to do his job, but the consultant has to maintain and guide the RMOs about what is the cause of death. This should be specified. The cause of death certificate issued from hospitals saying cardiorespiratory arrests. These have been given to the various municipal bodies. These may kindly not be given. There might be some broad death patients in the casualty. What do we do with them? We have to create and follow the policy which has been laid down by the hospital. So that healthcare organizations must maintain a broad death register which can be used at a later date to certify what time the patient came and what treatment was given and what treatment was not given and why. So all the circumstances must be recorded so that we can save ourselves at a later date. When you are in a clinic and a person is being brought to you in a dead situation, you have to adopt and maintain a professional attitude. Do not panic. Do not be hyper. Oh, don't isko kahin aur le jao. Mujhe nahi isko karna hai. No, this is something which you cannot do. You must attend to him, see whether that patient is actually alive or dead. If he is alive, if some CPR can be given, you must give it. So the professional attitude to a dead body must be always there. Deal these cases with empathy, politeness. Examine thoroughly to exclude foul play. Determine whether the patient is an MLC or non-MLC. This is your right and duty both. If there is any history of poisoning or suspicion of poisoning or injury, we have to see. There are guidelines issued by the professional bodies and they must be adhered to. The certificate of medical cause of death, it can be given if the patient has been under your treatment and not otherwise. When you are going on a home visit, presume it to be a medical legal case unless proved otherwise. The documentation of history is very important. You have to document your physical findings and don't give any certificate of cause of death unless the patient has been under your treatment for a long time and you know the circumstances of the death. When the negligence is alleged, whether it is by an act of omission or commission or that of your subordinates, it has to be clarified. Stay calm, do not panic, inform your legal counsel, medical defense organizations, insurance, gather all information, gather all documents, and prepare a factual reply. Avoid tampering or creating false documents at the last moment because it may cause problems later on. When are the negligences alleged? When there are non-compliances with the statutory requirement. Suppose you have not done something which is compliant with PCP NDT Act, MTP Act, POXO Act, These are the situations where you must do something. The common causes where the litigation fails, the litigation succeeds against you is when you have gone beyond your competence, where you do not have the required equipment with your hand, there is lack of accurate documentation, and you have disregarded the guidelines set by the organizations or government. So how to save yourself is, there are three things. Knowledge you must have. Knowledge is your power. Diligence is your duty. And show of diligence is mandatory. What is the knowledge? Knowledge of your rights. Duty to know the latest in your medical field. You have to know the limitations. What is the scope of your services? That you must know. And duty to know the law relating to the statutory obligations. Duty to know the professional code of conduct. Has any one of you read the code of conduct 2002? Please go and read it today. Which are the code-laid laws for the medical practice? And ignorance of law is not an excuse for saving you anywhere. Diligence is acting as per the standard guidelines laid down by the textbooks, professional bodies, current practices, and law of the land. The Bolam test, which has been laid down by the Supreme Court, which has been accepted by the Supreme Court in the Jacob Matthew cases, a doctor is not negligent if he acts in accordance with the practice accepted as proper by a responsible body of medical men. The duty of care applies to three stages: before treatment, proper assessment, consent, explanation; during treatment, reasonable skill, due diligence; and after treatment, follow-up, record keeping, and discharge advice. How to show? Documentation, documentation, and documentation. So if you have done something and you have documented everything, you are safe. Do not rely on verbal communication and other things. I will take 3 more minutes. Law on negligence is under 4 headings. You can be prosecuted under a civil law, law of torts, where you can be asked for compensation. There can be a criminal law in which you can be prosecuted for a death under the relevant law of under IPC and now BNS. There can be disciplinary proceedings against you in the medical council, where medical council can give you a suspension, removal from the register, or warning. Hospital administration may terminate you. So the criminal law, recently it has been changed, as you everybody of you must be aware. From 1st of July 2024, the new laws which have been enacted by this government have been put in place. How is it relevant to us doctors? What hasn't changed since the previous IPC is that the criminal liability of doctors in course of profession continues. The procedure for trial remains the same, and procedure of adjudication of complaints by medical boards also remains the same. But what has changed is the term negligence by medical practitioner has been included specifically, which was not earlier there. Death due to negligence by medical practitioners have been covered under section 104, and punishment for 106 has become mandatory. Previously, you could have been given a jail term or a fine, but now jail term is mandatory, fine is additional. Another complexity that has come up is that if the patient dies, you get a punishment of 2 years, but if the patient gets permanent disability, you get 10 years plus of punishment. This is the paradox. So the Supreme Court has given some guidelines. In Jacob Matthew case, Jacob Matthew versus State of Punjab, it defined the standard of care. What should be the standard of care? Which I just told you. Indian Medical Association versus VP Shanta said that the doctors are under Consumer Protection Act. I will give you some headlines of the Jacob Matthew case. So, this is a landmark case which protects doctors. It says that doctors, a mere deviation from the normal professional practice is not necessarily negligence. Mere accident is not evidence of negligence. Suppose you cut a vein or an artery during a surgery, it is not a negligence as long as you are able to deal with it. The usual practice is, so long as it can be found that the procedure which was in fact adopted was one which was accepted in medical science as on date, so that will not be a negligence. There is another judgment of Martin D'Souza versus Muhammad Ishaq. In this case, the Supreme Court laid down that no civil liability will be imposed unless there would be a judgment or a opinion from an expert. Now, who is going to be the expert? The expert is going to be one amongst us. Suppose you have taken a consent and you are happy that I have taken a consent and some mishap has happened. Will that save you? No. The consent will not save you if the consent is not proper. And what is a proper consent is? It must be informed, voluntary and specific and by the patient. Most of the time what we get is a signature is put by any of the attendants. That is something which is not acceptable in the court of law. The consent has to be done by the patient. The nature, purpose of the surgery or the procedure which we are going to do has to be mentioned. The risks of the procedure and the alternatives, if available, they will also be mentioned in the consent. For the minors, guardian's consent is acceptable. In emergency, implied consent. If the person is saying that I'm willing to undergo a particular procedure, that is acceptable. Besides the consent, to save our skin from penalties, we have to show that we have followed the protocols and we have not done anything which is beyond the competence or the qualification of the person. So, the consent does not save you absolutely, but it does save you when it is proper and it is accompanied by evidence and documentation that whatever needed to be done was actually done. Some of us are here who are responsible members of the council or the bodies which are adjudicating the complaints by the patients. I have a special request for them. Those who are giving opinion, they need to be professional. They need to study the facts as objectively as possible. There is no need to show favor to doctors. If somebody is saying that we obliged you by doing this favor to you, that may not be done because that is not acceptable in a court of law. Don't see things from a high pedestal of judge. Since I have been called to give opinion, my opinion is that this person should have been treated like this. If he is not been treated like this is negligence. Please accept this fact that circumstances for everyone are not same. The skills that you have may not be the same with the test is average person. if a common average doctor does that thing that way, please forgive me for exceeding my time. The test of prudence by the as done has to be done as laid down by the Honorable Supreme Court. Realize the practical situation under this case which is under scrutiny. After you have given your report, please see what goes under your name. So key takeaways are: negligence is breach of duty and not mere error. Documentation and consent are your strongest defense. Always follow standard protocols. Legal help should be sought early. After you have filed your reply, if you are seeking a legal help, that may not help you. If you have given something away, that will sustain forever. And that is something which we must take care of. Continuous legal awareness is equivalent to professional safety. Thank you very much. If there are any questions, I would be happy to answer.
Yes, Dr. Bhatia.
Sir, I have got a very practical question. I've got a center. Supposing a patient comes to me, diagnosed cirrhosis of liver, stays with me around 4 days. I advise him go for liver transplantation and refer to higher center. I have got his lama signed with me, but he doesn't goes to higher center. He goes to home and dies after 5 days.
Yeah.
Then his attendants come to me, help me in getting the death certificate. MCD persons are not giving death certificate. They are asking for the cause of death. Because you have treated patient, you have diagnosed, so you help us. So what I'm supposed to do?
So, between the time that you saw him and his death, there has been ample time. You do not know what foul play went on. You do not know. So you cannot give a certificate of death. You can just simply say, because you have supplied a Lama summary to him. This is Lama summary is something which we have to mandatorily give. You can tell him, I have given you this certificate. This Lama summary is the last certificate which I attended to. So that is all I can help you with. In case the MCD accepts this as the cause of death, it is their business, not yours.
There are 3 levels of discharge. One is a normal discharge we do, a doctor do. Second, we write normally, whether it's illegal or not, I don't know.
Discharge on request.
Discharge on request. And third is the LAMA. The problem is that when you write the LAMA, sometimes this insurance companies, they don't pay. They create some fuss about this payment. So what should we do? Because if he's not fit for discharge, personal request is not valid. LAMA is difficult to write because sometimes some cause violence also. 15 there or something there. So what is your solution?
See, as a legal person, I would say that whatever is honest, you have to do it. You cannot manipulate things and do this thing. But what we generally do is, we refer this patient to another hospital. Whether he goes there or not is his business. That is the middle path.
So refer, they don't want refer, then how can you write?
They cannot have the both of the words. They cannot have the money and they cannot have you sued.
It's not
See,
money.
it is your requirement. What are you going to do? If you are sending him away without any discharge summary, that is wrong. And if you want to help him out by getting him payment, see, you have to have some kind of a balance.
लामा में हम देखते हैं कि लोग ट्रीटमेंट भी नहीं लिखते.
See, that is something which we all need to sit together and discuss what needs to be done. A LAMA summary has to be same as that of discharge summary. In case you feel that there is a patient who is hemodynamically unstable,
medical advice should we give?
Medical advice is continue medical advice which is being given here. That is the only thing that you can do.
And what about discharge on request?
That is an invalid.
That is invalid.
That is an invalid. Yes.
came to casualty with a stab injury and patient was referred to higher center. Who give the opinion of grievous or simple or
That
it
is
is that is the CMO or the treating doctor?
the treating doctor.
The treating doctor.
The treating doctor. The medical MLC is always finalized by the treating doctor.
Any more questions?
In this case, doctor.
So thank you, sir. Thank you
Thank
for
you.
such a lucid talk.
Thank you very much.
Now for the remaining lucky draws. And then we'll request Dr. Tripathi to have the closing words. First of all, the lucky draws. I have a few in my hand. Which I took them out like.
Yes, but if I could also please interest our chairpersons and our panelists for the felicitation, please, while we indulge ourselves into the lucky draw in the interest of time, right?
Dr. Amit Singhal. Dr. Rupesh Sharma. Dr. Rupesh Sharma is here. Dr. Deepti Sinha. Dr. Deepti Sinha. Dr. JB Dang. इनका हो चुका है. Dr. Anand Prakash Agarwal. आप निकाल दो. Dr. R. Gopal. Dr. Anurag Garg. Dr. M.K. Singhal. Dr. M.K. Singhal. Acha, he's there. Dr. Alok. Dr. Alok. Dr. Alok Aka. Dr. Harshit Goyal.
Dr. Mansi.
Dr. Ravinder Gupta.
Dr. Rupesh. Dr. Rupesh.
Dr. Pramod. Dr. Akshay Gupta. Dr. Akshay Gupta. He's here?
Yes.
Dr. Vikas, please do the honors.
Dr. Akshay. Goyal. Dr. Goyal, आइए. Dr. Vineet Mittal. आइए सर. नहीं, but he has to be here.
Dr. R.S. Bajaj. Dr. R.S. Bajaj. Dr. Singhal, please take your...
Mr. Ashok Gupta.
Dr. Akash Tayal. Dr. Kamal Garg. Satish Gupta.
आइए सर, आइए, please. Dr. Vandana Gupta. Dr. Vandana Gupta is also here. Please, ma'am, आइए.
Dr. Rachna Kashyap. Dr. Rachna Kashyap.
Dr. Brij Bajaj.
Dr. Rakesh K. Gupta. Please come. Dr. Anil Dogra.
Dr. Bhavik.
That's it. Thank you all. Now I'll request Dr. Tripathi. I'll request Dr. Tripathi, please come.
Ladies and gentlemen, with this, as we are almost culminating this evening, I think all of us need to have a big, thunderous applause for Dr. Nityanand Tripathi for organizing this.
A big round of applause for all the team, the whole team.
Dr. Parashar and Dr. Alok, if we can please invite you for a... Acha, ho gaya? Okay, sorry. Okay, done. So, Dr. Tripathi, we'll invite you, sir.
Yeah. Thank you. Every good thing comes to an end, and so is this conference. So throughout the day, we had been deliberating. We had deliberated on long, complex topics, various topics rigorously, and was participated by everyone and all of us. We should congratulate to everyone and all of us. I should start thanking from the audience. Without the audience, any conference cannot be successful. Thank you so much for taking out time on this busy Sunday to be here. Thank you. I thank you from my core of the heart. I thank you all the team VOH who has been here since beginning till the end, managed so nicely, so comfortably, and so organized. Thank you VOH so much. Thank you. Thanks a lot. I am very thankful to all the organizing team, all the people who have helped me throughout, and everyone. I have a long list, and I think I might miss some of the names, so I'm not going to take it. Everyone is my dear to my heart. Thank you so much. Thanks a lot. Without you, it could not have been possible. I thank the organizing committee who has helped me at each and every step to this conference. Thank you, organizing committee. Thanks a lot. Th- thanks for me often. Thank you so much. I am highly thankful to my team who has not only worked as a team but has been there in scientific committee, has helped me to shape out the conference design, conference topics, and deciding what will be better one, what to deliver and what not to deliver. Thank you, scientific team and my team, very much from core of my heart. My uh, the coordinators who has been throughout this journey. Thank you so much. I thank marketing team from of the Fortis Hospital who has been here throughout. I thank Ashish who has been day in and day out for last 2 to 3 months. And in fact, I had never been anywhere most of the times. He was there waiting for me till 9 o'clock in the night and then morning and then continuing in the second morning again. I thank the Fortis management who has allowed us to use the Fortis resources and allowed us to be here, present here, and allowed us to flourish there in the Fortis hospital and to organize this conference and future conferences as well. Thank you, Fortis management. Thank you so much. And I thank this hospital, this hotel and hotel staffs who has been managing this throughout from beginning to end and making us comfortable, our life comfortable. It is very essential that our partners who have supported us financially. I thank whole industry with core of my heart, particularly this Medtronics and the Abbott who has been major partners. And without their support, this could not have been possible. Not a single thing could have been organized. Thank you from core of my heart. I thank other partners as well who has supported this event. So I will lack my duty in not thanking. I thank from core of my heart the directors of CardioSafe Foundation, which has been doing a huge work. Without directors' approval, this could not have been possible to organize. The directors are Dr. N.N. Jha, Dr. Rashi Khare, and Dr. Mr. Jayesh Timri. All the three have permitted me to use this CardioSafe Foundation resources to organize this and similar conferences in the past and these conferences as well. Thank you. I thank everybody and everyone and hope to meet you again in the next year in the next session of this IICT.
I'll request the core team of Dr. Nityanand Tripathi, Dr. Rashi Khare, Dr. Dinesh, Dr. Sudhanshu Parida, Dr. Ankesh. Please, all of you come over. Now, I'll request Dr. Nityanand Tripathi to honor his organizing team. Dr. Sandeep Mahajan. Sandeep Mahajan, okay. It's okay. Ashish Chatrat. Tarun. हाँ हाँ वो Mr. V. Kumar and the second Tarun. Tarun Pawar. Vinita, I think, is not here. She's left. हाँ तरुण सबको मैनेज करता रहता है. I was also there. Personally, I'm saying thank you to all of them. And Tarun used to manage. My father was admitted there, and he used to manage everything, along with Vinita, Sandeep, everybody's Ashish, Tarun. Vinita, where's Vinita? Left? Okay, okay. No issue. Please, Dr. Sudhanshu, Dr. Rashi, Dr. Dinesh. Please. तुमको बुला लो कोई रहना जाए. बुलाते हुए. A big round of applause for great management and great anchoring. Thank you all. Now I will request one photograph of the core team of Dr. Tripathi, Dr. Rashi Khare, Dr. Tripathi, Dr. Sudhanshu Parida, and Dr. Dinesh, please. आप आइए ना, Dr. Rashi, आप आओ आगे. आप आओ राशि.
Dr. Rupesh.
I'll request Dr. Praveen Bhatia, Dr. N.N. Jha, Dr. Abhishek, Dr. M.K. Singhal, please come on the stage. Please, Dr. Ruchi Singhal, Rupesh, Dr. Tiwari, please come, please. आ जाओ सारे. बार-बार बुलाना नहीं पड़े सबको. अभिषेक आओ ना. कितनी बार बुलाऊंगी? नहीं, आप आओ. मैं नीचे आऊं बुलाने. हाँ, अब इतने में नखरे नहीं मारो. प्लीज. डर तिवारी आइए सर. Thank you everyone. And I would like to thank Dr. Tripathi for giving us the honor of calling and being involved in this conference. Okay, one photograph of CardioSafe Director.